Hello dear friends, now we are going to talk regarding the most developed part of our central nervous system, that is the brain. Here is the one diagrammatic presentation for all of you. You can see the superolateral surface of the brain where you can observe the important sulci and the gyri. Yes, this is our lateral sulcus. Here is central sulcus. This is our parieto-occipital sulcus, which is joined to the our pre-occipital notch. So these are dividing the brain into the, yes, in front of the our central sulcus, frontal lobe. Behind this central sulcus, here is parietal lobe. You can observe the temporal lobe below the lateral sulcus, and behind this imaginary plane you can easily catch the occipital lobe. Now further, there are the different sulci and gyri which are dividing this our superolateral surface of the brain in different areas. Now try to catch. One anatomist, physiologist, physician, broadman did one experiment. He stimulated the different part of the brain and observe the activity in animals and the human body and given them number, and he elaborated their function. Yes, that person was our broadman. So these are controlling the different functions of the brain. That's why these are known as the broadman area. Yes, these are controlling the function of the brain. That's why these are known as functional areas of the brain. Okay, so try to understand one by one. Catch here. Sir, this is our central sulcus. In front of the central sulcus, here is the pre-central sulcus. So in between them, you can observe the pre-central gyrus. Correct, sir. Now, catch here. He studied about this our pre-central gyrus in sequence of 4. So given the number 4 area, yes, he observed that it is controlling the motor function of the body. So this is our motor area. Physiology, the function of this anatomical structure is our, yes, this is the our motor area. It is controlling the function of the body. So now come to the medicine. If there is a damage in this motor area, there is a loss of motor activity. This is known as, yes, paralysis. You will see it will control the opposite half of the body. That's why there is a contralateral paralysis. So here is the anatomy, this is the physiology, and here you can observe the medicine. So beautiful integration. So very high chances of the questions directly or indirectly coming from this topic. Now remaining frontal lobe is divided into the our three different gyrus by the two sulci. Yes, this is the our superior frontal sulcus, inferior frontal sulcus, which is dividing the frontal lobe into the superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus. Correct, sir. Now catch this point. Just behind this our middle frontal gyrus, here is the area number 8, ophthalmology integration. Sir, this is our area number 8. I am making in such kind of the way so that you can see. Yes, here is the presentation of the eye. Remember, this is our frontal eye field area. Yes, it is our frontal eye field area. What is the function? It is responsible for the conjugated saccadic movement of the eyeball. Both eyes follows the same direction. Yes, you will do test in your medicine. It is responsible for the conjugated saccadic movement. So if there is lesion, there is a loss of this horizontal gauge. Do you remember the vertical gauge, upward gauge? It was controlled by superior colliculus, interstitial nucleus of the Cajal, but this horizontal gauge is controlled by the frontal eye field area, area number 8, ophthalmology integration. Now see this our remaining part of the superior frontal gyri. It is our area number 9, 10, 11, 12. Yes, it is known as prefrontal lobe. So there was the one medicine question. If there is insertion of any rod, any traumatic agent in this prefrontal lobe, then what will happen? Remember the medicine integration, the patient will present with the prefrontal lobe syndrome. So this is our medicine integration. But what is the function of this prefrontal lobe, remember it is one of the very important area of our brain. This is controlling the personality, judgment, behavior, skills of the person. So if there is a damage in this area, there is no death, but the person will forget, he will lose his all kind of the personality. The prefrontal lobe syndrome, the classical presentation, Anand Bhai, yes, Munna Bhai MBBS, you can remember this character. Yes, he is all the vegetative function, he will go under the vegetative state. All the visceral activity, yes, they are working, but he cannot respond to the different kind of the stimuli. Now look here, the very very important area in this our inferior frontal gyrus, you can see again it is divided by the our anterior rami, ascending rami, and this is our posterior rami of the lateral sulcus. Yes, you can observe there is presentation of the area number 44 and the 45. These are nothing but these are our Broca's area. Yes sir, these are our Broca's area. Also you can say motor speech area number 44, 45. The MCQ in your NEET PG 2018, it had been asked that Broca's area is located where. Answer is inferior frontal gyri. Remember this point, that if there is the damage in this area, then there will be the motor aphasia integrating with our medicine. Now come to this portion, our yes temporal lobe. So this temporal lobe part is divided by the superior temporal sulcus, inferior temporal sulcus, into the superior temporal gyrus, middle temporal gyrus, and inferior temporal gyrus. Now catch this point, here is the functional area studied by the our Broadman just below the central sulcus. This is our area number 41 and the 42. Agree? Yes. You will be able to see that there is one another area around this area number 44, 42. This is our area number 22. So remember our ENT integration, this area number 41 and 42, it is responsible for the hearing. It is our primary auditory area, it is responsible for the hearing. If there is a damage in this primary auditory area, definitely there is our hearing loss. And this is our area number 22, this is secondary auditory area. If there is a damage in this secondary auditory area, in that situation there is loss of analysis, loss of interpretation of the heard sound. This is known as auditory agnosia. So remember this one, ENT integration, you all know the auditory pathway is Ecolima. So integrating with that point, Ecolima. E for eighth cranial nerve, then impulse reaches to the our cochlear nucleus, then olivary nucleus, then there is our lateral lemniscus, then you will see there is the our inferior colliculus, and now impulse is reaching to the medial geniculate body and then auditory area. Yes, this is our auditory area. Impulse is reaching into this area number 41 and then 42, then impulse is reaching into the area number 22, and the person becomes able to analyze, to interpret the heard sound. And one update for all of you, Wernicke's area, lots of confusion is there. Remember the Gannon, the Harrison, all this standard textbook, they are showing the posterior part of this area number 22 is our Wernicke's area. Getting the point? So this is our Wernicke's area. The posterior part of the auditopsychic area, secondary auditory area, is the Wernicke's area, which is also known as sensory speech area. So if there is a damage in this sensory speech area, yes, you will get there is sensory aphasia. So this is again physiology and then medicine integration. So these are the points. Now we are going to look for our yes parietal lobe. So in the parietal lobe, there is a postcentral gyrus. You will see there is our area number 312, which is controlling the sensory activity of the body. So it is our sensory area. If there is the damage, then there is a loss of sensation, means anesthesia to the related part of the body. Now you will see there is the our in parietal lobe, intraparietal sulcus, above it superior parietal lobule, below it inferior parietal lobule. Yes, you can remember this inferior parietal lobule, this is area number 5 and 7. It is controlling the our vibration and stereognosis sensation. So there was the one interesting question in our NIMHANS exam. Yes, which sensation is lost earliest in old age? Answer is our, you can remember easily, sir, that is the vibration sensation. One funny way, at the old age our body is doing vibration tremor. So if you are catching, if you are giving the tunic fork to the patient, he cannot identify the vibration of that tunic fork. Why? Because his own body is vibrating. One funny way, what you have to remember, the earliest sensation which is lost at old age, at the senile age, answer is vibration. And another question from the NIMHANS exam, which is now converted in your INICT, that was our loss of vibration sensation, is also known as pal anesthesia, palanesthesia. Important MCQ, please don't forget it. Now come to here, there is our occipital lobe. So you will see in the occipital lobe there is the one moon shaped sulcus. Yes, this is actually the calcarine sulcus. Around it there is a moon shaped sulcus, that is the lunate sulcus, as the name is suggesting. Now you can observe here, you can see, sir, this is area number 17, which is the primary visual area, which is responsible for the proper vision. We all know the visual pathway from our physiology, from our, yes, ophthalmology part, sir. Retina, optic nerve, optic chiasma, optic tract, lateral geniculate body, then there is optic radiation, and then impulses are coming to the primary visual area, area number 17. And around it, sir, there is the area number 18 and 19, which is our secondary visual area. Yes, visopsychic area also you can say. So if there is a damage in this primary visual area, sir, there is the blindness, sir, there is the anopia. But if there is a damage in this secondary visual area, person can see, but he cannot analyze, he cannot interpret the visualized object with the past memory. This is known as visual agnosia. Okay, beta, getting the point? Yes, here is the our primary auditory area. Sir, here is the primary visual area. Sir, here is the secondary auditory area. Sir, here is the our secondary visual area. Sir, damage to this our primary visual area. Yes, it is resulting in the anopia and secondary visual area, that is the visual agnosia. In the similar way, if there is a damage to the primary auditory area, there is the hearing loss, and if there is a damage to the secondary auditory area, there is the auditory agnosia. So this is the very, very interesting way to learn all the things. Yes, now catch this point. There was the aphasia. One very interesting way. Remember, there are the many areas in the brain which are related to with our speech. Yes, there is a motor speech area, Broca's area. There is a sensory speech area, Wernicke's area. Also, you will see there is an association area, area number 39 in your physiology and the medicine. If there is a damage to that our, yes, association area, then person will forget the name of the object. You know very well this movie, the Avara Pagal Divana, the Johnny Lever and the Paresh Rawal combo. Yes, he was saying a chota chhatri. Yes, he was saying kon chota chhatri, kaju katri, tad patri, something like that. The person is forgetting about the, yes, name of the object. So what I want to tell you, don't forget this speech topic integrated with our anatomy, medicine and the physiology. What are, there are the different types of the aphasia: motor aphasia, sensory aphasia, and nominal aphasia. Also you have to learn about the global aphasia. Okay, so come to the our next part. Yes, we are going to integrate this all the different areas with the medicine with proper correlation to the blood supply of the brain. Why? Because we all know if there is the any kind of the problem in the blood supply of the brain, yes, then there is the our situation, stroke, also you can say transient ischemic attack. So remember, it will lead to the different kind of the manifestation, paralysis and involvement of the broadband area. So we are going to learn regarding this all. See here, sir, there is our aorta. Yes, sir, arch of aorta. It is giving the subclavian artery. Yes, so directly from the arch of aorta, the branch is coming. This is the common carotid artery, which is dividing into the our external carotid artery and internal carotid artery. This internal carotid artery is reaching inside the brain. Agree, sir. Now look here. Here is our another artery, vertebral artery. I told you the vertebral artery is the branch from the subclavian artery. The branches from the subclavian artery, the VITCD. V for vertebral artery we had seen. So this vertebral artery is passing from the C6, C5, C3, C2, C1 vertebra. It is not passing through the C7 vertebral level. Getting the point? Now it is reaching inside the our brain. So this vertebral artery is having the different parts. Can you see this part is running in the neck? It is the first part of the vertebral artery. Sir, it is the cervical part. Then it is passing through the our foramen transversorium of C6 to C1. So this is our cervical part. Then it is going backside. Yes, it is the third part. The question from this third part, it had been asked in your AIMS 2016-17. Then again it had been repeated in the 2021-22 INICET pattern. So don't forget, this is the third part which will lie on the posterior part, on the lamina part of the vertebra. Now this is the third part which is running in the suboccipital triangle below the occipital bone. That's why it is known as suboccipital part. Then it is entering within the brain and it is uniting with the opposite side vertebral artery and making the basilar artery. Getting the point? So this is our part of the vertebral artery which is within the brain. So it is the fourth part of the vertebral artery. Sir, it is our intracranial part. So it is the first part, here is the second part, this is the third part, and here is the fourth part. Now this vertebrobasilar system and the vertebral and the carotid artery, these are making one circular anastomosis in the brain. This is the circle of Willis. Remember, cow was important in our school time. Yes, important essay was asked in the similar way. The cow is very important. Circle of Willis is very important in this time of our INICET, NEET, PG, your next pattern, your FMG exam, whatever. For simple diagrammatic presentation, here we are showing the right vertebral artery and the left vertebral artery. Yes, both are uniting together and making the basilar artery which is running within the basilar sulcus of the pons. And then this basilar artery is dividing into the two posterior cerebral arteries. Yes, again labeling for all of you. Sir, here is our vertebral artery uniting together, making the basilar artery, dividing into the posterior cerebral artery. Agree, sir? Now, this vertebrobasilar system is anastomosing with the internal carotid artery. Correct, sir. This internal carotid artery is giving the branch anterior cerebral artery, which is supplying the front part, yes, which is main artery of the medial surface of the brain. Now this anterior cerebral artery is anastomosing together with one branch. These are our anterior communicating arteries. This internal carotid artery is meeting with the posterior cerebral artery. Yes, the name of this anastomosing artery is posterior communicating artery. Again revising this all the things with the labeling. Sir, this is internal carotid artery, here is anterior cerebral artery, and these are anastomosing branches, anterior communicating artery. Yes, this is posterior communicating artery. So you can see this is one circular anastomosis in the brain at the base of the brain. You can easily see the importance of this circle. Yes, suppose there is a blockage of this posterior communicating artery. In that situation, the blood is coming from here and it is not supplying this part of the brain. In that situation, the blood will flow from the opposite side and it will supply the brain properly. So this is the importance of the circle of Willis. Now we are going to count what are the five components of the circle of Willis. Sir, the anterior component is our anterior communicating artery, anterolateral is anterior cerebral artery, lateral component is internal carotid artery. Yes, posteriorly and lateral component is posterior communicating artery, and posterior most is posterior cerebral artery. MCQ had been asked which is not the component of the circle of Willis. Remember, the middle cerebral artery is running on the lateral side. Yes, middle cerebral artery is not making the component of circle of Willis. Now, in the same question, we are going to see what are the different branches of the internal carotid artery. Remember, there are the five branches of our internal carotid artery in cerebral part. So, what are the five important branches showing with the blue color? Sir, this is akka. anterior cerebral artery. This is Makka, middle cerebral artery. This is posterior communicating artery. Yes, it will give branch to the eyeball, that is ophthalmic artery. Very important for your ophthalmology, and it is supplying the our choroid plexus anterior choroidal artery. Again revising with the proper labeling, sir, internal carotid artery, it is having the 5 different branches. First is Akka, second is ophthalmic artery, third one is middle cerebral artery, and the fourth one is posterior. Yes, this is our anterior choroidal artery, anterior choroidal artery, and here is the our fifth one. This is posterior communicating artery. Getting the point? So these are our different 5 divisions. Here we are going to see the main arteries of the brain and what are the different main areas integrating with the medicine again. See here, this is our superolateral surface of the brain. The main artery of the superolateral surface of the brain is middle cerebral artery. No excuse with this point. Yes, you will see the 2 centimeter wide strip area from the frontal pole up to the parieto-occipital sulcus. This is supplied by anterior cerebral artery. Getting the point? And another important MCQ, that inferior surface of the brain along with the occipital lobe, this is supplied by posterior cerebral artery. Yes sir, this is the posterior cerebral artery part. Now look here, here is the medial surface of the brain. It is very old kind of the question pattern. You can see this is the central sulcus encroaching from the supromedial surface, suprolateral surface to the medial surface. Yes, so the area around this central sulcus, this is paracentral lobule. What is the function of the paracentral lobule? It controls the perineal area. Yes, what are the different structures at the perineal area? We all know area between the two thigh. Here is the presentation of our bladder. Yes, sir. Genital area, correct, sir, as well as anal canal. Getting the point? So try to catch this point. If there is the damage, ischemia, any kind of the trauma to this paracentral lobule area, then this perineal area is affected. So abnormal bladder activity, abnormal genital function, abnormal anal canal activity is seen. This is the very important question which are always asked in the medicine part as well as anatomy. So the patient will present with the abnormal urination, means patient will do urination at the bed. Yes, patient will show the genital abnormal activity. Yes, there will be the loss of erectile function of the penis or clitoris. Also the patient will do defecation in the on the bed. Okay, so this is the abnormality in case of the involvement of the paracentral lobule. What you have to remember, this entire area, the main blood supply of the medial surface of the brain is anterior cerebral artery, akka, you can say. Okay, so recently in INICET exams, many questions had been asked, what is the blood supply of the corpus callosum? Here is the septum pallidum, and this is the fornix. Many times this question had been asked. Remember, sabka malik ek hai. Yes, this CSF, all the structures, paracentral lobule, the medial surface structures, mainly they are supplied by akka, anterior cerebral artery. And you can see this is our posterior cerebral artery area, which is supplying the inferior surface of the brain as well as occipital area. So this is pakka, while this temporal pole is small area on the medial surface is only supplied by the makka, middle cerebral artery. So remember this formula, akka makka pakka, just like the abba dabba jabba, one funny dialogue from the Anil Kapoor movie Judai. Okay, now here is our coronal section. So you are cutting the brain in this way, so you can see the coronal section. This is our medial surface of the brain. I already told you this 2 centimeter wide strip area is supplied by the anterior cerebral artery, while this suprolateral surface is supplied by our, yes, middle cerebral artery, while this inferior surface is supplied by our posterior cerebral artery. So easy. Sir, what is the importance of this all? Yes, you have to learn this physiologic concept, sensory and the motor homunculus representation. You can see in this cartoon the face is very large, lips, tongue, they are very large, hands are very large, as well as foot, they are very large, but remaining part of the body, they are very small. Try to understand this point. Yes, the anatomist, physiologist, physician, they studied about the function of the brain, and they had observed that whatever the part of the body more and more motor activity, yes, like hands, they are having the large presentation at the brain. This is the homunculus representation. Yes, the facial expression, can you see? Yes, lots of expression in seconds, as well as you will see there is the very free, very fast movement of the tongue. चमड़े की जुबान बहुत तेजी से चलती है, so you can easily remember very fast movement of the lips, very fast movement of the tongue, this all the things. So the face presentation is very large, as well as the foot, but remaining part like the arm, forearm, the trunk, thigh, these are having the very small, very less kind of the activity, that's why less presentation. And the same phenomenon with the sensation, more receptors over the face, lips, tongue, hands, foot. So these are present with the large areas over the face. So over the brain, yes, again we are doing the coronal section, and the different parts of the body they represented here. So you can see that tongue is large, face is large, hand is large, but the remaining part they are small. Yes, these are small, but foot is large. This is our homunculus representation. More motor activity, more sensory activity, more area of the presentation. Also you have to remember that if there is our damage to this supralateral surface, can you tell me which is the artery of the supralateral surface? Sir, middle cerebral artery. So if the middle cerebral artery is affected, the patient will show the aphasia, the patient will show the upper limb paralysis. If there is the involvement of the akka, anterior cerebral artery, definitely patient will show with the abnormal perineal activity and paraplegia. Yes, if the occipital pole is getting damaged, in that situation definitely there is the presentation of the visual loss. So this is the way how you can remember, sir, this is our homunculus representation. In medicine you will see the question pattern that one patient is chronic smoker, alcoholic, obese, and this is the blood investigation, cholesterol, HDL, LDL, so on, and he is coming to the OPD with the unconsciousness. He is presenting the aphasia and the upper limb paralysis, but lower limb is normal. This is the CT MRI or angiography, cerebral angiography, and we all are getting fear. I don't know about the cerebral angiography. Remember concept, if your anatomy is strong, you can crack each and every subject, medicine or the radiology. Yes, simple logic you have to apply. The supralateral surface is presenting the face and the upper limb. So if the artery of the supralateral surface, yes, middle cerebral artery is damaged, definitely this symptom will occur. So without the knowledge of the cerebral angiography, you can say sir, middle cerebral artery has gone. In the similar way, if lower limb and the perineum area is involved, same case is there, your answer will be the akka. Hope you are catching this point. Yes, these are the very conceptual. Fine beta, now we are coming for the our next part. Till now we had seen the functional area of the brain, Broadman area, and their blood supply. Yes, that was the gray matter part. Now we are going to see the white matter and the basal nuclei. Catch this point, this funny mnemonic. What are the different white matters in our brain? You can remember with this funny mnemonic, ACP Rathore, the Rowdy Rathore, Chintata Chita Chita, something like that. Okay, so there are the three types of the white matter. A for you can remember, sir, association fiber. C for you can remember, sir, commissural fiber, and P for you can remember the projection fiber. So this is our first task. There are the three types of the white matter. For proper understanding, one diagrammatic presentation. Suppose these are our, yes, right and left cerebral hemisphere. Correct, sir. Now catch this point. Yes, these are our different sulci and gyri within the each cerebral hemisphere. So type of the white matter, yes sir, which is communicating the nearby areas within the same cerebral hemisphere, these are known as association fiber. Correct. While the type of the white matter which is joining the two different cerebral hemisphere but same areas, yes, it is joining the same areas in the brain, so it is making one thick band in between the two cerebral hemisphere. And there are the one another type of the white matter which is projecting from inside to the out or the from outside to the in. So what are the different nomenclature? Again, yes, first type of the white matter which is situated within the same cerebral hemisphere. It is associating the two different areas. So it is association fiber. It is associating. Yes. Next fiber, which is joining the two different cerebral hemisphere, it is acting like the commissure. So this is our commissural fiber. And these fibers which are projecting from inside to the out or from outside to the inside, these are simply the projection fiber. So you can remember this funny mnemonic, sir, ACP. Few important examples we are going to see. First of all, no doubt we have to see the corpus callosum. Remember the frequently asked question. C for corpus callosum, it is our which type of the fiber? Sir, it is a commissural fiber. So you can remember, sir, it is a commissural fiber. How can you remember? C for corpus callosum, C for commissural fiber. No need to mug up. And another MCQ, this is our largest white matter band. You can easily remember, sir, it is largest white matter band. Which is the largest white matter band in our brain? Answer is corpus callosum. What are the different parts of the corpus callosum? So you can see this first part is known as the rostrum, then turn part is known as the genu, then here is our, yes, body or trunk, and this is our thickest part of the corpus callosum, splenium. Again, sir, this is rostrum, turn part is genu, here is trunk, also you can say body, and this is our splenium part. So this is splenium. So these are the different parts of the corpus callosum. Remember, it is on the medial surface. So artery of the medial surface, that is the ACCA, anterior cerebral artery, it will supply the corpus callosum. Now, remember, there is a situation corpus callosum agenesis in medicine. What is the function of the corpus callosum? It coordinates in between the right and left cerebral hemisphere. So, if there is the no corpus callosum, there is the no kind of the disease. Person will survive normally, but what will happen? There is the no proper coordination between right and cerebral hemisphere. Yes, you will see this clinical point in your medicine. I told you the platform. Now, see here, there is the one another important question many times asked, that is the one fornix. Try to understand, this is a very small structure in our brain which is situated just below the corpus callosum, septum pellucidum, and yes, below to it whatever the structure is fornix. When we will do cut section, it will appear in such kind of the manner, figure of 8, you can say. Why? See here, this is our one mass in our brain, sir. This is hippocampus. Remember one important question, this hippocampus is important part of the limbic system which is responsible for the conversion of short term memory into the long term memory. Now remember, Hollywood, Bollywood, Tollywood, they all are coming from our anatomy. How? You know, the our Sanjay Singhania, he got the lesion at the hippocampus, so he was unable to convert the short term memory into the long term memory. Yes, this was our Gajani movie in which he forgotten to the Kalpana. Okay, so this movie was totally dedicated to this hippocampus. This is important question of the physiology. Remember, the short term memory is converted into the long term memory with the help of the hippocampus. Yes, where is the site? Hippocampus. Now there is the one bundle of the white matter which is arising from this our fornix. Yes sir. So this is the posterior column of the fornix. Now this is coming front, but these both parts are united together. So this is our trunk, also you can say body of the fornix. Now it is dividing into the anterior column. Yes sir. And it is ending into the mammillary body. Yes, one very favorite question you can see here, one simple flow chart which had been asked many times in your INICT pattern. Remember, the impulses from the hippocampus, they are carried to the mammillary body, and which structure is responsible? Answer is fornix. So this is very usual kind of the pattern. They will give the mid-sagittal section, coronal section, or CT MRI of the brain. Arrow will be over fornix, and they will ask this indicated structure is, yes, afferent for. Yes, we all know afferent means when the impulses are coming. Yes, remember afferent. Fornix is afferent for what? Remember, the impulses from the hippocampus, they are coming to the fornix, and from the fornix the impulses are coming to the mammillary body. So this fornix is afferent for the mammillary body, And remember, this same fornix will act like the efferent for what? Yes, it will act efferent for the hippocampus. I told you already this way, that SAME. S for sensory, A for afferent, M for motor, and E for efferent. Remember, afferent means ana. So you can say, for the mammillary body, the sensations are coming, the impulses are coming from the fornix. So afferent is fornix for what? Mammillary body. And efferent means jana. Yes, hippocampus, the impulses are going to what? To the fornix. So fornix will efferent for the hippocampus. So remember, look each and option. For is asked or to is asked, so carefully give the answer. Okay, so this is very useful way. Another MCQ which had been asked, this fornix is which type of the fiber? White matter fiber. Yes, your options are, this is association fiber, commissural fiber, or projection fiber. Look here, it is joining the same side of the hippocampus to the same side of the mammillary body. Sir, it is the property of the association fiber. Yes, it is joining the opposite side of the column of the fornix also. Yes, so it is commissural fiber. And just like the tract, just like the projection fiber, it is projecting from one point of the brain to the another point. So this is projection fiber also. So who is real? ACP Rathor. Who is real? Rowdy Rathor. Answer is the fornix. So this is the classical question which had been asked in the INI CET exam. Which structure is our? Yes, remember which structure is classical example of all types of the white fiber. Answer is our fornix. Now come to the next point. Yes, we are going to talk about the projection fiber. Simply you have to remember, sir, projection fiber, these are projecting. So you can say all tract or tracts related structures, they all are projection fiber. So this question pattern has been asked, that lateral spinothalamic tract, yes sir, projection fiber, because it is the tract. Even you will say corticospinal tract, anterior spinothalamic tract, any tract, they all are projection fiber. Yes, from the physiology we know the corticospinal tract, it will make the corona radiata. Yes, this corona radiata will merge and it will make the internal capsule. So this corona radiata, internal capsule, they are also the projection fiber. Each point had been asked in your exams. Okay, now come to the next, basal nuclei. Try to understand what is the basal nuclei. Then we are coming to this funny mnemonic. Yes, suppose this is our cerebral hemisphere. We all know that gray matter is located at the peripheral part. Correct, sir. Here is the gray matter. And at the base of the brain, sir, there is brainstem. Yes, sir. Midbrain, pons, and there is our medulla. Correct, sir. So you will see at the peripheral part there is the gray matter. Then inside to it there is the white matter, and also you will observe the gray matter mass which is embedded within the white matter at the base of the brain. Yes. Catch this point. This is located at the base of the brain. That's why you will say, sir, basal, and these are the gray matter collection within the CNS. That's why you will say nuclei. Remember, it is not outside the brain, so you cannot say ganglion. The basal ganglion is the misnomer. Remember, the basal nuclei is the correct term. So what are the different structures which are located at the base of the brain? You can see here one funny mnemonic. Yes, you can remember the ACC, cement. Remember, if any person is getting death, just what you have to do, go and put the 2 spoons of this ACC cement, because remember, is cement mein jaan hai. Just one funny thing so that you can remember this mnemonic. As well as here you can see the stainless steel. So SS is your mnemonic. So what I want to tell you, within this our basal nuclei, you have to learn regarding the amygdala. Okay, yes, you have to learn about the corpus striatum. Correct, sir. You have to learn regarding the claustrum. Yes, we have to know about the our substantia nigra we had seen in our midbrain part, and one more is that is the subthalamic nucleus. Getting the point? Remember, this amygdala is very small almond like structure in our brain. And yes, this is the almond, very small almond like structure in our brain. And this is the same thing over which our, not only the Hollywood, Bollywood, Tollywood, they are depending, but even our TikTok star are also there. So just one funny thing so that you can remember, this is the almond like structure over which this TikTok video, yes, almond like structure, amygdala, this was from the kacha badam. So just a few lines for all of you so that you can remember this amygdala, this basal nuclei. Yes, পায়ের তোড়া হাতের বালা থাকে যোগী সিটি গোল্ডেন চেন দিয়ে যাবেন ততে সোমন সোমন দাদা কাঁচা বাদাম ও বাদাম বাদাম দাদা কাঁচা বাদাম. Just one funny way, which structure is the kacha badam or the almond like structure in our brain? Remember sir, it is the amygdala. Yes, in physiology you will learn this amygdala is responsible for the food and sex activity. So if there is the damage in this our amygdala, there is the hyperphagia and hypersexual activity, which is known as Kluver-Bucy syndrome. This is again your physiology and the medicine integration. Okay, yes, now look here, this is our corpus stratum, which is formed by the two structure. It is corpus means mass, stratum means thin striation. So it is formed by the chordate nucleus and lens separate nucleus, lentiform nucleus. Yes, we all know the chordate nucleus. Sir, chordate nucleus is having the very long tail. So this is the structure of the our chordate nucleus. Correct sir, it is our chordate nucleus. Now you will be able to see at the tail portion of this chordate nucleus, there is location of the our almond like structure. Yes, our amygdala. What are the different parts of this chordate nucleus? Sir, it is having the head. Yes sir, here is the head, this is body, and this is our tail. This is our almond like structure, amygdala. Now one more thing you can remember, the thalamus. Yes sir, the gray matter mass, oval mass, is located within the concavity of this our chordate nucleus. So this oval gray matter mass is nothing, it is our thalamus. Okay, so this is the structural presentation of the chordate nucleus. And in the similar way, the lentiform nucleus. Sir, this lentiform nucleus is lens shaped. Yes sir, it is lens shaped, which is having the lateral part and the medial part. Yes, this lateral part is known as putamen. Yes sir, it is our putamen. This is the question, which is the lateral structure? Sir, putamen is the lateral structure and the globus pallidus is the medial structure. These are making the lens shaped structure. Yes, in case of the Wilson's disease, again medicine integration, conceptual brainstorming integration with the medicine. Remember, there is the hepatolenticular degeneration, again one beautiful integration for all of you. Yes, this is our Wilson's disease you will learn, in which you will get there is our mutation of the chromosome number 13, ATP 7b gene is involved. This is the Wilson disease, in which you will see the abnormal excessive accumulation of the copper around the limbus, which is representing in the Kesher-Fleischer ring. Yes, it is getting accumulation in the liver, causing the liver involvement. And there is the high urine copper excretion, low ceruloplasmin, high free copper level. Yes, you will see there is the involvement of the lentiform nucleus, which is the part of the corpus stratum. And whenever is the corpus stratum is involved, yes, substantia nigra, nigrostratal fiber is involved. And in case of the nigrostratal pathway involvement, there is the Parkinsonism. Yes, that's why in medicine you will see, in case of the our Wilson's disease, there is a Parkinsonism feature. One classical finding, there is the wing beating tremor. So the patient is presenting with the wing beating tremor, you will learn in medicine. Also, there is the face of the panda is visible. Face of the panda is visible in our CT MRI of the brain. Okay, so these are the different points. What I want to tell you, just integrate with this knowledge, sir. There is our lens shaped nucleus, which is involved in the our, yes, Wilson's disease. Sir, there is the Wilson's disease. Remember, Parkinson, Wilson, Jacobson, Morrison, Simpson, this all son will create problem. Daughter never creates problem. Remember, the biggest problem of our life, that is the Harrison, Davidson, Parson, Hutchinson. Okay, so this is the one funny way. Yes, substantia nigra we had seen. If there is a damage of the substantia nigra, which is the part of the basal nuclei, there is our Parkinson disease. Already we had discussed, and one very frequently asked question in our NEET PG exam, subthalamic nucleus. Yes, if there is a damage in the subthalamic nucleus, there is presentation of the hemibalismus. So this is the very favorite question from the NEET PG 2021 as well as 22 pattern. Very important. There's a projectile. Yes, throwing movement of half of the body, that is the hemibalismus. Yes, balismus, ballistic missile, projectile throwing movement of half of the body. He will appear like he is doing the bowling. He will show the movement from the foot also. So this is hemibalismus. Don't forget it. Now look here. Yes, this is the our cadaveric image practice. Such kind of the images will be there, and most frequently asked question this one. Yes, so try to catch. Sir, first try to understand this is which type of the section. Sir, it is showing the gray matter, then white matter. And here you can see the bulb-like structure. Definitely it is medulla, over the medulla. So this is our pons, and above the pons, sir, this is our midbrain. So this is the brain stem. So just use the common sense. It is possible only in case of the coronal section. Agree, beta? Fine. Now you can see the two different cerebral hemisphere, they are joined together with the help of the white matter band. So definitely this is the corpus callosum. Yes, C. I told you whatever the structure just below the C, that is the S. Yes, it is septum pallidum, which is separating the two lateral ventricles. Correct, sir. And just below to it, can you see the figure of 8 like appearance? Sir, this is the our, yes, you can remember the F, that is our fornix. Most frequently asked question in your INICET and your NEET PG exams. Now, just below to it, you can see one narrow cavity. This narrow cavity is nothing. It is our third ventricle. Yes, here you can see the lateral ventricle. Remember, this third ventricle is the narrow cavity in between the two thalamus. So this gray matter mass are clear cut showing the diencephalon part. Yes, sir, these are thalamus. For the radiology, remember this thalamus, yes, this third ventricle, it is the midline structure of the brain. If it is shifting on the one side, means there is a brain tumor, brain abscess, brain swelling on the opposite side. So this anatomical structure will be very helpful for the radiologist also to decide the midline of the brain. Now you will see the more structure lateral to it. Yes, one time you had been asked about the midbrain, one structure which is negro in appearance. Definitely it is substantia nigra. If there is a damage in this structure, there is resting tremor. That is nothing, that is our Parkinson disease. Also you can see this part of the brain, it is hidden. Remember, this is the our hidden lobe of the brain, which is known as insula. Yes, it is also considered as the fifth lobe of the brain, and which structure is considered as sixth lobe of brain. Remember, it is our limbic system, which is also considered as a primitive brain. Okay, now we are integrating the same thing with the another cadaveric image. Can you see this image for your practice? Sir, the outermost structure is the gray matter. Then you can observe inside the gray matter the white matter, and now you can easily observe this white matter band which is joining the right and left cerebral hemisphere. Definitely it is our corpus callosum. So thin septa just below the corpus callosum, definitely it is the septum pallidum. So this small mass figure of 8 like appearance is there. So this is our fornix. Yes, now you can easily catch the structure which is making the floor of the our, yes, corpus callosum part. You can say, sir, this is the cavity within the each cerebral hemisphere. This is lateral ventricle, and the floor of the lateral ventricle, yes, it is formed by the our caudate nucleus head. Now you can see the narrow slit like structure. Sir, this is our third ventricle, and on each side of the third ventricle you can see the our gray matter mass. Sir, this is our thalamus. Now observe carefully. Here is our location of boomerang shaped structure. It is nothing, it is V-shaped structure. The concavity is outside, it is inside capsule of the brain. Sir, it is internal capsule which is having the anterior limb. The turn part is known as the genu. Yes, the posterior part is known as the posterior limb. Now lateral to it, can you see the lens shaped structure? Sir, this lens shaped structure is nothing, it is a lentiform nucleus. The medial density dense part is our globus pallidus and the lateral part is putamen. So this question had been asked, which is the lateral part of the our, yes, basal nuclei. Your answer is the putamen. Now outside it you can see the different structure. You can remember the sequence, sir. E, then C, and then I. So just like the Medical Council of India, you can remember the funny way, the ECI. Yes, sir. This is our external. Yes, this is the Engineering Council of India, ECI, you can say. So E for external capsule, C for claustrum, and I for insula, you can remember. Getting the point? Now catch this all the different more points. This insula is hidden lobe of the brain, we had already discussed. Sometimes in textbook in different question pattern you will see extreme capsule also. This extreme capsule is actually located in between the insula and the claustrum. So this is not too much important, but sometimes you will see, that's why I'm just talking. So try to identify this structure in cadaveric image. In our detailed classes, in our detailed videos, we had seen more things, but this is the rapid revision. So this concise part you have to revise just before the exam. Yes, if this all the things are clear, strong, then you can easily crack this CT MRI of the brain. Yes, sir. This is our outermost part. So you can say this is our scalp. Then you will see there is our skull bone. Then you can see the gray matter. You will see, yes, this is the gray matter part. Here is our white matter part. You can see easily there is the our lateral ventricle, which is showing the less dense area, and here is the part of the septum pellucidum, and this is the portion where there will be the fornix. Yes, this is our third ventricle part, and on each side of the third ventricle, easily you can say this will be our thalamus part. Can you see the caudate nucleus head is making the floor of the our lateral ventricle, and this portion will present the internal capsule area. Now you can catch easily this lens shaped part is our lentiform nucleus. The different two densities are visible here. Yes, sir. This is our medial density, which is our, yes, globus pallidus, and this lateral one is the putamen. And here is our insula. Medial to it you can say there is a claustrum, and you will see there will be the our external capsule. So ECI will be our sequence. In FMG exam 2022 there was a question at this site, which sinus is present. We had seen in our dural venous sinuses, this is the part where straight sinus is present. So go for the your radiology. Yes, straight sinus is presenting at this part. So you can compare easily this all the CT MRI of the brain. It will be very very easy if your anatomy is strong. All subject will be strong if your anatomy is good. Now remember this Wilson's disease or integrated pattern will be asked in your exam pattern. Yes, I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 1,000 times, 10,000 times, more times. Yes, practice gives perfection. So best practice gives best perfection. Remember this all the lines. Thank you. God bless you all. Now in this rapid revision session, we are going to look the thorax part. Yes, as we know, our trunk is divided by the thoracoabdominal diaphragm into the thoracic cavity and abdominal cavity. Yes, we are going to talk regarding the thoracic cavity. It is having entry boundary by the sternum on the back side from the T1 to T12 vertebra, and on each side, yes, you will see there are the 12 pairs of the rib. You can see beautifully in this image. Correct, sir. So you can observe the manubrium, body of the sternum, and the xiphoid process anteriorly. On the back side, the thoracic vertebra, and on each side there are the presence of the pairs of the rib, 12 pairs of the rib. Correct, sir. Now catch this point. The thoracic wall, the unit of this thoracic wall, you can say the intercostal space, the gap between the two ribs, known as the intercostal space. We are doing dissection. We are cutting the space between the two ribs and enlarging it. Yes, sir. So when we are enlarging, you can see easily the upper rib, and here is the lower rib. Correct, sir. So the space in between the two ribs, it is known as intercostal space. Correct. Now total there are the 12 pairs of the rib. Sometimes extra rib is present above the first rib, known as cervical rib. Sometimes there is the extra rib present below the 12th rib known as the gorilla rib. Yes, 13th pair rib is known as the gorilla rib. And now we are going to see the content of the intercostal space. You can see in the intercostal space, there is the presence of the intercostal muscles, and then you will see intercostal vein, intercostal artery, and intercostal nerve. Yes, the easy way to remember this sequence is the VAN. What are the different intercostal muscles? You can easily catch the outside muscle which is running downward, forward, medially, hands in the pocket direction. This is our external intercostal muscle. Then the next muscle which is making 90-degree to this extra intercostal muscle, this is our internal intercostal muscle. Then innermost layer is our transversus thoracis, which is again divided into the three group. Yes, front is our sternocostalis, back side is our subcostalis, but middle to third part is covered by the our innermost intercostal muscle. Just one way to remember. What is important fact which you must remember, that in this our intercostal space there is a presence of the neurovascular bundle. Yes sir, intercostal space there is a presence of the intercostal muscle, vein, artery, and the nerve. Agree sir? These muscles are external intercostal muscle, internal intercostal muscle, and transversus thoracis. Now see here, there is presence of the VAN in our costal groove. Correct sir, costal groove there is a presence of the VAN. This is fixed relation which is present from above to below of the costal groove. So remember this important relation, because whenever we are performing thoracocentesis and we are inserting the needle at this lower border of the rib, or you can say we are inserting the needle at the upper part of the intercostal space, then we are causing damage to these our intercostal vessels neurovascular bundle. So always do the thoracocentesis along the upper border of any rib, or you can say lower border of the intercostal space. This question had been asked also in FMG exam, that which intercostal space is not following this VAN relation. That is our first intercostal space, because first intercostal space, the first rib is not vertical, it is situated horizontally in this way, so this relation is disturbed. Now we are going to move for the our next important topic for this rapid revision session. We are looking for our respiratory system. So you can see this is our trachea at the point of the carina. This trachea is dividing into the our right and left bronchus. Remember, the right bronchus is short and wider. छोटा है लेकिन मोटा है. That's why the foreign body is very commonly going to the our right side of the lung. Okay sir. Now on the right side there are three lobes of the lung, so it is dividing into the three primary bronchus. Getting the point? Yes. So trachea is dividing into the main stem bronchus, that is also known as the primary bronchus. Now there are the three lobes, that's why these are lobar bronchus, also known as the secondary bronchiole, and then these are supplying to the bronchopulmonary segment. So these structures which are supplying the tertiary, which are supplying the our bronchopulmonary segment, they are known as tertiary bronchiole. This is the question, which structure, which part of the respiratory tree is supplying the our bronchopulmonary segment? Answer is tertiary bronchiole. Now it is dividing into the our terminal bronchiole, respiratory bronchiole, then it is making the alveolar duct, then it is opening into the our alveolar sac, and it is supplying each alveolar part. So from the respiratory bronchiole up to the alveoli, yes, this entire part is known as the respiratory unit, your physiology part, where the exchange of the gases occur. Okay, now look here, this is one important fact. There was the one question, where is the site of the bifurcation of the trachea? We all know the answer is the T4 T5 junction. Yes, but you will see many books they are saying the lower border of the T4, but recent edition of the Gray's Anatomy they are clear cut writing. There was the study by the Mirza Lili et al in 2012, and he is saying that the level at which the trachea bifurcate appears to move inferiorly on an average by a mean of 3 mm per decade. Every 10 year the tracheal bifurcation is moving down 3 mm. So now you can see the study tracheal bifurcation in 153 bodies. Yes, it is upper half of the T6, approximately 46%. Also, you can say approximately 50%. So, according to the recent update from the anatomy, from the Gray's Anatomy, the best answer is upper half of the T6. If it is not given, then you can mark the T4, T5 junction. If it is not given, then you can mark the T4. But remember, clinically, bronchoscopically, yes, in living person, this bifurcation is T45 junction. So correlate with your clinical and according to the option, give the best answer. Now look here, these are our lungs. So you can easily catch the cadaveric image. Sir, this is our right side lung. How can you identify? Sir, there is our horizontal fissure. Correct, sir. And here is our oblique fissure. Correct, sir. So it is divided into the upper lobe, middle lobe, and basal lobe or the lower lobe. So three lobes in the right lung, while the left lung, you can see there is presence of the cardiac notch to accommodate the heart. Yes, sir. Here is the presence of the cardiac notch, this one is showing, and the free mobile part of this left lung, this is known as lingula. Here you will get only and only one fissure, that will be our oblique fissure. So again this lung is divided into the 10 bronchopulmonary segment. So we are going to show what are the different bronchopulmonary segment in the our right lung. Yes, suppose this is our right lung, we are looking from the lateral side. Yes, you all are aware there is our one horizontal fissure and one another is oblique fissure. Again, for the bronchopulmonary segment, you have to draw one Y and another vertical line parallel to the stem of the Y. And here you have to draw one horizontal line and the two vertical line. So what are the bronchopulmonary segment in the our upper lobe? Yes, you can see there is presence of first apical, second anterior, and third is posterior bronchopulmonary segment in our upper lobe. So there are the three bronchopulmonary segment in upper lobe. Now in this middle lobe you can see only and only two bronchopulmonary segments are visible. Correct, sir. Only there are the presence of the two bronchopulmonary segment. One is medial and another is lateral. So there are the two bronchopulmonary segments in the middle lobe. And here you can observe, yes, this is our basal lobe which is presenting with the, yes, you can observe there is presence of our apical basal, anterior basal, this is anterior basal, lateral basal, and the posterior basal, and one more medial basal which is not seen from this lateral view. So you can see there are total presence of the 5 bronchopulmonary segments. So you can observe properly. Here is the 3 plus 2 plus 5. So total 10 bronchopulmonary segments in our right lung. So this is your MCQ. Okay. Now see here, there is presence of our 10 bronchopulmonary segment on the left side. Yes, this is our left lung which is presenting the cardiac notch. Sir, suppose this is our left lung, again supralateral, again lateral view of the left lung. Yes, sir. Here is only presence of the oblique fissure. So here is only and only upper lobe. Yellow color is presenting the upper lobe, and there is another one lower lobe, also you can say the basal lobe. Correct, sir. So these are our two lobes in the left lung presenting with the, yes, cardiac notch and the lingula. Yes, for the better understanding we are drawing one horizontal line, but it is not the fissure. Now bronchopulmonary segment, again draw Y and one another vertical line parallel to the stem of the Y, and the same presentation just like the on the right lung. So in the left lung you will see there is our, yes, this is apical basal, yes, apical, here is anterior, and this is posterior. This is the portion lingula. So this is superior lingular, and here is inferior lingular segment, bronchopoint segment. So 5 bronchopoint segment in upper lobe of the left lung, while the basal lobe it is presenting with the apical basal, anterior basal, yes, this is lateral basal, here is posterior basal, and the medial basal cannot seen from the our lateral view. So again 10 bronchopulmonary segment in left lung. But the Gray's anatomy, it is also saying sometimes the our posterior basal and the medial basal both are getting fused. Yes, sometimes the medial basal is absent to accommodate the heart. So you can see, yes, sometimes 9, even sometimes 8 bronchopoint segment in the left lung. So this is one update from the Gray's anatomy. You must remember, sir, 10 by 10 bronchopoint segment is the best answer. But if it is not given, then 10 by 9 is the best answer, and if it is not given, then you can opt the 10 by 8 also. These bronchopulmonary segments are very well defined anatomical sectors, physiological sectors, and surgical sectors of the lung, which are aerated by the tertiary bronchiole. Remember this point. What is the clinical importance? With the knowledge of this bronchopulmonary segment, if there is a cancer only in this segment, just cut this part. Yes, this is the clinical part of the knowledge of the bronchopulmonary segment. This is pulmonary resection. No need to cut entire lung or any lobe. Only you have to remove this bronchopulmonary segment. Also, for the postural drainage, the knowledge of the bronchopulmonary segment is important. Remember, the lung cancer is one of the most common cancer in the world. That's why this bronchopulmonary segment knowledge is important. Also, the lung infection. Yes, for that you have to do postural drainage. That postural drainage is very easy if you are having the proper knowledge of this bronchopulmonary segment. Now few more MCQs, that which bronchopulmonary segment is most commonly infected. Remember this posterior basal lobe is the most common site for the infection, for the foreign body enlargement in our both the lungs. And if person is supine in position, remember this posterior basal segment is most common infection site in erect posture, but in supine posture this segment is most common site for the infection. So these are the points which you must remember. Now we are moving for the next part. Remember the great quote by the Stephen Hawking, sir: however difficult life may seem, there is always something you can do and succeed at. So remember these positive lines. Now we are moving for the next. Thorax is very sweet topic for our rapid revision. Why? Remember the 80% topics of the thorax, they will be come by your heart topic. Why? Again, because the top 3 most common cause of the death in the world, among which the coronary heart disease is the topmost. That's why. And another important topic which you have to learn from thorax, definitely it is the lung. So we are going to talk regarding our heart and the coronary circulation. Try to understand. Yes, in our detailed videos I told you this basic things. Again telling you, heart, just one simple presentation from our school time imagination. Yes, heart is having the 4 chambers: right atria, left atria, right ventricle, left ventricle. But heart is not straight, it is tilted in such kind of the way that 1/3 is on the right side and 2/3 is on the left side. So just to tilt it, so the heart is having such kind of the appearance. Yes sir, just one simple diagrammatic presentation so that you can remember. Yes sir, again right atria, you can remember the left atria, right ventricle and left ventricle. We all are aware that superior vena cava is opening within the right atria, inferior vena cava is opening within the right atria. So the MCQs had been asked that right border of the heart is only and only formed by the right atria. But in cardiac shadow, in your x-ray, in your radiology also, you will count the superior vena cava and the inferior vena cava. Another MCQ, that apex of the heart is only and only formed by the left ventricle. And one more question, that base of heart is formed by mainly the left atria, two-third part, and the right atria is contributing only the one-third part. So the main answer is left atria. Okay, so the base is also our posterior surface, which is important for the your ECG purpose. Now we can observe, yes sir, the heart. Now we will show the heart in this way. Sir, heart is having the superior border, right border, inferior border, and the left border. So this is the one diagrammatic presentation of the heart we will show for the coronary circulation in such kind of the way. You can observe the coronary circulation. Yes, the heart is having the two main arteries. One is our right coronary artery and another is left coronary artery. So these arteries are arising from the our beginning portion of the aorta, that is the root of the ascending aorta. We all know in our root of the ascending aorta there is a semilunar valve, aortic valve. Yes, there are the three cusp, anterior cusp, yes, left posterior cusp, and the right posterior cusp. So there is the formation of the gap in between these margins of the cusp, and here is our, yes, the wall of the aorta. So you can see there is the cavity, a small cavity. Yes, it is our sinus. So this is our anterior side, anterior aortic sinus. It is left posterior aortic sinus, and you can see the right posterior aortic sinus. Yes, this right coronary artery is arising from the anterior aortic sinus, MCQ, while the left coronary artery is arising from the left posterior aortic sinus. Getting the point? Yes, here you can see the presentation. This is the closed situation of the aortic valve. This is the open situation. These gaps are the our aortic sinus. Remember, the right coronary artery is arising from the anterior aortic sinus, while the left coronary artery is arising from the left posterior aortic sinus. So now we are starting the diagrammatic presentation of this all the arterial supply of heart. So listen carefully, it will be very important for your medicine. Yes, suppose this is superior border, here is the right border, this is inferior border, and here is our left border of the heart. To show the four chambers of the heart, we are just showing these linear presentation. Yes sir, here is our right atria, this is our left atria, here is right ventricle, this is left ventricle. We all are aware that superior vena cava is opening into the right atria, inferior vena cava is opening into the right atria. Yes, the aorta is having the ascending aorta, yes, then arch of aorta, then descending aorta. This ascending aorta part is coming from the left ventricle, but over the pericardium it is appearing at portion of the right atria. Sir, this is our ascending aorta, then here is the arch of aorta, and the descending aorta is coming from the backside. Yes sir, we all are aware there is presence of anterior wall, left posterior, right posterior. So there is a formation of the sinuses. Now catch this point, that our right coronary artery is taking origin from the anterior aortic sinus. Then it is running in between the right atria and the right ventricle on the anterior surface of the heart. Then it is winding the right border of the heart and inferior border of the heart, and it is reaching at the backside. Yes, sir. Dotted line is presenting the posterior course, and here it is terminating by dividing into the two branches. Getting the point? Yes, at the margin it is giving one big artery. So what are the large branches of our, yes, you can say the right coronary artery? Sir, this is our marginal artery. So you will say, sir, this is our marginal artery. Here is our transverse artery, and this is our posterior interventricular artery. Yes, this is the marginal artery, here is a transverse artery, and posterior interventricular artery, which is also known as the piva. Remember, this piva is responsible for the decision of the cardiac dominance. Yes, if this posterior interventricular artery is the branch from the right coronary artery, then it is known as the right cardiac dominance. 90% of the individual, we all are with the right cardiac dominance, but sometimes this posterior interventricular artery is the branch from the left coronary artery, so it is known as the left cardiac dominance. Yes, only the 10% people they are presenting with the left cardiac dominance. Getting the point? So these are the three major branches you can remember with this mnemonic, the MTP. Sir, the medical termination of the pregnancy. These are the large branches of our right coronary artery. There are the different small branches like the atrial branches, like the ventricular branches. There is a right conus branch also which will anastomose with the left conus artery. Remember, this right conus branch, when it directly arises from the ascending aorta, then it is known as, yes, third coronary artery. And one another important question, that one of the atrial branches from the right coronary artery, it is enlarging and it is supplying our, yes, the SA node, which is located at the upper border of the crista terminalis. Yes sir, this is our SA node. So this artery is simply the SA nodal artery. Yes sir, it is our SA nodal branch. Remember, the 65% cases it is branch from the right coronary artery, but 35% cases it is branch from the left coronary artery. MCQ. Now after this all, we are going to look the branches from the left coronary artery. Again, simple diagrammatic presentation. Suppose this is the superior border of the heart, this is right border of the heart, here is inferior border of the heart, and you can observe this is left border of the heart. For the presentation of the four chambers, we are just drawing the imaginary lines over the surface of the heart, so you can easily catch the different four chambers of the heart. We all are aware that superior vena cava is opening into the right atria, inferior vena cava it is opening into the right atria. Yes, there is presence of the our ascending aorta taking origin from the left ventricle, but at the surface it is appearing over the right atria. So you can see there is ascending aorta, yes, arch of aorta, then descending aorta is coming down. Fine. Now you can observe better that here is the anterior aortic valve, then left posterior aortic valve, then right posterior aortic valve. Yes, these are making the sinuses cavity along the margin of the valve. Agree, sir. Now catch this point. There is the presence of left coronary artery which is taking origin from the left posterior aortic sinus. First MCQ. Then immediately it is dividing into two. Yes, one is running along the anterior interventricular groove, then it is ending on the backside by anastomosing with the piva. Yes, this is the artery. It is running anteriorly, so you will say anterior in between the two ventricles. That's why interventricular artery. IVA. Yes, remember this artery is most important. Why? Because 40 to 50% of the MI they occur due to the left, due to this entry interventricular artery. This artery is the branch of the left coronary artery, so you will say left. Yes, it is descending anteriorly, that's why left anterior descending artery. Yes, this artery is the LADA, which you will study again and again in your medicine. This is the LADA artery. Remember, it is getting blocked in approximately 50% cases of the MI, and MI is more commonly seen in the males, so males are getting death. That's why females are becoming widow. So this is the one very interesting and the funny question, which artery is known as the widow's artery? Also you can say which artery is known as widow maker artery? Our answer is again LADA. Okay, now look here, this another branch is running to the left side and it is winding backside, and it is ending by anastomosing to the transverse artery. Sir, it is our left circumflex artery. Another artery is running just like the digone. Yes, so it is running just like the digone at the surface of the heart. Yes, it is most commonly branched from the IVA, but variations are seen. Sometimes it is the branch from the left circumflex artery also. Sir, it is our, yes, diagonal branch. Getting the point? There are the many small branches like the atrial branches, like the ventricular branches. Yes, there is a left conus artery, so on. but three major branches you have to remember: the diagonal branch, the entry interventricular artery, and the our LADA. So these are the different branches of the left coronary artery. One more additional point you can learn: this left conus artery is anastomosing with this right conus artery around the pulmonary trunk, around the neck of the pulmonary trunk. So it is making one necklace like structure which is known as necklace of Wilson. Here is the cadaveric image practice. You can see the pericardium covering over the heart. You can observe the four chambers: right atria, right ventricle. The left atria is hidden here. Yes, this is the left atria part, and this is our left ventricle. You can see this is our apex of the heart, which is supplied by the anterior interventricular artery. Yes, you can observe this is ascending aorta, which is turning backside arch of aorta, and this is our pulmonary trunk part. Now look here, this is right coronary artery, which is winding on the backside, and at the margin it is giving the marginal artery. Yes, it is our marginal branch. While you can see the left coronary artery is coming from the our, yes, left posterior aortic sinus. Immediately it is dividing into the anterior interventricular artery, also you can say LADA, and it is going backside, that is a left circumflex artery. So you can easily catch this point after that diagrammatic presentation. Now what is the benefit of this topic? Yes, one more thing we have to learn: the venous drainage of the heart. You can observe this is the posterior surface of the heart, where you can see the largest vein of the heart. Sir, this is coronary sinus. So remember, it is the largest vein of the heart, which is located on the backside in between the left atria and the left ventricle. It is having the 3 centimeter length. Here is the one diagrammatic presentation for the venous drainage of the heart. Sometime it is asked. I told you the largest vein of the heart, that is the coronary sinus, located at the backside in between the left atria and the left ventricle. Yes, it is draining the all the veins of the heart except two. One is our enterocardiac veins. These are directly opening into the right atria. Also there is the veni cordis minimi, which are considered as the smallest vein of the heart. Both are MCQs. Now see the major veins of the heart which are draining into the coronary sinus, that is our great cardiac vein. It is running along with the our entry interventricular artery. It is winding backside and opening into the coronary sinus on the backside. Yes, another is after this great cardiac vein, you can see the middle cardiac vein. It is running along with this our posterior interventricular artery and opening into the coronary sinus. You can see there is the our right marginal vein. Yes, a small cardiac vein. It is draining. It is now known as the small cardiac vein, and it is running with the marginal artery, and again it is opening into the coronary sinus. So you can remember the major veins of the heart, sir: coronary sinus. All the veins are draining here except two. Yes, anterior cardiac vein and veni cordis minimi, and three main veins which are draining into the coronary sinus. They are great cardiac vein, middle cardiac vein, and small cardiac veins. So simple. Now why this topic is important? Because many topics are integrated with the cardiothoracic surgery medicine. Yes, you have to learn regarding the angina. It's all the three types: stable, unstable, and the Prinzmetal. MI you have to learn. Yes, ST segment elevated MI and non-ST segment elevated MI. In pathology, you have to see the myocardial infarction changes also. You have to learn ECG in your physiology as well as in your medicine. Yes, you have to learn about the angiography, for which our diagrammatic presentation of coronary circulation will be helpful. And you must know about the angioplasty, coronary artery bypass grafting, and best artery for the coronary artery bypass grafting. Yes, you will see in your medicine such kind of the coronary circulation. Exactly, it is running in the similar kind of the course which we had drawn. So learn in the medicine. Yes, you must learn the anti-anginal drugs. Sure, short questions are going to ask from the angina and the MI. It's pharma part or the medicine part. Now yes, angioplasty you must learn. Yes, we are doing the catheter, we are introducing the catheter within the blocked area, and we are ballooning it. So this is our angioplasty, and no excuse with this coronary artery bypass grafting. This question had been asked in your NEET PG 2021 and the 22. Remember the coronary artery bypass grafting. Earlier we were taking the great saphenous vein. This great cephalous vein was actually asked, yes, it is closely related with our saphenous nerve, which is the longest cutaneous nerve of the body. So whenever you are doing the phlebotomy, you are cutting the great saphenous vein, then saphenous nerve is also getting cut down. But now remember that the best choice for the coronary artery bypass grafting is our internal mammillary artery. Do you remember the subclavian artery and its branches, sir? VITCD. I told you the I for internal mammillary artery, which is actually supplying the breast. So heart is on the left side. So left internal mammillary artery is the best artery because its diameter, its musculature, its structure, all the things, it is very similar to the our coronary arteries. So you will just do the bypass. You will do just the bypass pathway formation, and you are implanting it after the blocked portion. So this is our bypass grafting. So these all are very very important points. Again, remember, this thorax is very short and sweet for the rapid revision view. Okay, so at the last of this session, सुना है आज समुंदर को बड़ा गुमान आया है, उधर ही ले चलो कश्ती को जहां तूफान आया है. Now we are going to see the GIT portion in this our rapid revision session. Remember, the surgical anatomy part you will cover in your surgery, and the many things relevant to the surgery you will observe there. But what are the points which are asked in recent pattern in our anatomy we are going to discuss here. Yes, remember this GIT is starting from the cricopharyngeal junction. You can see the upper dilated part of our esophagus, sir. It is known as pharynx, which is ending at the cricopharyngeal junction. Also you can say pharyngoesophageal junction. MCQ, it is the narrowest part of the GIT which is located at the C6 vertebral level. We had seen already in our head neck portion. Now in front of this esophagus, you can observe here is the esophagus. There is the location of the trachea on the front side, and this trachea is dividing into the right bronchus and the left bronchus at site of the carina. Okay, yes, so the left bronchus is crossing the our esophagus and producing one narrowing. Just above the our left bronchus there is the our arch of aorta which is producing the narrowing, and then you can see the diaphragm. Yes, the esophagus is crossing the diaphragm and opening into the our stomach. Here is a gastroesophageal junction. So in all over, if you will observe what are the important points, there are the different structures which are producing the narrowing over the esophagus. It is very important topic. What you have to remember, there is the first narrowing. Correct, sir. The first narrowing is produced by our cricopharyngeal junction. Next constriction is produced by arch of aorta. Next constriction is produced by left bronchus, and last one is by diaphragm. Okay, whenever you are inserting the Ray's tube, nasogastric tube, at that situation you have to be careful at the sides of the constriction produced by the other structure overlapping to the esophagus. Now you all know the cricopharyngeal junction is located at C6 level. So C for cricopharyngeal junction, just turn it. So it is C6 vertebral level. MCQ. Arch of aorta, sir, this is the way how we are writing A. So just erase one stick of the A and add here. So this is the 4. This is T4 vertebral level. Now left bronchus, this is the B. So just turn this B in this way. So this is turning into the 6. Yes, it is T6 vertebral level. The left bronchus is producing the narrowing in the esophagus at the T6 level, and the diaphragm, just remember this one, 4 plus 6 is equal to 10. So this diaphragm is producing the narrowing at the T10 level. Now you have to measure this all the distance in your Rice tube. How, which is the landmark? Remember, the upper incisor is the landmark. This is the another MCQ. Yes, you have to measure this constriction from the upper incisor teeth. Yes, so what are the different distance? Simply you have to remember the table of the 3. 3 2 are 6, 3 3 are 9, 3 4 are 12, 3 5 are 15. Yes, these are inches. Just remember these two structures are very close together. So instead of the 12, we are doing 11 inches. So these are the distance from the upper incisor teeth. Now look for this into the centimeter. So just multiply by 2.5 because 1 inch is equal to 2.5 centimeter. So it is turning into the 15 centimeter. This is approximately 22.5 centimeter. Yes, it is showing the 27.5 centimeter and this is 37.5 centimeter. Okay, so remember what is the length of the our esophagus? Yes sir, this is 37.5. Approximately you can do the 40 centimeter. So length of the esophagus, you can just deduct this 40 centimeter and the 15 centimeter. So you will say 40 minus 15 is equal to 25 centimeter. So one funny trick, what are the different structures having the 25 centimeter length? One is the esophagus, and there are the more and more things we are going to learn with the tricks and the magics. Yes, so here is the your funny mnemonic, that is the dudes. So remember the structures having the 25 centimeter length. Answer is duodenum. U for ureter, D for sir descending colon, E for remember it is our esophagus, and S for sir it is our stomach. So these all are the structures having the 25 centimeter length. Very most important MCQ. Now we are also looking for the arterial supply. Yes, the venous drainage as well as the lymphatic drainage of the esophagus for your clinical, for your surgery purpose. Suppose this is the esophagus and here is the stomach. Agree sir, it is piercing the diaphragm. Correct sir. So we can divide into three parts sir: upper one third, middle one third, lower one third. Also you can say the cervical part, mediastinal part, also you can say thoracic part, and intra-abdominal part, abdominal part also you can say. Okay, now look here, this upper one third, it is very close to the our inferior thyroid artery. So artery is the inferior thyroid artery, and the upper one third part, it is drained by the inferior thyroid vein. Correct sir. And it is close to the our neck part, that's why cervical lymph node is the lymphatic drainage. So here we are showing the artery, here is presentation of the vein, and here is the lymph node. Okay, now the thoracic part, mediastinal part, you can say here which artery is present sir? Aorta itself is present. So you can say esophageal branches of thoracic aorta. Agree, sir. Which vein is present in our mediastinum? Remember, there is our azygous venous system. So azygous vein is draining, and which lymph node? It is the mediastinal region. That's why mediastinal lymph node. Yes, stomach. Yes, our esophagus cancer. It spreads by the lymphatic route. That's why you must know the lymph nodes also for your surgery purpose. While this our lower part, abdominal part, you can say this is close to the left gastric artery. So left gastric artery will give the esophageal branches. So it is our arterial supply, and venous drainage same left gastric veins, and our lymph node, it is very close to the left gastric lymph node. So these are our different MCQs which had been asked in your surgery. Okay, one funny way to remember this all important structure, yes, we are applying oil at our ball. So ball, or you can say hair oil. Okay, so remember the different structures. B for sir brachiocephalic vein, in which the inferior thyroid vein is draining. So few books will mention the brachiocephalic vein, few books will mention the inferior thyroid vein. Yes, A for you can remember the azygous vein, and L for you can remember the left gastric vein. So these are our different veins. Okay, one by one you can remember first, second, and third for the different three parts. And you can remember the OIL. O for yes, esophageal branches of abdominal of thoracic aorta, better to say, yes, of aorta. I for you can remember inferior thyroid artery, L for left gastric artery, the esophageal branches. So you can remember the mnemonic for the arterial and the venous drainage, that is our yes hair oil. Also you can remember the oil applying over the ball. Now look here, we are going to look for the our stomach portion anatomy. So you can see the muscular bag of the food reservoir. This is our stomach. Yes, sir. Here is the esophagus, which is opening within the stomach, which is presenting with the two curvature, laser curvature, and here is the greater curvature. You will see the two angles, sir, esophageal, and this is the fundic part of the stomach. So here is one angle is formed. This angle is our, yes, angle of his. Remember, it prevents the gastroesophageal reflux disease. So it is important in your clinical part. Now look here, this is our terminal part, yes, pyloric part, where it is making one more angle with the duodenum. It is incisura angularis, also you can say angular notch. So there are the two notch, two curvature. Yes, you can divide the stomach into the two parts. This upper part is cardiac part close to the heart, also you can say esophageal part, while this lower part is close to the our pyloric region. So this is the pyloric part. Getting the point? Each part again you can divide into the two. The upper part is showing the dome shaped turn, so this is our fundic part. Yes sir, it is our fundic part, and this is our very large part of the stomach. This is body of the stomach. Now this pyloric part is divided into the large cavity, that is pyloric antrum, and this small narrow tunnel like portion is known as pyloric canal. So stomach is having the two part, you can say the cardiac part and the pyloric part, and each part again divided into the two part. So this is the magic of two. Remember, they are the two surfaces, antero superior surface and postero inferior surface. Two curvature, two angles, two surfaces, yes, two parts. Each part is again divided into the two parts. Yes, along the laser curvature there is the fold of the peritoneum known as laser omentum, and along the greater curvature the big fold of the peritoneum is known as greater omentum. This greater omentum is also known as the policeman of the abdomen. Now after this all the magic of stomach, we are going to see the arterial supply of GIT. Sir, GIT is divided into the three parts. You can say foregut, midgut, and hindgut. No excuse. The foregut is supplied by celiac trunk, the midgut is supplied by superior mesenteric artery, and the hindgut is supplied by inferior mesenteric artery. Very important MCQ. Remember, this celiac trunk is located at the T12 L1 vertebral level, superior mesenteric artery at the L1 vertebral level, inferior mesenteric artery at the L3 vertebral level. So this is very old kind of the question pattern. No excuse. First, we are looking what are the different branches of the celiac trunk, because this celiac trunk is going to supply the stomach. Celiac trunk is the artery of the foregut, which is direct branch from the abdominal aorta. Yes, it is located near the stomach above the first part of the duodenum. It is giving the three main arteries. This is the left gastric artery and the zigzag tortuous artery passing from the bed of the stomach and going to the splenic hilum. This is splenic artery, and another artery running towards the liver, that is our common hepatic artery. So these are the three main branches. Again, sir, this is our first left gastric artery, this is second branch splenic artery, and here you can see the third branch common hepatic artery. One by one, it is supplying, left gastric artery, it is supplying the lower end of the esophagus. These are our esophageal branches of the left gastric artery. The arterial supply of the lower end of the esophagus, abdominal part of the esophagus, complete. Yes, arterial supply of the spleen, splenic artery, complete. It is giving the pancreatic branches. One of them is very big, that is the arteria pancreatica magna. So with the help of this diagram, we had completed the arterial supply of the pancreas also. Sir, pancreatic branches, remember, along the greater curvature, this splenic artery is giving the short gastric artery, which is running within the fold of the peritoneum between the stomach and our spleen. Yes, these are our short gastric arteries, which are the content of the gastrosplenic ligament. Another MCQ. Yes, here it is giving one very big branch running towards the epiploic foramen. Sir, it is our, yes, you will say left gastroepiploic artery. Now check this point that common hepatic artery, it is dividing into two, towards the liver proper hepatic artery, another is running towards the stomach and the duodenum gastroduodenal artery. This gastroduodenal artery is dividing again into two. One is anastomosing with the left gastroepiploic artery, and another is supplying the pancreas as well as duodenum from the above. So this is our superior pancreatico-duodenal artery. Again, sir, this is our right gastroepiploic artery, and here is our gastroduodenal artery, which is dividing into the right gastroepiploic, and another is superior pancreatico-duodenal artery. Now check this point. Along the greater curvature, you can see there is anastomosis between the left gastroepiploic and the right gastroepiploic. So you can cut this greater curvature along this vascular bud, you can roll and you can put over the esophagus part. Yes, it is the best choice for the esophageal replacement surgery. MCQ from the surgery, integration with the surgery. Now this gastroduodenal artery, it is supplying the area where there is the most common site of the duodenal ulcer. So this is the surgery MCQ. You can solve with the help of the anatomy, that in case of the duodenal ulcer, you will ligate which artery? Answer is gastroduodenal artery. Now see, this superior pancreatico-duodenal artery, it will anastomose with the inferior pancreatico-duodenal artery. Yes, sir. Inferior pancreatico-duodenal artery, which is the branch from the superior mesenteric artery, while the superior pancreatico-duodenal artery, it is coming from the our celiac trunk. So this is the point where there is a junction between, yes, you can say foregut. Above it there is a foregut, and below to it this is our midgut. So this point, the anastomosis between the our superior pancreatico-duodenal artery and inferior pancreatico-duodenal artery, it is showing the junction between the foregut and our midgut. Very important point for the embryology. Yes, it is the same point where there will be the opening of the common bile duct. Agree, sir? Now look here, this our proper hepatic artery. Yes, it is our proper hepatic artery. It is dividing into two. What are these two structures? Yes, one is supplying the left lobe of the liver, another is supplying the right lobe of the liver. These are the right and left hepatic branches. Yes, sir, this is right hepatic artery, here is the left hepatic artery. So we had completed with the arterial supply of the liver also. Remember, this right hepatic artery is giving the branch to the gallbladder, which is known as cystic artery. Another important surgery conceptual brainstorming integration, that this cystic artery is the classical example of the end artery. So it is not draining into the venule, vein, vena cava. So if any clot is coming, it is blocking this our cystic artery. So there is the ischemia of the gallbladder easily occurs, cholecystitis easily occurs. That's why, yes, it is one of the urgent surgical situation. So this is the one thing, cystic artery is your end artery which leads to the cholecystitis in case of the blockage. So this is the beautiful diagrammatic presentation. It will be useful not only in the surgery but also in the medicine as well as in your radiology. In the similar way, the venous drainage of the stomach and the related organs are same, but they will drain into the which structure? Sir, it is draining into the portal vein. We will see in portal vein detailed part, we will see in our portal vein part. Okay, look here, one important thing. Yes, there is the one vein which is running in front of the our pyloric part of the stomach. This is the pre-pyloric vein of Mayo. It is important surgical landmark because it is the site where there is a location of the duodenal sphincter. MCQ. Remaining portion we will see in the portal vein part. Now look here, the lymphatic drainage, जिसको जो पास पड़ेगा वहां वो ड्रेन करेगा. सो जस्ट लाइक द आर्टरी, यू विल सी देयर इज द लेफ्ट गैस्ट्रिक लिम्फ नोड, right gastric lymph node, yes, pancreatico-splenic lymph node, there is the our right gastroepiploic lymph node and pyloric lymph node. But final lymph node of the stomach, remember, this is the celiac lymph node. Remember, clinical integration, the stomach cancer, gastroadenocarcinoma, gastric carcinoma, you can say, yes, that is showing the lymphatic spread. In case of the stomach carcinoma, there is the enlargement of the left supraclavicular lymph node known as Virchow's lymph node, and this sign is known as Trousier sign. Enlargement of the left axillary lymph node, sir, it is known as the Irish lymph node. Yes, enlargement of the periumbilical lymph node known as Sister Mary Joseph nodule. Yes, spread of the stomach carcinoma, transcelomic spread involving the ovarian cancer. Yes, this is the Krukenberg tumor. So you will see this all the things in your surgery as well as ops gynae part. In between this our beautiful session, few motivating lines for all of you. Remember, रास्ता भी जानते हो, चलना भी जानते हो, तुम आग हो तबीयत से जलना भी जानते हो, खुद को मोम न समझो जो झट से पिघल जाओगे, तुम सूरज हो डूब कर निकलना भी जानते हो. So we are moving for the next part with this beautiful lines for the small intestine and the large intestine. Yes, the small intestine, it is divided into the three part: duodenum, jejunum and ileum. Now this ileum is opening into our large intestine. First part of our small intestine, we are going to look for the duodenum. We all know the duodenum is having the, yes, four parts. First part of the duodenum, D1, then second part of the duodenum, yes, D2, then third part of the duodenum, yes, you will say the D3, and last part of the duodenum, D4. Within this C-shaped concavity of the duodenum, there is a location of the head of the pancreas, and this tail is lying at the hilum of spleen. Getting the point? Yes. Remember, this duodenum is ending above the level of the umbilicus. So you can catch easily the D1 is located at the L1, D2 at the L2 vertebral level, and D3 at the L3. So there was the question, umbilicus is located at which vertebral level? Easily you can catch, it is below the L3 and above the L4. So it is located at the L3 L4 junction. This is the recent question. Remember, entry abdominal wall and umbilicus is important. Yes, you can see this more detailed diagrammatic presentation. Yes, duodenum is having the D1, D2, D3 and D4, four parts. The first part of the duodenum, D1, at the vertebral level L1, D2 at the L2, D3 at the L3. So you all know the foramen of Winslow. Yes sir, the foramen of Winslow, the inferior relation is the D1. So once a question had been asked in your NEET PG exam, yes sir, what is the vertebral level of the foramen of Winslow? Remember, it is above the L1, so definitely answer is the T12. Beautiful answer, beautiful logic, beautiful concept. One more thing I want to tell you, sir, there is the D1, D2, D3 and D4. Sir, D1 is 2 inches, yes, D2 is 3 inches, D3 is 4 inches and D4 is only 1 inch in length. So if you will add all, then you will find, sir, total it is 10 inches in length. Correct sir, it is total 10 inches in length. So if you will multiply by 2.5, then it is 25 centimeter in length. So this is your very very important question. The structures having the 25 centimeter length, I told you the mnemonic DUDES. Again revising: D for duodenum, U for ureter, D for descending colon, E for esophagus and S for stomach. These are the structures having the 25 centimeter length. Now look this diagrammatic presentation integrating with the surgery. You will see there is our first part of the duodenum, second part of the duodenum, third part and the fourth part. Here is the jejunum. So the junction between the duodenum and the jejunum, definitely it is known as the duodenojejunal flexor. Remember, at this part there is the attachment of one ligament. Yes, it is holding the duodenum and the jejunum structures. Yes, it was studied by the trids. So this is known as the suspensory ligament of the trids. It is attached at the duodenojejunal flexor. Why it is important? Because it is very important landmark for the upper GI bleeding. Yes, above to it there is the bleeding, so you will say, sir, that is our upper GI bleeding. And any kind of the bleeding below this suspensory ligament of trids, you will say, sir, that is lower GI bleeding. So remember this point, very very beautiful integration of this anatomical structure with the GIT, with our surgery. Now we are looking the parts of the large intestine. You can see the small intestine ileum is coming and it is opening into the cecum. So this portion is ileocecal junction. 2 centimeter below to it there is a worm like structure. Yes, it is vestigial organ. It is known as the vermiform appendix, which may be 2 to 20 centimeter in length. Yes, now there is our ascending colon. Here is the hepatic flexor. Then you can see transverse colon. This is our splenic flexor. Then descending colon making the S-shaped structure sigmoid colon, then straight running structure is the rectum, and here is the anal canal. Yes, you will see the different clinical point in your surgery. So in this rapid revision session, we are requesting to look this all the anatomical surgical anatomy part only, because directly question from the anatomy they are not asked from here. So we are concentrating for the more output topics. Yes, we are concising, we are making the content revisable. Yes, we are doing the clinical relevant part for all of you. So here is the one important anatomical thing. What is the difference between the large intestine and the small intestine? Remember, you must know, sir, you have to say the HAT. These are the three features which are only and only present in the large intestine. These are not present in the small intestine. What are these? H for, remember, sir, hostra. Can you see? In the large intestine, there is the formation of the pouch. Yes. A for, you must remember, sir, appendices, epiploiky. These are nothing. These are the small pouch of the fat located over the large intestine. These are not present in the small intestine. And there is the T. T for Tinea coli. Remember this Tinea coli. These are nothing. These are the longitudinal muscle coat. Yes, sir. These are our longitudinal muscle coats. These are present over the surface of the large intestine, not present in the small intestine. When this tinea coli, they will show contraction. In that situation, there is the formation of the pouch. That is nothing. That is our hostra. You can say also the saculation. So you can present with the S. Now one important thing we are going to look in anatomy. Yes, in surgery you will not see these detailed things, so we are including in anatomy arteries and veins of the GIT. So what I want to tell you, there was the one movie, yes, Bahubali Devsena movie. Yes, this was the position. It was directly stimulated from our abdominal aorta and the inferior vena cava. Remember, this is our Bahubali uncle and here is our Devsena auntie. So you can see the aorta easily, and the different branches we are going to look. These are the structures, these are the arteries which are supplying the abdomen and the abdominal viscera. You can do imagination for this Bahubali. Yes, ये बाहुबली की आंखें हैं, ये नाक है, ये मुंह है और ये बाहुबली का कान है, और इस तरीके से बाहुबली का चांद सा रोशन चेहरा, ये बाहुबली का हाथ है, ये बाहुबली की निप्पल है. दिस इज द अम्बिलिकस एंड दिस इज द लोअर लिम्ब. वेरी फनी वे टू रिमेंबर, एंड जस्ट गिव him the archery. Okay, so this is our Bahubali. What are the different branches? You can see there are the three ventral branches. What are the three ventral branches, sir? Celiac trunk, superior mesenteric artery, inferior mesenteric artery. One, then our two, and then you can see the three. These are the arteries of the foregut, midgut, and hindgut. Three MCQs. Vertebral level, you can see the celiac trunk in between the T12 L1, superior mesenteric artery L1, and the inferior mesenteric artery L3. Agree? Now, what are the lateral branches? So you can see the inferior phrenic artery supplying to the diaphragm. This is our middle suprarenal artery, artery supply of the suprarenal gland, and then renal artery in between the L1, L2, and very important, the gonadal artery at the vertebral level L2. Now you can see this abdominal aorta is dividing at the junction of L4, L5 into the two common iliac artery. Also, there is one dorsal branch which is not shown in this image. So we can make one flow chart for the abdominal aorta branches. Sir, there are the our four types of the branches. What are these four types? Sir, you will say the ventral branch, you will say the lateral branch, you will say the terminal branch, you will say the dorsal branch. What are the different ventral branch? We had seen these are our celiac trunk, superior mesenteric artery, inferior mesenteric artery. Different MCQs we had seen. The lateral branches, you can remember the mnemonic IMRT, Imarati. Yes, the brother of the jalebi, one kind of the sweet. Otherwise, you can remember the TRIM, trim mnemonic also. So, I for inferior phrenic artery, M for you can remember the middle suprarenal artery, R for you can remember the renal artery, T for testicular, also you can say the ovarian, also you can say the gonadal artery. Yes, So it will be useful for the obs gynae, yes, as well as male genitourinary system. Now, the terminal branch, common iliac artery, right and left, where it is dividing, don't forget, at the junction of L4, L5. L3, L4 junction, umbilicus, while the L4, L5 junction, yes, there is our common iliac artery bifurcation, abdominal aorta bifurcation. There is only one dorsal branch. You can forget it, you can leave it, it is not important. It is at the midline. Yes, sir, that's why median, running in front of the sacrum, that's why sacral artery. Okay, so you can leave this one, but remaining all are very, very important. Getting the point better? Now, look here, we are, yes, what another funny thing, here you can see this is our abdominal aorta. Yes, sir. And here is our inferior vena cava, Devsena and Bahubali. But same kind of the phenomena, yes, Hollywood, Bollywood, Tollywood, they all are coming from our anatomy. This Titanic super pose, yes, a very famous pose was, again, it was inspired from our anatomy. Now, look here, what are the different branches? We had seen the branches from our celiac trunk, but now we are going to see the branches from our superior mesenteric artery. It will be very helpful in your surgery as well as in your radiology. The superior mesenteric artery, sir, it is artery of the midgut, so it will supply to the midgut. Yes, the midgut is starting from the second part of the duodenum at the junction, at the opening site of common bile duct. So it is giving the first branch, that is our inferior pancreatico-duodenal artery. Yes, sir, inferior pancreatico-duodenal artery. Getting the point? Now you can remember this superior mesenteric artery, it will supply to the jejunum, so it is giving the jejunal branches. It will supply to the ileum, so it is giving the ileal branches. Now it is giving the branch to the ileum and cecum area, so ileocolic artery you will say, yes, then it will supply to the our ascending colon. That's why it is right side, because it is right side, that's why right colic artery. Then it is giving the branch to the middle part of the colon, so you will say the middle colic artery. Remember, these arteries are not directly supplying to the large intestine, but they are giving the different branches which are anastomosing together, and from here the marginal branches are coming. Yes, these are known as marginal branches of Drummond. So you will see this term. Yes, sir, marginal arteries of the Drummond. Also, the inferior mesenteric artery. Yes, sir, this inferior mesenteric artery, it is the artery of the hind gut. Yes, right two-third and the left one-third. Here is a junction of the foregut. Yes, a junction of the midgut. This is the midgut, and after it there is the hindgut. Okay, so this is the point. So after this junction, this entire area will be supplied by our, yes, inferior mesenteric artery. So now see here, on the left side you can observe there is the left colon, descending colon. So the left colic artery is the first branch of the inferior mesenteric artery. Then you will see the arteries are supplying to the sigmoid colon by the many branches. Yes, it is our sigmoid artery, and one continuation, it is supplying the rectum from the above. So this is the superior rectal artery. Again, these are not directly supplying, they are giving the anastomotic branches which are supplying with the help of the marginal artery of the Drummond. Remember, there is the anastomosis between the branches of the superior mesenteric artery and inferior mesenteric artery, making the arc of Riolan. What is the importance? This part is very susceptible for the ischemia. Yes, this part is very susceptible for the ischemia. So this is the splenic flexor part, and in the similar way, this sigmoid colon part is also very susceptible for the ischemia. You can remember the point. This is splenic flexor, and here is our sigmoid colon part. Your mnemonic is GS, General Secretary. Remember, G is coming above and S is coming below. G first, then S. This is nothing. This is our Griffith point of the ischemia, and it is our Sudex point of the ischemia. So you will learn in your surgery, but yes, it is important. Now we are going to look for the vein. So I told you for the portal vein, here we are completing this one. Remember, S for splenic vein, it is coming from the spleen, running behind the pancreas. Yes, there is the superior mesenteric vein which is coming from the our midgut part. Both are running behind the neck of the pancreas and uniting together and making the portal vein, the most important vein of the GIT. Yes, this portal vein is dividing into the left branch and the right branch. What I want to tell you, yes, remember that portal vein is equal to S plus S. What is this S? Sir, S for splenic vein. Sir, S for superior mesenteric vein. So portal vein is equal to our splenic vein and the superior mesenteric vein, where it is formed at neck of pancreas. At which vertebral level? Remember, at L2 vertebral level. Both, yes, these all the 3 points are very important MCQ. With the help of the portal vein and its different tributaries, we are going to know why there is the gastroesophageal varices, why there is the piles hemorrhoids bleeding, why there is caput medusae is occurring. See here, the simple diagrammatic presentation: S for splenic vein, it is uniting with the S for superior mesenteric vein, and now they are making the portal vein. Agree, sir? This portal vein is dividing into the right division and the left division. Remember, the right division is shorter and wider, but the left division is narrower and longer. That's why whenever there is the infection in the mesentery, yes, we all know this, our superior mesenteric vein is the vein of the midgut. So infection from the GIT, from the superior mesenteric vein or the inferior mesenteric vein, it will reach to the portal vein, and from the portal vein there is a more tendency to involve the right lobe of the liver. Yes, with the help of the anatomy, now you can say why in case of the ant amoeba histolytica, parasitology, microbiology integration, yes, you will see in surgery and medicine the ant amoeba histolytica, why the right lobe is more commonly infected. Yes, another thing, pathology and the surgery integration, why the hepatocellular carcinoma secondaries from the GIT, they are coming from the superior and the inferior mesenteric vein, and they are reaching into the portal vein, and they are involving the right lobe of the liver more commonly. We are going to look this all the things with the basics of our portal vein. One funny thing you can remember, this portal vein is just like the nibba of the first MBBS. Yes, he is very fashionable. You can see this is the body, correct, sir? This is lower limb. Yes, and this is the one limb resting over the ground and another at the air. Here are the upper limb. He is dancing. Okay, you can see the cap. Yes, sir. And here is the tail. Yes, sir. You can observe where is the Nibbi. Nibbi is here. She is also dancing. So this is the dancing movement of the portal vein. Easily you can remember. What I want to tell you, sir, these are our left gastric vein and the right gastric vein, which are showing the anastomosis along the our stomach. So you can see these portal veins are located close to the lower end of the esophagus, where they will make anastomosis with the vena cava system. So it is the one side of the portocaval shunt. Also observe now next thing, sir, there is our para umbilical vein draining into the left branch. Yes, it is reaching to the umbilicus, where it will show anastomosis with the vena cava system, another site of the portocaval system shunting, that is our umbilicus. So if there is the more and more blood in the portal vein, it will accumulate around the umbilicus, and it will show the abnormal dilated tortuous zigzag vein. Yes, which will appear like the head of the medusa at the our umbilical region, caput medusae. Also you can see the inferior mesenteric vein is opening into the splenic vein. Remember, this inferior mesenteric vein, it is having one tributary, superior rectal vein, which is showing anastomosis with the vena cava system in our rectum anal canal. So if there is a portal venous hypertension, yes, sir, the portal vein, it will get accumulation here, 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 and our superior rectal vein, they are showing the congestion. So there will be the piles and hemorrhoids. So these are the three classical sites for the portocaval shunt. Lower end of the esophagus, esophageal varices is common. Yes, around the umbilicus, caput medusae is seen, and lower end of the rectum and anal canal, sir, there is our piles and hemorrhoids. These are visible. Okay, so you can observe easily whenever there is the portal hypertension vein, because it is draining into the liver. So whenever there is a liver cirrhosis, alcoholic cirrhosis is the most common cause, then portal vein, there is a more and more blood, portal hypertension is occurring. Yes, esophageal varices is occurring. Yes, there is the paraumbilical vein involvement. Yes, sir. Here is the paraumbilical vein. That's a caput medusae, and the blood is accumulating into the inframesenteric vein piles. Okay, sir. But it is also including the splenic vein. So the pressure in the splenic vein is high, splenic venous congestion, and spleen is getting congestion, so there is presence of splenomegaly pathology integration. Also there is superior mesenteric vein and inferior mesenteric vein which are draining the blood from the midgut and hindgut, so there is presentation of the ascites. So this is the beautiful integration. This portal vein, directly questions may be asked, may not be asked, but the portal hypertension and the portocaval shunt manifestation, they are very important. Now, at the end of this beautiful session, few motivating lines for you, all the amazing students. Remember कि दरिया अब तेरी खैर नहीं, बूंदों ने बगावत कर ली है, नादा न समझ बुजदिल, इनको लहरों ने बगावत कर ली है, हम परवाने हैं मौत समा, मरने का किसको खौफ यहाँ, तलवार तुझे झुकना होगा, गर्दन ने बगावत कर ली है, अब गर्दन को भी डर नहीं है कि अब हम कट जाएंगे. सो दिस इज द करेज. Remember, if you are having the courage, then you can achieve your target. Yes, always give the proper direction to your energy. Definitely you will crack everything. Now we are moving for the next part. This is all about the abdomen. Thank you. Hello friends, now we are going to see the abdominal viscera and the pelvic viscera. First we are looking the abdominal viscera. In this portion, yes, this is the cadaveric image. In previous section we had already seen the many orientation of the different viscera with their blood supply, but one cadaveric image practice again for all of you. You can easily observe here, sir, this is the position of the largest metabolic organ of the body. Yes, within the right hypochondrium, this is our liver. You can see the gallbladder located within the gallbladder fossa. You can observe here the duodenum, first part, second part, then you can see the third part, and here is our fourth part of the duodenum. Yes sir, within this C loop of the duodenum you can observe there is the position of pancreas. So this is head of pancreas. Here you can see the uncinate process. This narrow part is the neck of the pancreas, then body, and then the tail part is encroaching to the spleen. Yes sir, here is the our spleen. So remember the different parts of our pancreas I'm indicating here, so that you can catch easily the points of the surgery. Here is head. Yes sir, this is small projection is uncinate process. You can see the neck portion. Here is body and this is tail part. Now capture this point. This is location of the our celiac trunk, where you can see the our common hepatic artery and the proper hepatic artery is running. Then it is dividing into the right and left hepatic arteries. You can see the gastroduodenal artery which will make the superior pancreaticoduodenal artery at the our concavity of the C loop of the duodenum. You can see this particular artery making highlight with the bluish color. Yes, gastroduodenal artery, it will divide into the superior pancreaticoduodenal artery, and another will be the our, yes, right gastroepiploic artery. Now look here, at the hilum of the spleen, the different structures are coming within which you will observe, sir, there is the location of the splenic vessels also. Now one by one, step by step, more knowledge points we are looking. Yes, we are going to talk the first important viscera, that is the spleen. More things you will learn in your surgery, directly question from the anatomy, less likely to be asked in recent pattern, but just one view. So for the spleen, you can remember the Harris dictum. Yes sir, there is the Harris dictum, which is our magic of odd number. So you can remember 1, 3, 5, 7, 9 and 11. Sir, 1, 3, 5, these are inches. Yes, dimension. Correct, sir. So these are the dimensions of the spleen. It is located in our left hypochondrium at the bed of the stomach. Yes, 7 ounce is the weight, and remember 9 to 11 ribs are location. So you can observe beautifully. This spleen is having the two end, anterior end which is like the border, posterior end is broadened, it is narrow like the point, and it is having the three border, superior border, intermediate border and inferior border, which are corresponding to the respectively 9th rib, then 10th rib, then 11th rib. Remember, this 10th rib makes axis of the spleen approximately 45 degree. Now, within this spleen, you will observe two surfaces, outer surface and inner surface. Outer surface is related with the ribs. So this is also known as the costal surface, and inner surface is related with the viscera. So there are the four important viscera related to the inner surface. You can remember the mnemonic, that is the girls common room may बैठकर pee. So there is the word gastric impression by the stomach. You will see there is the colic impression by the colon. Yes, you will see there is kidney impression, renal impression by the left kidney, and the pancreatic impression. Remember, the tail of the pancreas is related to the hilum of the spleen. So these are the important points. Also, you can focus that this our tail of the pancreas is rich in the beta islet cells, which are responsible for the secretion of the insulin. So surgery integration, if we are doing the splenectomy operation, the tail of the pancreas is also removed. So there is the complication diabetes mellitus. Yes, surgery integration. Also remember, along the upper border there is the course of the zigzag artery, splenic artery. So in case of acute pancreatitis, which arterial aneurysm is seen? Answer is our yes, splenic artery. One question from the surgery had been asked, if there is the cancer from the uncinate process, which vessels will get compressed? So you can easily see these are our superior mesenteric vein as well as artery. So there is the compression of the superior mesenteric vessels. This is the question from your surgery 2019 pattern, which you can solve on the basis of anatomy. Now we are coming again for the our spleen part. This is the cadaveric image for the spleen. Yes, here is the superior border, intermediate border, lower border. Yes, intermediate border is related with our hilum of the spleen, where you can see splenic vessels, and you can see the superior border near the anterior end, it is showing the notched pattern. This is our costal surface where the 9th, 10th, 11th ribs are associated. So after this knowledge, we are coming to the next organ, that is the largest metabolic organ of the body. Yes, it is our liver. So on the front side, you will see the location of one ligament, sir. It is our falciform ligament, which is dividing the liver into the left lobe, and here is right lobe. Getting the point? The left lobe is approximately 1/6, while the right lobe is approximately 5/6. So which ligament is dividing? Remember, this is our falciform ligament. And here is a gallbladder fossa where the gallbladder is located. Yes, now we are turning the liver and we are observing at the back side. So you can observe this is the posterior surface of the liver, where the different viscera, they are showing the impression. We are turning the liver, so it is showing the stomach impression in such kind of the way. So stomach is located here, then it will continue as the duodenum. So this is the part where duodenum will be located, and you can observe, sir, this is the portion where the gallbladder is located within the gallbladder fossa. And here you can see the position for the inferior vena cava, and this is the part where the kidney, yes, right kidney is located with the right suprarenal gland. So these are the our different structures on the posterior surface of the liver, yes, as well as inferior surface. I had told you. Look here, to make easy this point, can you do imagination of one H-shaped area? Yes, sir, this is our H-shaped area. So in this H-shaped area, you can see this is the position for one ligament, sir. This is our ligamentum venosum, and here is another ligament is present, that is, yes, you can observe here, ligamentum teres. So remember, just on the left side of this ligamentum venosum and the ligamentum teres, this is left lobe of the liver, and right to this both the ligament, entire portion is our right lobe of the liver. Okay, now you can observe this is our porta hepatis, where you can observe the important 5 structures entering within the porta hepatis. Yes, these are our, you can remember easily, the VAD, portal vein, hepatic artery, bile duct. Each will show right and left division. Along with this, you will see the hepatic nerve plexus as well as hepatic lymphatics or lymph node. So these are the 5 structures within the porta hepatis. The length of the porta hepatis is again 5 centimeter. Now look here. Yes, in this H portion, This vertical limb is showing the inferior vena cava position, while this downward limb is showing the gallbladder position. Correct, sir. Now you can observe this particular important lobe for the surgery. Sir, this is our caudate lobe. Yes, in coinod segmentation in surgery, you will see this was given the coinod segment 1, while here the coinod segment 4 is related with the gallbladder. So remember these two segments. Just one important anatomical structure boundary: the caudate segment superiorly, it is having the superior surface of the liver. Inferiorly, there is the porta hepatis. On the left side, ligamentum venosum. On the right side, inferior vena cava. So easily you can understand this, all the things. Now the quadrate lobe: superiorly the porta hepatis, yes. Left side, ligamentum teres, yes. Right side, gallbladder. And inferiorly, there is a sharp border of the our liver. So this is the diagrammatic presentation. Yes, one easy way to remember the liver. Liver you can understand as the magic of 5. For the spleen, Harris dictum, magic of odd number. For the liver, yes, magic of 5. There are the 5 surfaces. Yes, it is wedge-shaped organ. It is presenting with the superior surface, right surface, and inferior surface. Then there is the anterior and the posterior surface. Okay, sir. Now, there are the 5 structures in porta hepatis. I told you these are our hepatic, yes, that is a portal vein, hepatic artery, bile duct, then our nerve plexus, and then lymph node. So these are the 5 structures. Again, remember 5 centimeter length of the porta hepatis. Correct, sir. There are the 5 important ligaments, which are nothing. These are peritoneal fold. So what are the 5 different ligaments? First is falciform ligament. Second is ligamentum venosum. Third is ligamentum teres. These are the 3 ligaments which are dividing the liver into the left lobe and the right lobe. Okay, sir. Now, there are the 2 more ligament, that is the coronary ligament and triangular ligament. Okay, sir. So these are the 5 ligaments. Also remember the 5 important viscera on the inferior surface of the liver. These are stomach. Correct, sir. Second is our duodenum. Correct, sir. Then you must remember the gallbladder, as well as you can see the colon, the hepatic impression you can remember, and another structure is our right kidney. So these are the structures at the inferior surface. When you will talk for the posterior surface, you will include on the posterior surface the right suprarenal gland as well as the inferior vena cava, and this is the portion where no viscera is related. Yes, where there is the no peritoneal covering, which is known as simply the bare area, the naked area of the liver. So these are the points which you have to remember about the liver. Yes, we had already seen the arterial supply, venous drainage, this all in our previous artery and the veins of the GIT. Now look, from our Bailey and Love recent editions, it is updating regarding the sphincter. So this is the one controversial question. The bile duct, yes sir, common bile duct, it is opening with the pancreatic duct in our second part of the duodenum. Getting the point? So in the second part of the duodenum, this is the part where there is the junction between the foregut and midgut. Correct, sir. We had seen. So at the site of the opening, there is the mucosal elevation. This is simply known as the ampulla of Vater. Correct, sir. But remember, there is the group of the circular muscles which are acting like the sphincter. This is the sphincter of Oddi. So the question was there, how many sphincters at the sphincter of Oddi? So you can see the common bile duct is having the superior choledochal sphincter, then inferior choledochal sphincter, and you can see there is the our ampullary sphincter. So common bile duct is having total 3 sphincters, while the pancreatic duct, it is having the, yes, our pancreatic sphincter as well as this ampullary sphincter is common for the pancreatic duct also. So it is having the 2 sphincter. So how many sphincters are present total at site of the second part of duodenum? Your answer is, sir, 1, 2, 3, 4. Agree? Now, how many sphincters are present for the common bile duct? Your answer is, sir, 1, 2, 3. Agree? And now, next question, how many sphincters are present for the pancreatic duct? So you will say, sir, 1 and 2. Okay? So concentrate properly what the examiner is asking, what is the exact term. Okay? Every part is having the different kind of the answer. Now, come to the next. This is our diagrammatic presentation for the kidney and abdominal aorta, inferior vena cava. So we had seen for the our same story, Devsena and the Bahubali. Sir, this is our abdominal aorta, and here is our inferior vena cava. Can you see this inferior vena cava is having the opening of the renal veins, and you can observe the renal arteries which are the branch from the abdominal aorta. Yes, this is our abdominal aorta part. Now you can see the, yes, sir, inferior vena cava. Here is our abdominal aorta. You can observe the major ventral branches. Sir, these are celiac trunk. Here is superior mesenteric artery, and you can observe the inferior mesenteric artery at the downside, the three main arteries of the our GIT. Yes, you can observe beautifully the different structures at the our, yes, this is our left kidney, and here is our right kidney. You can observe the suprarenal gland above the kidney. Now you can see there are our different structures at the hilum. The renal vein is on the front, then renal artery, and the posteriormost structure is our ureter. So these are our different structures. Remember, the relation is the vein, artery, and ureter. Now look here, the next diagrammatic presentation for the kidney. Sir, the kidney is having the two poles, upper pole, and here is the lower pole. Correct, sir? The sequence is the vein, and then you can see the artery, and the posteriormost structure is ureter. So don't forget this VAU relation, just like the VAN at the kidney hilum. Yes, you can see there is the anteriorly and medial, anteromedial border, and here is our posterior and lateral border. So this is the posterolateral border. You can see the anterolateral surface, and there will be the posteromedial surface. So magic of two for the kidney: two poles, two borders, two surfaces. And don't forget this VAU relation for the different procedures of the surgery. Now look here, the cut section of the kidney. You can see the outermost layer is our cortex, and then you can see the medulla. You can observe the position of the minor calyces. Yes, sir, minor calyces, which are opening into the major calyces, and then this all the major calyces are uniting together and opening into the pelvis. Okay, and then this pelvis is continuing as the ureter. Okay, so these are the different structures we are looking from the back side. Now come to the our next. The knowledge of this kidney will help you in the radiology. It will help you in intravenous pyelography. Yes, different kind of the view for the our kidney. So you can see the kidney. Yes, sir. Here you can observe the minor calyces which are opening into the major calyces, and here you can see the pelvis, and this is our ureter portion. Yes, this continuation is our ureter. Correct. Now come to the our next part, but in between this session, remember few positive lines. रख हौसला, वो मंजर भी आएगा, प्यासे के पास चलकर समंदर भी आएगा, थक कर न बैठ आए मंजिल के मुसाफिर, मंजिल भी मिलेगी और मिलने का मजा भी आएगा. So with this positive lines, now we are moving for the next, for the perineum and the pelvic viscera. Remember, abdominal cavity was divided into the abdominal cavity proper and below portion, that is the pelvic cavity. The separating structure is our pelvic diaphragm, which is mainly formed by the levator ani. We are going to see this all the things step by step. Try to understand. Sir, this is our coronal section of the pelvic area. So you are able to see the different bones. Here is ilium. You can see the ischium. Pubic portion has been cut. Okay, so you can see the position of the rectum and anal canal at the center. There is one muscle which is slopy. Yes, when this muscle will contract, it will elevate the rectum anal canal. Just apply the physics concept. The two vectors are going in such kind of the way. so resultant will pass through the center. So this muscle is elevating the anus. That's why this is our levator ani, which is the major contributor for this pelvic diaphragm. What is the diaphragm? Any muscle, any structure which is separating the two cavity. Yes, it is separating the true pelvis and our perineum area, or you can say the pelvic outlet. So one by one we are going to understand. See here, this is very important position, lithotomy position, which we had already discussed in our general anatomy part for the study of the genitourinary region. So this is the lithotomy position. On the front you can see, sir, here is penis and scrotum, and on the back side there is the anal canal. Yes, this is the perineum. The area between two thigh is known as the perineum. But in female you will see the three different opening. In the males, genital system and urinary system both are having the common opening, while the anal canal is having the another opening, two opening in the males. But in female you can see there is our urethral opening one, there is the vaginal opening two, and here you can see the anal canal opening three. So total three openings in our female. So this is the perineum. This is very important for the delivery of the baby, obs gyne integration. So what are the different boundaries of the perineum for obs gyne? We are cutting this all the structure. So definitely you will get the skin, sir. After the skin, there will be superficial fascia, then deep fascia, and then you will see the muscles and bones. So we are removing this all the structure, so you can observe such kind of the pattern. Yes, on the front side there is the our pubic symphysis, there is a pubic tubercle, and here is the our ischial tuberosity in the lithotomy position. Yes, in lithotomy position you will observe at the back side, sir, there is the sacrum, correct sir, which is articulating with the, yes, suppose this is sacrum, which is union of the five bones, and it is articulating with the coccyx. We all know, yes, here is the position of the obturator foramen, and this is presenting the ligament between the sacrum and the ischial tuberosity. You can say this is our sacrotuberal ligament. Yes. Now, this area is our perineum. Getting the point? So, what are the different boundaries of the perineum? Yes, on the front side, there is a pubic symphysis where the fibrocartilage is located. So what are the different boundaries? Sir, anterior boundary is formed by pubic symphysis structure. Yes, anteriorly and laterally, this is between the ischial tuberosity and pubic symphysis, so known as ischiopubic rami. Correct, sir. The lateral boundary is formed by ischial tuberosity, while the posterior and lateral side of the our perineum, it is formed by the ligament between the tuberosity and our sacrum. So you will say, sir, it is sacrotuberous ligament. Getting the point? And the posterior most boundary, this is the posterior and lateral boundary. Posterior boundary is formed by the our sacrum and coccyx. Correct, sir. Now catch this point. There are the three openings are visible. Urethral opening on the front, and at the back side there is the anal canal opening. Okay, sir. But in female, there are the three opening. Just behind the urethra, there is the vagina opening. So urethral opening, vagina opening, and anal canal opening. Now, catch this point. One imaginary line is dividing this perineum into the two triangles. This is our front side. Yes, here the urinary and genital area is there. That's why it is known as urogenital triangle. While this is our posterior part where anal canal is located. So this is known as the anal triangle. So what I want to tell you, one classification for all of you, sir, perineum. It is divided into the two triangles, anterior triangle and posterior triangle. Agree, beta? Now, anterior triangle, here is urinary and genital area. So, urogenital triangle. While the posterior triangle, yes, here is the anal canal. So, you will say anal triangle. Now, catch this point. In this, our urinary and genital area, again, you can divide into the two spaces. These are superficial perineal pouch. Also, you can say space, and the deep perineal pouch. Also, you can say deep perineal space. While the anal triangle can be divided into the right and left ischiorectal fossa. Correct, sir. So these are your classification. You can easily catch these points. Now we are going to draw one another diagrammatic presentation for understanding this perineal pouch. Simple diagrammatic presentation for proper understanding. This is our entry abdomen wall. This is penile area. Here is the scrotum, and this is our perineum part. Now catch this point. There is a modification of the fascia in the penis. This is our buccal fascia. Modification of the fascia in the scrotum known as Dartos fascia, and the modification of the fascia in the perineum area known as Colles fascia. So your mnemonic is BD Chaurus. Yeah, yes, BDC is your mnemonic. You can remember the buccal fascia is anteriormost in the penis. D for sir, Dartos muscle, yes, in the scrotum, and C for Colles fascia in our perineum part. Now, diagrammatic presentation that here is our pubic symphysis and central tendon of the perineum, that is the perineal body, is located, suppose here. Again, what is the central tendon of the perineum? Try to understand. In this perineum part, there is the location of the one structure which is having the insertion of the 10 muscles. This is known as the perineal body. Also you can say the central tendon of the perineum. Okay, so what you have to remember, the same thing, this is our perineal body. Now look here, there is our urogenital diaphragm. One simple diagrammatic presentation. This is the perineal membrane. Also remember, the old concept was separate. There was the urogenital diaphragm with the superior fascia and the inferior fascia, but now this concept has been abolished. Now this is simply our urogenital diaphragm. Yes sir, urogenital diaphragm, which is considered as the perineal membrane. Earlier the inferior layer of the urogenital diaphragm was considered as the, yes, the perineal membrane. Now try to understand the space below this urogenital diaphragm and in between the Colles fascia. When you will do operation, it will come first. So this is superficial perineal pouch, and the space above this urogenital diaphragm, this is known as deep perineal pouch. Simple concept. Okay sir, now try to understand the more things within the same diagrammatic presentation. Yes sir, we all are aware there is the location of the urinary bladder, the pelvic viscera, correct sir? Now it is continuing as the urethra. In the males, you will see there is the location of the prostate gland at the neck of the bladder. So this is our prostate gland. Agree, sir? Now, this our urethra, which is passing within the prostate gland, this is prostatic urethra. Yes, it is passing through the perineal membrane. So now it is known as membranous urethra. Then it is showing the bulb-like dilatation, bulbar urethra, and then it is continuing within the our penis. So this is penile urethra. What are the different parts which we had shown here, sir? This is our urinary bladder. Here you can see the prostate gland, and you can observe the four parts of the urethra. Sir, this is our first part passing through the prostate gland. This is, yes, prostatic urethra. Then second is passing through the perineal membrane. So it is our membranous urethra. Next is our, yes, bulb-like dilated part. So you will say bulbar urethra, and which is passing through the penis. This is simply the penile urethra. So these are the four parts of the male urethra. Yes, male urethra is very long, total 20 centimeter in length, MCQ, but in female you will see only the 4 centimeter because of absence of the penile part. So remember, the females are having the short urethra. That's why more chances of the UTI in female, integrating with your microbiology, with your pathology, with your medicine, as well as obs-gynae. Now look here, in surgery you will observe these are coming first when you are going through this superficial part. Yes, that's why these are also considered as the anterior urethra, while these are considered as posterior urethra in your surgery. So this is our surgery. Beautiful integration. Now try to understand, apply the logic. If there is the injury at the perineum area, there is a urethral rupture, definitely questions are asked. That's why we are going to talk. So in this situation, remember, whenever, what is the most common cause of the urethral injury? Answer is instrumentation. Yes, catheter we are introducing, the Foley's catheter, this all can cause the injury. In that situation, the most common site is our, yes, bulbar urethra. But remember, if there is the pelvic cavity injury or the pelvic bone rupture, fracture, in that situation, this membranous urethra is getting ruptured. So question will be asked, one patient is coming to you with the swelling of the penile area, scrotal area, perineal area, means definitely the urine is coming from here and it is passing into this portion. So this is the site of the injury of the bulbar urethra, also may occur in the penile urethra. But if any patient is coming to you with the dysuria, not able to pass urine, and there is a no swelling in this area, in that situation, the urine is getting collection in the upper part to the urogenital diaphragm, means you can say the deep perineal pouch. So you will see this all the integration in your surgery. You can see in this pelvic viscera portion, there is our pubic symphysis. Here is the urinary bladder, prostatic urethra, and urethra is coming out. Sir, prostate gland is visible, and behind to it there is our rectum and the anal canal. Yes sir, here is our sacrum. You can observe that urogenital diaphragm is pierced by the our prostatic urethra, membranous urethra, and here is the our, yes, you can say the penile urethra. Now look here, this is our cadaveric image. You can easily catch these points. You can see the anterior abdominal wall, and here is our posterior abdominal wall or gluteal region, you can say. So this is bony part, pubic symphysis. You can see the our urinary bladder here. This is our urinary bladder just behind the pubic symphysis. You can observe the location of the prostate gland. Yes sir, it is our prostate gland at the neck of the urinary bladder, and you can see this is our prostatic urethra, which is becoming the membranous urethra. Yes sir, it is very thin. Then it is showing the bulb like dilatation, the bulbar urethra, and here is our penile urethra, long penis course. Yes, this is the penile urethra. You can observe the scrotum area behind the penis. Now at the back side, you can see this cavity. It is nothing, it is our rectum, which is continuing within the narrow canal. Yes, it is our anal canal. Okay, now look here, the same presentation. Yes, we are looking for the urine bladder also. So this is the one important view of the urine bladder from the back side. You can see this is our urinary bladder, where at the neck the prostate gland is located. The urinary bladder is related with the four important structure on the back side. First, there is the peritoneal covering. Yes sir. Second is our opening of the ductus deferens. Yes, it is meeting with the seminal vesicle and making the ejaculatory duct, and this portion is having the condensation of the fat. This is our fascia of Denon Wheelers. Yes, so this is the one important MCQ for the our different kind of the examination, like digital rectal examination. You will learn DRE. Yes, you will insert in the anal canal finger. Yes, you will insert the finger in the anal canal here. Okay, sir. And you will palpate the anterior side. So you can see the posterior surface of the urinary bladder, our seminal vesicle, prostate gland, this all the things. Prostate cancer is important, for which you will perform this procedure. Now, look here. This is our urethral injury, which you will learn in your surgery part. Also, the radiology is very helpful investigation for this. Yes, there is the straddle injury. Person is walking and foot is over the manhole gutter, so there is the injury of the perineum area, urethral injury by this our manhole. So you can see this is our urinary bladder, correct sir, and this is our prostatic urethra, membranous urethra, and then bulbar urethra, and here is the penile urethra. I told you the case, if there is the dysuria and urine is collected in the perineum area, also you can say superficial perineal pouch, means most common site of the injury is bulbar urethra. But patient is coming to you and there is the no passage for the urine, you can say dysuria, but there is no swelling at the perineum area. So you can observe by the different radiological modality that urine is accumulated above the our perineal membrane, urogenital diaphragm, in the deep perineal space. So the most common site will be the our membranous urethra, also sometimes the prostatic urethra. So integrate with your surgery, it is important. And the same thing you will see in radiology. This is our urinary bladder. So this portion is showing the prostatic urethra. The thin portion is showing the membranous urethra, and here you are looking the bulb like dilated part. This is our bulbar urethra, and you can see there is our penile urethra. So these are our different portion for this quick revision session as well as surgery integration. Now come to the more things for the our clinical purpose. Try to understand, this is the same thing, our perineal area. Yes, this is our pubic symphysis. Here is a sacrum and coccyx portion. This is ischial tuberosity. So you can observe at the center part there is the perineal body. Also you can say the central tendon of the perineum. It is having the total 10 muscles attachment. How? From the front side there is the bulb of the penis or bulb of clitoris is coming. Yes sir. So these are two in number, 1 and 2. These are our two bulbospongiosus muscle. These are getting insertion into this our perineal body. You can see the transversely running muscle group. This is superficial transverse perineal, again 2 in number, and depth to it there is a one more another group. Yes, it is deep transverse perineal muscle. Yes, you will be able to see the one muscle group. This is our levator ani muscle, which is responsible for the elevation of the anal canal. So these are again 2 in number. Also you will see the external anal sphincter as well as external urethral sphincter. They are also having the attachment for this perineal body. So there is the one external anal sphincter and also the urinary sphincter. They are 1. So total 2, 2, 2, 2, 8, then 9 and 10. Total 10 muscles are getting insertion in the perineal body. So remember, never cut this perineal body. Remember, here is urethra, then there is a location of the vagina. So always do episiotomy on the posterior and lateral side. If you are doing on the posterior side, the episiotomy of gynae integration, you are causing the damage to the perineal body. There is the paralysis of this all 10 muscles. So it will result in the prolapse of the uterus, prolapse of the rectum, because it is very important structure getting attachment of the 10 muscles. It is supporting this rectum as well as our uterus. Okay, so this prolapse of the uterus and the prolapse of the rectum you will learn in surgery and obstetrics, but it is very important. That's why this perineal body you must know. Now we are coming to the our one more important structure, that is the pelvic diaphragm. Try to understand, this is again our perineum area. This is anterior part, here is the posterior part. You can see the pubic symphysis, and here is our sacrum and the coccyx. Yes sir, here is the location of the ischial tuberosity. Getting the point? Now you can see there is a urethral opening, vaginal opening and anal canal opening. Correct sir. And at the center you can see the perineal body. Okay, now look here, at the urinary genital area there is location of the our, yes, urogenital diaphragm. Agree sir. But try to understand, there are different groups of the muscle. Yes, this is our pubic symphysis, also you can say the pubic bone. Okay sir. Now above here you will see the iliacus. Correct sir. So the group of the muscles are coming from the different parts of the pubic bone. Yes, you are looking from the downside lithotomy position. So the group of the muscle which is coming from the pubic bone and getting insertion into the coccyx. Yes, so this is our pubococcygeus, from the ilium iliococcygeus, and from the ischium ischiococchygeus. Okay, so this is the simple way to remember. Yes, pubococcygeus, iliococcygeus and ischiococchygeus. These are the three different groups of the muscle. Now these all the muscles are uniting and they are making the separation of the two cavity. See here, this is our one slopy muscle. Correct sir. When these two muscles will contract, they will elevate the rectum and anal canal. Correct sir. So this muscle is known as levator ani. Agree? Above this levator ani, you will see the abdominal cavity proper, and below to it, you will see there is the perineum. So this structure is separating the two cavity. That's why this is acting like the diaphragm. Any structure which is separating the two cavities known as a diaphragm. It is situated in the pelvic area. That's why it is pelvic diaphragm. You can remember the pelvic diaphragm is equal to levator ani, and a small muscle is contributing in this our pelvic diaphragm, that is from ischium to the coccyx, that is the ischiococchygeus. One more thing you can remember, I am telling you in very simple way for this rapid session. Okay, otherwise it is very detailed and many new theories are also there. Yes, this levator ani is nothing. It is the part of the muscle which is coming from the pubic bone and the iliac bone. So you can say pubic bone to the coccyx, pubococcygeus, and from the iliac bone to the coccyx, so iliococcygeus. So you can say the pelvic diaphragm is equal to pubococcygeus plus iliococcygeus plus ischio-coccygeus. Little more detail we can observe from this diagrammatic presentation. Yes, you can see the urethra and the genital area. So the small diaphragm separating structure is our urogenital diaphragm located here. Now you can see from the pubic bone, the muscle groups are coming and they are encircling the vagina. So these are acting like the sphincter. So these are known as the sphincter vaginae. Simple way. Yes. In males, there is the presence of the prostate gland. So the same structure is replaced by the levator prostatae. Yes. Now look here, the group of the muscles which are taking origin from the pubic bone and they are attached to the rectum. So these group of the muscle is simply known as pubic bone to the rectum. So puborectalis. Okay, sir. And you can see there is another set of the muscle which is taking origin from the iliac bone and it is coming to the our coccyx part. So this is our pubococcygeus. Remember, there is one another set of the muscle which is attached from the pubic bone to the coccyx, that will be known as the pubococcygeus. So what I want to tell you, sir, there is our pubococcygeus, here is the iliococcygeus, and from the ischial tuberosity to the coccyx part, you will say that is simply the coccygeus muscle, which is simply known as the coccygeus also. Yes, this is the ischio-coccygeus, which is also known as the coccygeus. At the posterior side, you will see the sacrotuberous ligament. So finally, what you have to remember, sir, pubococcygeus plus iliococcygeus plus ischio-coccygeus, they are slopy in structure. Yes, these are separating the pelvic cavity and the perineum. So these are the diaphragm. Yes, it is our pelvic diaphragm. The levator ani, simple way, the pubococcygeus plus iliococcygeus is equal to our levator ani. Yes, when it will show contraction, it will elevate the anus. It is the main participant of our pelvic diaphragm. For obs-gynae purpose, one point I want to tell you, sir, this is our pubic symphysis part. Obturator foramen, you can see this is our ischial tuberosity part. You can see the sacrum and the coccyx part at the back side. So here is a greater sciatic notch, lesser sciatic notch. In between them, you can see there is the ischial spine. Yes, there is the one ligament from the our sacrum, and you can see this is our sacrospinous ligament. So try to understand, there is a formation of one facial canal. Yes, this is our one canal through which pudendal nerve is passing. This pudendal nerve is very, very important nerve. It is a somatic nerve of the perineum area. It is a painful nerve. So remember, for any kind of the surgery, you have to block the pudendal nerve within the pudendal canal. This was studied by the Alcock. That's why it is also known as the Alcock's canal. Catch this point again. This is the procedure of the pudendal nerve block. You will see that pudendal nerve is running just over this our ischial spine. So in lithotomy position, you will go through the pervaginal approach, or in the males through the perrectal approach. Yes, you are inserting the finger posterior and laterally. You can feel the ischial spine. Anatomy is saying just over it there is a pudendal nerve. So you will give the infiltration of the anesthetic agent over this ischial spine. This is our pudendal nerve block procedure, which is done for the urinary surgery, for the genital surgery, for the anal canal surgery. Yes, because the pudendal nerve is the nerve of our perineal area. It is painful nerve. So just a few lines for this pudendal nerve. You can easily catch that pudendal nerve is formed by the S2, S3, S4 root values. MCQ. Yes, then it is running over the ischial spine. Correct, sir? You can see the three structures over the ischial spine. You can remember the PIN mnemonic. P for pudendal nerve, I for internal pudendal artery, and N for nerve to obturator internus. Pin is your mnemonic. Now this nerve is coming and it is giving the branch. Yes, this is inferior rectal nerve. It is supplying the rectum. Then it is coming. It is giving the branch. This is dorsal nerve of the penis. So penis related surgery, you have to block this pudendal nerve, and you can see this nerve is giving the branch to the scrotum. Yes, so for the hydrocele, for the scrotum related any kind of surgery, you have to block the pudendal nerve. So remember these points regarding the pudendal nerve. It is important for the genitourinary surgery as well as obs-gynae. One another quick revision for the prostate gland pelvic viscera. Yes, the prostatic urethra is passing through the our prostate gland. Correct, sir. You can see the anterior lobe, you can see the posterior lobe. Here is our median lobe. You can observe the seminal vesicle is meeting with the ductus deferens and making the ejaculatory duct and opening within the our prostatic urethra. Yes, this is the front view. You can see in this front view, this is location of the our prostatic urethra within the prostate gland. Okay, sir. So there is the spindle shaped structure within the prostatic urethra. This is known as urethral crest. Within it, you can observe there is the opening of the prostatic utricle. Remember, this prostatic utricle is the remnant of the paramesonephric duct, which is responsible for the formation of the female genital tract. Remember, this is rudimentary in the males. So this prostatic utricle is considered as the male uterus or male vagina. Yes, uterus and vagina, they are present in males. Yes or no? Your answer is yes. These remnant are the prostatic utricle. Just below to it, you will see there is the opening of the ejaculatory duct. Yes, in surgery you will see this portion, this middle portion is known as the verumontanum for your surgical landmark, and the prostatic ducts, they are opening on each side of the prostatic, yes, urethral crest. This space is known as prostatic sinus. Okay, also you can observe there is the presence of the muscles above and down of this prostatic urethra. These are our internal urethral sphincter, and here is the external urethral sphincter. Physiology integration, this internal urethral sphincter is made by a smooth muscle. Agree, sir? So these are involuntary, while the external urethral sphincter, these are made by the skeletal muscle. So these are voluntary in nature. So remember, when we are performing the transurethral resection of the prostate gland, and suppose there is a damage to this internal urethral sphincter, in that situation, ejaculation from the ejaculatory duct, it can go upside, which is known as retrograde ejaculation. Yes, this is the cross section of the prostate gland we are observing from the top. So you can see the prostatic urethra, which is semilunar shape. MCQ, also you can say horseshoe shape. Yes, it is semilunar shape. Old question pattern. Remember, entry to it, anterior lobe, here is posterior lobe, you can see right lobe, left lobe, and this center part is our median lobe. Due to this median lobe, there is a compression over this prostatic urethra from the backside, and it is converting into the horseshoe shaped or semi-lunar shape of the our prostatic urethra. Now look the clinical point. Prostate gland is important. Why? Because of its clinical, there is the prostatitis. Yes, sir. There is the prostate tumor. Benign is known as the benign prostatic hyperplasia. Also, you can say hypertrophy. And the malignant condition is prostatic carcinoma. Yes, remember, the BPH is 70% males. They are affected with the BPH at the age of the 70 year. Yes, it is very commonly seen. Any old person is coming to you and he is saying that, Dr. Saab, I am having the more and more urinary frequency at time of night. I am awakening for the 8 to 10 times for the urine. Definitely it is the case of the BPH. It is so common. And also the prostate carcinoma is one of the most common carcinoma in the males in world. So you can see this is our normal prostate located at the neck of the bladder, but there is the benign prostatic hyperplasia hypertrophy. So there is a slitting of the urethra. MCQ for the patho. Yes, sir. Slitting of urethra. So this will result into the obstruction of the urinary pathway. So patient will present with the frequency, yes, urgency and hesitancy to pass the urine. Yes, it is seen in old age. So this is our BPH. Remember, the BPH occurs at the periurethral zone. Very important. While the prostate cancer, yes sir, the prostate cancer occurs at peripheral zone. So these are the two another very important question. The BPH at the periurethral part, while the prostate cancer at the peripheral part. Now we are going to look the treatment for this BPH. Yes, because there is the obstruction of the urethra. Here is the location of the alpha receptor. So you will give the alpha blocker. What are the alpha blocker? Remember the our phenoxybenjamin and the phentolamine, but these are non-selective, so better to give the alpha 1 blocker. Which is the alpha 1 blocker? Your answer is the prazosin, but this prazosin is again blocking the alpha 1 receptor of the blood vessel, so there is the orthostatic hypotension first dose effect. That's why you are giving this prazosin at the bedtime, and you are starting with the low dose. So after the study, alpha 1a receptor has been observed here. So alpha 1a blocker tamsulosin is given. Yes, it is the best drug, and this prazosin, this our BPH occurs due to the hormonal imbalance. So you have to inhibit the synthesis of the testosterone. So you will combine with the 5 alpha reductase inhibitor. Yes, 5 alpha reductase inhibitor, that is our finasteride. Yes sir, there is a finasteride combination with the tamsulosin, which is the best drug treatment. But if it is not cured, in that situation we have to follow the surgery. Now integrating this prostate anatomy with the pharma medicine, now with the surgery, yes, this is the best approach. We are going through the our urethra. Yes sir, we are going through the urethra. So this is our transurethral and reaching up to the, yes, this is urine bladder. At the neck you can see the prostate gland. We are cutting the prostate gland from the inside. So this is a resection of prostate turp. You are looking in the computer and you are cutting the inner side of the prostate gland. So this is the best surgery. But remember, at that time the sphincter, internal urethral sphincter can be damaged. So after the surgery, patient may have the complication. The ejaculation is not going throughout the penis, but it is going upside in the urinary bladder. This is one complication of the TERP, that is our retrograde ejaculation. So these are the different integration with the anatomy. Now we are going to see the arterial supply of the pelvic viscera, very useful for the obs gynae and the surgery. You can see there is our common iliac artery, which is dividing into the extra iliac artery. It will go to the lower limb and it will make the femoral artery. So we are not talking regarding this one, but we have to see the common iliac artery. It is giving another division. This is internal iliac artery. Yes, it is dividing into the anterior division and posterior division. Remember, the posterior division, it will supply the posterior part. It is giving the 3 branches. What are the 3 branches? Yes, on the back side there is the ilium bone lumbar region. So first is iliolumbar artery. Second is our superior gluteal artery. Yes, here is a gluteal region. And third one, you will see there is a sacrum on the back side. So it is giving the sacral branches. You can remember one funny mnemonic to remember this all the things. Yes, that is our Sunny Leone mnemonic. You can remember the I love Salman. Also you can say Sunny, Sonakshi, Shahrukh, whatever you like. So I for the branches from the posterior division. I for you can remember the iliolumbar artery. L for you can remember the lateral sacral artery. S for you can remember the superior gluteal artery. MCQ had been asked earlier. Now, what are the different branches from the anterior division? You can see the anterior division is giving the branch. Yes, it is superior vesical artery. It is giving the branch. This is obturator artery, which is passing through the obturator foramen. It is giving the branch to the uterus, uterine artery. It is giving the branch to the lower part of the urinary bladder, inferior vesical artery. But remember, this inferior vesical artery is absent in the female because females are not having the long urethra, short urethra only is there. But in female, there is the uterine artery. Also, you will see there is presence of the vaginal artery. You will observe there is our middle rectal artery. Another branch is inferior gluteal artery. Another branch is internal pudendal artery. How you can remember? One diagrammatic presentation. We all know in our pelvic cavity, sir, there is the urinary bladder and then there is our urethra. Yes, in the males, the urethra is very long, and behind to it there is rectum and then anal canal, and here is location of the vagina and uterus. So just remember this pelvic viscera. Automatically you can say the branches of the anterior division. Yes, there is the superior vesical artery. It is a branch of the anterior division of internal iliac artery. Yes, inferior vesical artery, which is supplying the our urethra in the males. In female it is absent. Okay, also it will supply to the prostate gland. Yes, uterine artery and vaginal artery, these are also the branch from the anterior division of internal iliac artery. Then the superior rectal artery, middle rectal artery, inferior rectal artery, these are the three arteries of the our rectum. Surgery integration. But remember, this superior rectal artery was the branch from the inferior mesenteric artery, so don't count it. But the middle rectal artery, it is directly branched from the anterior division, and this inferior rectal artery is the branch from the internal pudendal artery, and this internal pudendal artery is the branch from the anterior division. So this pelvic viscera you have to remember, and you can easily crack the different MCQs from the obs gynae as well as from the surgery. Now in this pelvic viscera segment, we are going to see the female genital tract. You can see in the females, there is the ovary which is acting like the primary female sex organ. Yes, the ovulation occurs and the ovum is getting entry into the fallopian tube. Yes, now fallopian tube is opening within the uterus, which is having the dome-shaped part, fundus. Now this is the body of the uterus, and this narrow part is known as cervix, where you can see internal os and external os. This lower tube-like structure is vagina. So these are the different parts of the female genital tract. First, we are looking the uterine tube. Remember, this is our fallopian tube studied by the fallopian. Okay, so what is the length of the fallopian tube? You can see the 10 is written here. Don't show the 110, because if you will do the 110 centimeter, yes, uterine tube will come out from our abdominal cavity. So remember, the best answer is our 10 centimeter. What are the different parts of the uterine tube? You can see the infundibulum, yes, then ampulla, then third part is the narrow portion, isthmus, then last part which is within the our uterus, this is intrauterine part. MCQ, you will see the largest part, yes sir, as well as the longest part is ampulla. Remember, it is the site for the fertilization. Earlier the answer was the ampulla isthmic junction, but according to the recent update, you must know, sir, it is our ampulla. Now there is a isthmus and the intramural part. One question: sphincter, which is acting like the sphincter? So there are the two types of the sphincter. One is anatomical sphincter and another is our physiological sphincter. So two types of the sphincters are there. Remember, A for anatomical, so it is acting like, yes, which is the our anatomical sphincter? You can remember the mnemonic intrauterine part. So remember this AA. The intrauterine part of the fallopian tube, it is acting like the anatomical sphincter, while the physiological sphincter, so the our isthmus acts, isthmus of our uterine tube, it is acting like the physiological sphincter. So these questions had been asked, that's why we are discussing. Now we are looking for the more things. Sir, we had seen there is the fundus, yes, dome shaped part. Above the opening of the uterine tube, there is a body, and this narrow part is cervix, which is embedded within the vagina. Now each side of the uterus, you will see there is the condensation of the connective tissue. This is our broad ligament. You can see within this broad ligament there is the presence of the ovary. Yes, ovarian artery is also the content of the broad ligament. This ovarian artery is supplying the lateral one third of the fallopian tube, and it is anastomosing with the uterine artery, which is the branch from the anterior division of the interiliac artery. So this uterine tube, medial two-third part, is supplied by the uterine artery. Now look here, there is a close relation of the ureter. Yes, ureter is also located within the broad ligament. So remember this important anatomy, because if you are ligating the uterine artery during the surgery related to the uterus, ureter can be also ligated and complication will occur. So this anatomical point you must remember. Also the content of the our broad ligament, the connective tissue, the lymphatics, the nerve plexus, many things. Now look here, one important question. There are the angle formation in our uterus. Remember, it is just simple diagrammatic presentation. Uterus is never straight, but it is tilting over the urinary bladder in such kind of the way. So you all know here is the location of the urinary bladder, rectum and canal on the back side. Try to catch this point, sir. Here is location of the vagina, and within this vagina cervix is embedded, and here is our uterus body. So you can easily see the angle between the vagina and the cervix, it is 90 degree. So V for vagina, angle with the vagina is the angle of version, anti-version. And you can see this is our cervix and here is the body of the uterus. So angle between it is 170 degree, 160 degree. It is angle of the flexion, anti-flexion. So these are known as uterine axis. Try to understand. Suppose this vagina, cervix and uterus, they are remaining in the straight line. So whenever there is the increase in intra-abdominal pressure, this uterus will come out in between the two thigh, which is known as the prolapse of the uterus. Very important. Yes, there is the chances of the infection, and if not treated, death can occur. So read this all the points in your obs gynae anatomy integration. Now we are looking one another important relation. You can observe this is the superior view of the female genital tract. This is fundus of uterus. You can see ovary, the uterine tube, and this is a round ligament of the uterus. So these are situated on the lateral side. You can easily remember this mnemonic R. Okay. Yes, O for ovary and ovarian ligament. It is postero-inferiorly to the our uterine tube, and the round ligament of uterus is antero-inferiorly to the uterine tube. This round ligament of uterus is making round course around the inferior epigastric artery, and it is passing through the inguinal canal. Remember, the content of the inguinal canal you will learn in surgery, sir. That is our spermatic cord and ilioinguinal nerve with the root value L1, but this spermatic cord is replaced by our round ligament of uterus in females. So this is the important relation. Now we are going to look the pouch in female. Yes, at the lower part of the peritoneum, lower part of the abdomen within the peritoneum. So this is urinary bladder. Here is vagina and uterus, and this is rectum and anal canal. Agree, sir. Just one simple diagrammatic presentation. So the peritoneum is covering the urinary bladder from the superior surface in the female. Then it is covering the anterior surface of the uterus. Then it is going backside and reflecting over the rectum in such kind of the way. So you can see there are the two pouches in the female. Yes, this is known as in between the uterus and the vesicle. So this is uterovesical pouch. Correct, sir. And this fold of the peritoneum is known as uterovesical fold of the peritoneum. Agree? Now you can see this is a space between the uterus and the rectum. So you will say this is rectouterine pouch, sir. It is rectouterine pouch. It was studied by the Douglas. That's why it is also the pouch of Douglas. Remember, the most dependent part in female in erect posture is the rectouterine pouch of Douglas. So the pus, blood, they all are getting collected here in supine position. So what you will do, the clinical integration, yes, we will go with the per vaginal introduction of the our needle. We will puncture, then we will aspire, then we will inject the antibiotic. Okay, but in the males, this rectouterine pouch is replaced by the our yes rectovesical pouch. So remember this procedure, both are common in the male and female, but in female there is a uterus. The most dependent part is a rectouterine pouch. Don't mark the our uterovesical pouch. But when female is lying down, yes, in erect posture, the pouch of Douglas is most dependent part, but in supine posture, this collection is coming behind our, yes, you can say liver and in front of the kidney. Here is the location of the kidney. So there is another space known as the hepatorenal pouch, which was studied by the Morrison. So this is the Morrison's pouch. Yes, it is the most dependent part in female in a lying down position. Yes, remember the Morrison pouch. So these will be applicable in your obs gynae as well as surgery. Now we are looking the important topic, integration with your obs gynae, the support of the uterus. You can easily see primary support or major support. Another is our secondary support. Also, you can say the weak support. Yes, again, this primary support is divided into the two category, muscular or active support, and another is fibromuscular or mechanical support. Now observe here that what are the different important structure. You can remember one mnemonic, the PPU, pappu, you can remember. Yes, P for pelvic diaphragm is the primary support. Yes, muscular support. The perineal body having the attachment of the 10 muscles, it is muscular support. Also the urogenital diaphragm. So PPU is your very funny mnemonic. Now remember, Pappu is Putra. Yes, he is very great person of India. Just one funny things, don't take otherwise. We are going to learn the topic. That's why we are concentrating. Okay, what I want to tell you, Pappu is Putra of India. Yes, and we call Baba as the Babu, Sona as the Sonu. Here we are using the term Putra. Yes, we are converting this Putra term into the Putru. So what are the different structures? Yes, P for pubocervical ligament, U for uterosacral ligament, T for transverse cervical ligament. Also, you can say McEnroe ligament or cardinal ligament, and R for round ligament of uterus, and U for uterine axis. We had seen the round ligament and uterine axis previously. Now I'm going to tell you the pubocervical, our uterosacral, and transverse cervical ligament. Again, this is the diagrammatic presentation. On the front, you can see, sir, this is pubic symphysis anteriorly. At the posterior side, you can see sacrum and our ala part. Okay, now here is our urinary bladder. This is uterus or cervix, and this is rectum anal canal. So you can observe one ligament which is coming from the pubic symphysis attached to the uterus. So this is our pubocervical ligament. Yes, it is attached to the pubic symphysis to the cervix of the uterus. Okay, sir. Another ligament which is running transversely. So this is transverse cervical ligament studied by our McEnroe. That's why McEnroe ligament, you can say. Now this is our ligament which is attached between the uterus and the sacrum. So you will say this is our uterosacral ligament. So you can remember the PUT. R for round ligament of the uterus and U for uterine axis. So these are fibromechanical support. While what are the weak support, minor support? You can remember the Pappu is Suputra, Putru of India. Why? Because he is not drinking any other thing. He is drinking the good thing, and that good thing is BRU, brew coffee. So you can remember the funny mnemonic Pappu, yes, Putru, yes, brew. So this is the way how you can remember. Yes, B for broad ligament, it was the weak support. Yes, R for recto-uterine, also you can say recto-vaginal fold of the peritoneum, and U for utero-vesical fold of peritoneum, which we had seen during the learning of pouch of Douglas. Now, at the end of this session, few motivating lines. If it was easy, everyone do it. याद रखिए, आसान काम तो हर कोई कर लेगा, कठिन काम करके दिखाएं तो जाने. All the best. Hello dear friends, it is very difficult to maintain the six packs app, but remember, it is most difficult to maintain the family pack app. Yes, we are starting this abdomen session with this funny line, but it is great motivation lines too if you will think properly. So we are going to look this abdomen part. We will learn under the two part. Yes, abdominal cavity proper, then we will go for the pelvic cavity one by one. This abdominal wall, yes, you will see there is an anterior abdominal wall and there is the posterior abdominal wall. This anterior abdominal wall is very important because any kind of the gastro surgery, hepatobiliary surgery, intestinal surgery, even for the obs gynae surgery, you are making incision here. So one by one, step by step. First, I want to tell you there are the total 8 layers in the abdomen. So we are looking for the different 8 layers of the anterior abdominal wall. Definitely first layer is our skin, then next is superficial fascia. Remember, this superficial fascia is having superficial fatty layer and another one is our, yes, deep membranous layer. MCQ, the superficial fatty layer. It was studied by campers. That's why it is also known as the campers fascia. While the deep membranous layer, it was studied by the scarpa. That's why it is known as the scarpa's fascia. So these are the our two different MCQs. Remember, C comes first and then S in our alphabet. Now, the third layer is deep fascia. But remember, deep fascia is absent at the highly mobile part like the face, thorax and abdomen. So, deep fascia is absent here. So, the next layer is our muscle, external oblique, then you will see internal oblique, then you will see the transversus abdominis muscle. Once question had been asked, the neurovascular bundle is running where? Remember in FMG question, yes, the neurovascular bundle, they are running in between this our internal oblique and transversus abdominis muscle. This is the FMG 2021 MCQ. Okay, now after this fascia transversalis, you will see there, after this transversus abdominis muscle, you will see the fascia, that is fascia transversalis. Then you will observe the extra peritoneal fat, and then there is the layer of the peritoneum. So these are the our 8 layers. You must know these 8 layers. Why? Because if you are doing any surgery, you have to give incision layer by layer, and after the surgery you have to suture them layer by layer, so that we can avoid the chances of the incisional hernia. Very important integration with our surgery. Now look here, in our anterior abdominal wall, we all know from the physiology, there are the two vertical lines and there are the two horizontal lines which are dividing the anterior abdominal wall into the 9 quadrant. We know, yes, there is the our umbilical region, correct sir, above it epigastric, below it hypogastric. Yes, there are right and left hypochondrium, right and left lumbar region, right and left our iliac region, iliac fossa, correct sir. Remember the two vertical lines, they are passing through the our mid clavicular line, tip of the ninth costal cartilage and mid inguinal point. Okay, but right now the more frequently the questions are going to ask from the our horizontal line. This is the first horizontal line, which is the transpyloric plane, and here you can see the last horizontal line, which is the transtubercular plane. Yes, these are passing through which vertebra? Remember, the first line is passing through the first lumbar vertebra, and the last horizontal plane, it is passing through the last lumbar vertebra, means L1 and L5. So easy. Remember, these are friends, so they try to lie close together. Yes, so they are running through the lower border of the L1 and upper border of the L5. They are not passing through the upper border of the L1 or the lower border of the L5. What is your way? Remember, these are friends, so trying to lie together close. Okay, and one more question had been asked, just below the our hypochondrium, yes, just below the our ribs margin, this one more line is passing, it is passing below the ribs. That's why it is subcostal plane. Yes, you can easily remember 1 and 5, these are odd number, so this subcostal plane is passing through the another odd number in between 1 and 5, that is the 3. Yes, remember this another MCQ, that umbilicus, very very important question, definitely damn sure one question from the anterior abdominal wall, because of the umbilical, because of the umbilical hernia, because of the umbilical deformity, fecal fistula, urinary fistula, because of the incisional hernia, many important topics from this anterior abdominal wall. So one question show, this umbilicus had been asked. Yes, it is situated at the our which level? L3 L4 level. 1 MCQ. Remember, this L3 L4 is the same level where we perform the lumbar puncture on the back side, where there is the location of the iliac crest. So different 3 MCQs for all of you. Yes, in FMG exams, the fecal fistula and urinary fistula had been asked, and recent NEET PG 2023, again the uricus, the median umbilical ligament was asked, which was attached to the anterior abdominal wall. Okay, so what I want to tell you, sir, umbilicus is at the L3 L4 junction, so subcostal plane is not overlapping it. Yes, it is passing through the upper border of L3. So remember, this is the recent pattern. Don't forget it. It is very important. Now look here, we are going to look the different structures in our diagrammatic presentation. We are doing dissection, so you will remove the skin, superficial fascia, then deep fascia is absent, so muscle is observed. Can you see, this is the muscle which is running downward, forward, medially, means hands in the pocket in this direction. This is our external oblique muscle. You can see this external oblique muscle is getting insertion into the iliac crest, and this bony elevation is our ascis. Yes, anterior superior iliac spine. You can observe it is showing the flat tendinous part. This is our aponeurosis of external oblique, and it is showing the free margin between the ascis and our, here is the position of the pubic tubercle, not shown in this image. So this lower free margin of the external oblique aponeurosis is our inguinal ligament. Remember one MCQ in NEET PG exam, it had been asked the different modification of the external oblique muscle aponeurosis. You can remember the mnemonic LIP, sir. L for lacunar ligament, correct, sir? I for, you can remember the inguinal ligament is the modification of external oblique muscle, and P for, you can remember the pectineal ligament. These are our three different modification and important MCQ for the NEET PG exam. Okay, sir. Now we are cutting it and we can observe one another muscle. This is our internal oblique, which is making 90-degree with the, yes, our external oblique muscle. Now, when we are cutting the internal oblique, you can see the transverse running muscle. This is our transversus abdominis muscle. Yes, this all the muscles, they are making the aponeurosis, and then these are making, covering around the one muscle which is located at the midline. Can you see this midline muscle is running straight from the lower part pubic tubercle, okay, sir, pubic crest, and then it is going upside, it is getting insertion into the fifth, sixth rib, fifth, sixth and seventh rib at the midline. It is very long muscle in abdomen. Yes, sir, it is running straight, that's why rectus. In the abdomen, that's why abdominis. You can see here these muscles are showing the tendinous intersection. Yes, sir, these muscles are showing the tendinous intersections, that's why it is getting stability. Also remember the external oblique, internal oblique, transverse abdominis muscle, they are making aponeurosis. They are covering the rectus abdominis muscle at the center from the front and the back, and then these are showing the tight interdigitation. Do you remember I told you the interdigitation of the muscle fiber tendon or aponeurosis is known as raphe. So there is the formation of one very very strong raphe at the midline. Yes, sir, here is the very very strong raphe at the midline. This is our linea alba, and one another line at the peripheral part which is semilunar in shape. So this is our linea semilunaris. Remember these all the our surgical landmark, linea alba and linea semilunaris. Now we are looking this all the things in our cadaveric image. You can easily catch, sir, this is umbilicus. Remember this umbilicus is located at L3 L4 level, and the dermatome of this umbilicus is T10 segment. Yes, sir, it is important. Now look here, the fibers which are running downward, forward, medially, these are our external oblique, and here is our external oblique aponeurosis. You can see this midline interdigitation is our linea alba, and here is the presentation of the linea semilunaris. You can see the ASIS, anterior superior iliac spine, at the downside, and in between the anterior superior iliac spine and the pubic tubercle part, there is the attachment of the inguinal ligament. Yes, sir, this is our fold of the inguinal area, so there is the free lower margin of the extra oblique muscle. This is our inguinal ligament. Now look here, this is the lateral view. You can observe easily the umbilicus. So definitely it is anterior abdominal wall. Here is posterior abdominal wall. You can see the serrated appearing muscle. Sir, it is serratus anterior, one very big muscle from the our iliac crest at the back side. So this is the wide muscle, that's why lata. At the back, that's why dorsi. So this is the latissimus dorsi muscle. You can see from the lower part of the ribs, the muscle fibers, they are running downward, forward, medially. So definitely it is our external oblique muscle. Now you can see in another image, we are cutting the external oblique, we are removing it, and now you can observe here another muscle which is taking origin from the iliac crest, and then it is running just at the 90 degree to the extra oblique muscle. Definitely it is our internal oblique muscle. And in next image, you can see beautifully the muscle which is running straight from down to the above. Yes, it is the muscle which is responsible for the six packs ab. It is showing the tendinous intersections in between. So this is our rectus abdominis muscle. And one very small muscle you will see at the downside here, this is one muscle known as pyramidalis. Okay, so these are the points. This lower free margin is our area for the inguinal ligament. Now come to the our next part. This is your clinical importance. Always remember, you have to give incision layer by layer, and after the operation you have to suture them layer by layer to make proper strengthening to the anterior abdominal wall. If there is the weakness, you will get there is the chances of the incisional hernia. Try to avoid it. It is enemy for any surgeon. हाथ बांधे क्यों खड़े हो हादसों के सामने, हादसे भी कुछ नहीं है हौसलों के सामने. Now we are moving for the next part of this our abdomen. In this our rapid revision session, we are going to talk regarding the our peritoneum as well as peritoneal ligaments. Also you can say abdominal ligaments. Nowadays questions are surely asked from this topic. One by one, step by step. What is the peritoneum? Try to understand. It is our fibroelastic structure which is covering the our abdominal cavity from the inside as well as different abdominal viscera. Just like the pleura, just like the our pericardium, it is having the structure of the mesothelium which is secreting the thin serous watery fluid. Try to understand the concept of the peritoneum. Suppose this is our anterior abdominal wall and here is our posterior abdominal wall. Sir, this is anterior abdominal wall, here is posterior abdominal wall. Yes, the peritoneum is the fibroelastic membrane like structure which is covering the entire abdominal cavity at the very beginning of the human development in such kind of the way. Agree, sir? Now what happens, the git tube is starting to develop from here and then it is growing inside. So in the next step you will see the covering of this wall in such kind of the way. Yes, this is the our growth abdominal wall. You will see that git tube is developing slowly. So now the peritoneum is covering the anterior abdominal wall from inside, posterior abdominal wall from the inside, but here is reflecting over the viscera in such kind of the way. Getting the point? So now this peritoneum is showing the two layers, sir. This is a peripheral layer. Yes, it is our parietal peritoneum, and here you can see the layer of the peritoneum which is covering the viscera known as visceral peritoneum. So these are the two parts of the peritoneum. Correct, sir? You can observe that this git is dividing the our abdominal cavity into the two equal halves, but now there is a rotation of the git, so this is falling on one side. It is simple diagrammatic presentation. So you can observe the next step, sir. This is our anterior abdominal wall, here is posterior abdominal wall. Git has been rotated and it has been reached to the one side. So now the peritoneum, it is covering the our abdominal cavity from the inside. Agree, sir? Yes, it is covering the posterior abdominal wall from inside, but here is our, yes, you can observe this is the our fold of peritoneum which is now tilting at one side. Remember, this fold of the peritoneum is known as, yes sir, this fold of the peritoneum is known as meso. Yes. So you will see the fold of the peritoneum which is attached with the intestine known as mesoentry. Mesentery attached with the colon, mesocolon attached with the duodenum, mesoduodenum attached with the appendix. Yes, mesoappendix. So these are nothing, they are just fold of the peritoneum, the two layers of the peritoneum. You will listen many ligaments like the gastrosplenic ligament, lienorenal ligament, phrenicocholic ligament. These are nothing, they are just fold of the peritoneum. You will listen the word like the omentum, like the greater omentum, lesser omentum. They are nothing, the fold of the peritoneum which is attached to the stomach. Agree? Also one very beautiful concept, the different viscera, yes, the different arteries. Abdominal aorta is located on the posterior abdominal wall. It is sending the vessels and supplying the GIT. So these vessels are passing through the our, yes, fold of the peritoneum. So try to understand. Suppose there is the abnormal rotation of the GIT, abnormal rotation of the GIT, which is known as volvulus. What will happen to this? Our blood supply to the GIT, yes, it will also get twist, and the lumen of this artery will get blocked, and that's why there will be the ischemia. Yes, this abnormal rotation of the GIT is known as volvulus. Getting the point? Okay, beta. Now we are going to look one another concept. Sir, now the cavity in front of this viscera, GIT, is big. So the big cavity, suppose it is stomach. So the big cavity in front of the stomach, this is greater sac, and the small cavity behind the stomach is known as nasal sac. So you will see there is the one opening, one foramen which is communicating between the greater sac and the lesser sac. Yes, it is nothing, sir. This is our epiploic foramen. Yes, sir. It is our epiploic foramen. Also you can say the foramen of Winslow. Very important topic, frequently asked in your INICT, in your NEET PG, even in FMG exam, due to the Pringles maneuver, the surgical importance. Now further try to understand, sometimes this viscera is rotating too much and reaching to the close to the posterior abdominal wall. Okay, not all the part, only the few part. So how the peritoneum is covering? Yes, this is the our parietal peritoneum, this is posterior abdominal wall, and now it is covering the viscera from the front side. So this viscera is showing the location behind the peritoneum. Such kind of the viscera, they are known as a retroperitoneal structure. Few structures are located below the peritoneum, they are subperitoneal structures, and many structures are within the peritoneum, they are intraperitoneal structure. So remember the GIT viscera, sir. GIT viscera, on the basis of the peritoneum, you can divide into the three categories mainly: intraperitoneal, yes, retroperitoneal, yes, and subperitoneal structure. Yes, sir. Now look here, the retroperitoneal structure, one way to remember: kidney and related structure. In our detailed videos we had seen this all the things, but remember, kidney, above the kidney, suprarenal gland. Yes, these all are retroperitoneal. What is the arterial supply, venous drainage for the kidney? Sir, renal vein, renal artery, ureter. These all are retroperitoneal structure. You can solve now the surgery question. In surgery it has been asked that which is the most common organ getting retroperitoneal fibrosis. Retroperitoneal fibrosis, answer was the ureter. So you can catch that point from this anatomy point. Okay, also remember the renal vein is draining into the inferior vena cava, so it is also the retroperitoneal. There is the renal artery which is the branch from the abdominal aorta. So renal artery as well as abdominal aorta is retroperitoneal structure. Also the duodenum and pancreas, they are retroperitoneal. That's why the pain of this structure, especially the pancreas, it is felt on the back side. That's why in medicine, in surgery, you will see patient is lying on the bed, and this is known as frog sitting position, Mohammedan prayer sign, because it is retroperitoneal. So pain is felt on the backside, so patient is having the tendency to lean forward. Agree? So this is very interesting, integrating with the anatomy. Now look here, this is one diagrammatic presentation. Yes, in our GIT the peritoneum is getting obliterated, but the few part where the peritoneum is persisting. So you can see that Yes, here there is the presence of the peritoneum with the appendix. So this is our meso appendix, but this cecum, this ascending colon, these all are situated behind the peritoneum, so they are fixed. But transverse colon is showing the very big fold of the peritoneum. This is known as the transverse mesocolon. And in the similar way, descending colon is behind the peritoneum, so it is retroperitoneal. And rectum anal canal, they are also retroperitoneal, so they will not show the peristalsis, they are fixed. But can you observe the sigmoid colon is having the very wide attachment of the peritoneum, and there is our narrow base. So here I am showing you the demo. Sir, this is descending colon, then there is a sigmoid colon and the rectum anal canal. Try to understand. So sigmoid colon is showing the S-shaped fold, which is having the very narrow base and wide attachment. So along this narrow base, this our sigmoid colon is twisting abnormally, and we know the blood vessels are passing within this peritoneum, so these are getting blocked and ischemia. This abnormal rotation of the our sigmoid colon, this is known as volvulus, sigmoid volvulus. Remember this point? Yes, sigmoid colon is the most common site for the volvulus because it is loaded with the fecal material. It is having the narrow base, wide attachment, and very long fold of the peritoneum. This volvulus concept is clear only with the basics of the anatomy. And you know the small intestine is having the very long fold of the peritoneum. This is the mesoentry, mesentery. Now catch our different more points. Yes, this is the one diagrammatic presentation for the development of the GIT peritoneum part. Yes sir, suppose, yes, here is the posterior side, posterior abdominal wall. This is anterior side, anterior abdominal wall. Okay sir, you can observe the stomach is developing in our abdominal cavity at the center. Correct sir, here is the stomach. Now you can observe the peritoneum is covering this our abdominal wall on the front side. Agree sir, this is our peritoneum covering, this is our peritoneum. Yes, anterior abdominal wall, and here is our posterior abdominal wall, the peritoneum covering. Correct sir. Now the different viscera had been developed here, so the fold of the peritoneum which is attached to our stomach, what we will say? Yes sir, it is our meso means fold of peritoneum attached to the stomach, that's why gastrium. Yes, mesogastrium. Now try to catch this point. This fold of the peritoneum which is attached on the back side, that is known as dorsal mesogastrium, and the fold of peritoneum which is attached to the front side known as ventral mesogastrium. In short, we are saying this is our DMG, dorsal mesogastrium. This is ventral mesogastrium, VMG. Why I'm telling you? Because nowadays questions are asked from here with correlation to the our surgery, medicine, even with the our CT scan radiology. That's why we are talking regarding it. So remember, these are the our दिमाग and विमाग. You know, अक्सर हम दोस्ती में कहते हैं, अबे तेरे पास दिमाग विमाग है कि नहीं? Do you know what is this dimag vimag? Yes sir, here is the dimag, dorsal mesogastrium, and here is the vimag, ventral mesogastrium. Fine. Now see, there is a development of the liver. Hepatic bud is developing in the which structure? Sir, ventral mesogastrium. Old pattern MCQ. Now in our dorsal mesogastrium, sir, there is a development of the spleen. Correct sir, we are going to crack the recent pattern question on the basis of this old pattern question. So these are our different MCQs. In vimag, development of the liver. In dimag, development of the spleen. Now these developing structures, again they are dividing these ventral mesogastrium into the ventral part of the ventral mesogastrium, and this is the our dorsal part of the ventral mesogastrium. And in the similar way, developing spleen, it is dividing the dorsal mesogastrium into the ventral part of the dorsal mesogastrium, and here is the dorsal part of the ventral mesogastrium. Agree everybody? Now see here, there is the GIT rotation. Yes, due to the GIT rotation, you will see there is rotatory activity in such kind of the way. Okay, so the next presentation, can you observe here? Yes sir, at the back side there is our abdominal aorta which is giving the branches to the retroperitoneal structure kidney, and it is giving the branches to the different GIT viscera. Okay sir, we will see. But here is the stomach. Correct, sir. The ventral mesogastrium was on the front and the dorsal mesogastrium on the back side, but now it has been rotated. So there is a twist. Now see, there is the our ventral mesogastrium showing the ventral part. This ventral part of the ventral mesogastrium is making the falciform ligament. Yes, sir. And this is the our dorsal part of the ventral mesogastrium, which is attached in between the liver and stomach. Yes, it is our laser omentum. Getting the point? So this is the MCQ in your NEET PG recent 2021. There was the one image and there was the arrow over the falciform ligament ABCD, and they asked about the identify structure. So this was our falciform ligament. And remember, these all are old question pattern which are now asked in image based or clinical pattern. Okay, so what you have to remember, this laser omentum is developing from what structure? Answer is, sir, it is developing from the dorsal part of ventral mesogastrium. Also you can see this is our, yes, ventral part of dorsal mesogastrium, which is making the ligament between stomach and spleen. So this is our gastrosplenic ligament, and you can see here is our spleen. Okay, so backside there is one ligament between the spleen and kidney. So this is known as linorenal ligament. So now I want to discuss with you one recent FMG 2023 question. Yes, FMG 2023 question, that in case of the splenectomy operation, correct, sir, which artery you will ligate? So definitely you will ligate the splenic artery. But now catch this point, there was the clinical case, splenic trauma, bleeding, patient is going under the shock, ABCD, such kind of the image was there, ABCD was there. You will ligate which structure? Okay, so you can crack with the help of anatomy, sir. This is our spleen. Spleen is supplied by the splenic artery, which is coming from the backside from the our aorta, from the celiac trunk. So definitely you will ligate this artery. Okay, and this artery is running in between the peritoneal fold, which is running between the kidney. Yes, sir, here is the kidney, between the kidney and our, yes, spleen. So this is our linorenal ligament. So this linorenal ligament was your answer. It had been shown in image ABCD was pointed. Agree? Now look here, the next image. You can easily see, observe, this is the basics of the CT-MRI of the abdomen part. You can observe here, this is our posterior abdominal wall, here is anterior abdominal wall. You can see the vertebra at the back side, and here is, yes, our spine and the different portion. Now observe here, at the center you can see the stomach. Correct, sir. On the right side you can see the liver, and on the left side you can see the spleen. Okay, sir. You are observing the ventral part of the ventral mesogastrium. It is falciform ligament. You can observe ventral part of the dorsal mesogastrium, which is making the gastrosplenic ligament. You can see the our dorsal part of the dorsal mesogastrium, it is making the linorenal ligament. And the abdominal aorta, it is giving the splenic artery, and this splenic artery is giving the branch to the stomach. Yes, it is our short gastric artery. So this is the old question pattern, that short gastric arteries, they are running within the our gastrosplenic ligament fold of the peritoneum. Okay, and now in front of the stomach you can see one very very big cavity. This big cavity is nothing, this is our greater sac, and there is the location of the small cavity behind the stomach. Sir, this is the laser sac. So you can observe the communication between the greater sac to the laser sac. This is our epiploic foramen, foramen of Winslow. You can observe in front of this foramen of Winslow, sir, there is the location of the portal vein, yes, hepatic artery and the bile duct. So this is one classical finding which we are going to discuss. The anterior boundary of this foramen of Winslow, it is formed by the VAD, V for vein, A for artery, D for duct. Okay, portal vein, hepatic artery and the bile duct. While the posterior side, you can see there is the location of the big vein. This is the big vein close to the abdominal aorta. So this is inferior vena cava. This is, yes, abdominal aorta. This is our thoracic vertebra. We will see. Now Look here, one beautiful integration, the boundaries of the epiploic foramen. Okay, but to understand this boundaries of the epiploic foramen, better to go with the our surgery. So try to understand, this is the one procedure in your surgery known as Pringle's maneuver. You can easily catch, sir, this is our esophagus, and here is the greater curvature of the stomach. Here is the laser curvature of the stomach, which is continuing as the duodenum. Yes, first part of the duodenum, second part of the duodenum, third part, and the fourth part. Along the laser curvature of the stomach, there is location of the laser omentum. Along the greater curvature of the stomach, there is attachment of the greater omentum. Yes, sir. Here is our liver. So try to catch this point. If we are doing the hepatobiliary surgery, at that time it is very important to ligate the important structures for the liver. They are VAD. Yes, these are our portal vein, hepatic artery, and the bile duct. Remember, these portal vein and hepatic artery and bile duct, these are running within the free margin of this laser omentum. Agree? Now catch this point. There is the free margin of laser omentum. So during the surgery, what you can do? You can insert the index finger behind it and you can put the thumb above it. And when you are compressing this free margin of laser omentum, you are compressing the portal vein, hepatic artery, and the bile duct. So now you can perform the surgery for the very long time. It is the same kind of the image. Yes, here you can observe the stomach and the duodenum. Here you can see the liver, and this is the free margin of laser omentum where you can see the vein, artery, and the duct. So you are inserting the finger behind this free margin of laser omentum, putting the thumb above, and you can compress this all the structures. Getting the point? So this is the finger which is going where? Try to catch. This is the stomach. In front of the stomach, yes, there is the big cavity, greater sac. Behind the stomach, there is the small cavity known as laser sac. And your finger is going from greater sac to the laser sac. Getting the point? Yes, your finger is going from the greater sac to the laser sac and you're compressing it. So this is nothing. This is the communication between the greater sac and the laser sac. And I told you already, the communication between the greater sac and the laser sac, greater sac to the laser sac, this is the epiploic foramen of foramen Winslow. So with the help of this surgical procedure, which is known as the Pringle's maneuver, used for the hepatobiliary surgery, you can easily say what are the different boundaries of the foramen of Winslow. Yes, sir. Here is our foramen of Winslow. The superior boundary is formed by liver. Okay, sir. In the liver, there is a caudate lobe, caudate process. That is the best answer. But liver also you can remember. Yes, stomach is continuing as the first part, second part, third part. So lower boundaries formed by the first part of the duodenum, D1. MCQ. And the anterior margin, entry boundary of this free margin of laser omentum, sir, it is formed by, yes, the entry boundary is formed by the entry boundary of the epiploic foramen. It is formed by the free margin of the laser omentum. Getting the point? Where you will see the vein, artery, duct, and posterior boundary, it is not visible here. So now catch this image from your anatomy. It will be very easy after learning the surgery. Yes, this is our epiploic foramen. Yes, sir. This is our foramen of Winslow. The superior boundary is formed by the caudate lobe or caudate process. Inferior boundary is formed by the first part of the duodenum. Yes, entry boundary is formed by the vein, artery, duct, which are within the free margin of laser omentum, and the posterior boundary is formed by the suprarenal gland, inferior vena cava, and T12 vertebra. Yes, I will tell you the first part of the duodenum is located at the L1, D1 at L1, D2 at L2, D3 at L3. I will tell you later. So obviously with the common sense you can say, sir, the foramen of Winslow is above the D1. So it is located above the L1. So this is again your question from the NEET PG old pattern. The same question pattern is nowadays asked, but in a new way. Okay. Now catch this very interesting point. We are going to integrate with our radiology sonography. In case of the portal hypertension, you will see there is enlargement of the portal vein. Yes, and we had seen right now there is the close relation with the our, yes, hepatic artery and the bile duct. So if there is the portal hypertension, yes, these are the structures within the our, yes sir, you can say these all are the structures, these all are the content of the our free margin of the laser omentum. You can see this one, yes, there is a portal vein, hepatic artery and the bile duct. Now if there is a portal hypertension commonly seen in case of the cirrhosis, then these structures are getting enlarged, yes, direction is changed, fine. So the portal vein, you can see the hepatic artery, you can see the bile duct, gallbladder and the liver, inferior vena cava, aorta. Yes, you will see in the radiology one beautiful integration. But if there is a portal hypertension, it is just appearing like the face of the Mickey Mouse, which is known as the Mickey Mouse sign. Neat PG question. So portal vein, you can observe, you can do imagination, hepatic artery and the bile duct. Okay, so this is the our Mickey Mouse sign, which is not the hallmark, it is not the signature, it is found at the many side. Yes, you will see this situation in midbrain of progressive supranuclear palsy. In this progressive supranuclear palsy situation, you will see this condition. Yes, where you will learn this Mickey Mouse sign, you will learn in the portal triad of the portal hypertension, midbrain of, yes, progressive supranuclear palsy of the midbrain. You will see in the polyostotic Puget's disease also the Mickey Mouse sign is also found in bilateral inguinal vesicle hernia. You will see this situation in dysmorphic Mickey Mouse RBCs, hematology integration and uretropelvic junction obstruction also you will see. So just one beautiful integration so that you can remember these different things. Also in your NEET PG exam 2021 question had been asked, the development of the spleen is not downward but it is growing towards the umbilicus and from the umbilicus towards the right iliac fossa. Yes, this is the direction of the splenomegaly. Why I'm telling you? Because again, one topic, one question from the anterior abdominal wall or the peritoneal ligament is sure. Okay, you can see this is our diaphragm. Here is our splenic flexor near the spleen. So there is a one ligament between the diaphragm and the colon. This is phrenicocholic ligament. It is making one slopy structure. So spleen is not able to grow downside. Yes, it is not able to grow downside. So this spleen is making a slope along this our phrenicocholic ligament and it is showing the splenomegaly towards the from the left hypochondrium towards the umbilicus, from the umbilicus region towards the right iliac fossa. So these are the points which you have to remember for the rapid revision point of view. Now remember, be loyal to your future, not your past. With this positive lines, we are moving for the next. After the completion of the pharyngeal apparatus topic, now we are going to look the general embryology and the few topics which are recently asked in your exam. So try to understand. We all know regarding the spermatogenesis and the oogenesis. Agree, sir? So after the oogenesis, ovum is coming out through the ovary, that is ovulation. Fine. Now there is the movement in the fimbria part. So this ovum is taken within the our fallopian tube in fundibulum part. Suppose ovum is outside, then sperm is making entry from the cervix and it is coming inside the our peritoneal cavity. And if fertilization occurs within the peritoneal cavity, then it is classical example of the ectopic pregnancy, obs gyne integration. Now see, this is our ovum. Sperm is coming through the uterine cavity and it is making the fertilization in which part? Remember, ampulla. Ampulla is the best answer. So there is the one cell stage is formed. This one cell stage is known as our zygote. Correct, sir? So this is our zygote. Now it will divide rapidly. One cell stage to two cell, 2 to 4, 4 to it is changing into the 16 cell stage. Yes, 2, then 4, then 8, 8 to 16 cell stage. This 16 cell stage is known as morula, solid ball like structure. Yes, it is formed on the third day. MCQ. Now another MCQ, one recent update after it is converting into the 32 cell solid ball like structure which is known as advanced morula stage. Getting the point? Okay, so this is the one recent update. After it, there is the imbibition of the uterine fluid and there is a formation of the cavity. So it is the cell with the immature cell. So you will say blast and it is presenting the cavity. That's why cyst term you will use. So this mass is known as blastocyst, which is formed on which day? Answer is fourth day. MCQ. Now this all the cells, they are getting aggregation at one pole. These are known as inner cell mass. Yes sir. And the remaining cells which are outside, that are known as outer cell mass. Once MCQ had been asked, this outer cell mass is responsible for the nutrition of inner cell mass. That's why it is known as the trophoblast. Tropho means nutrition, you can say. Now on the sixth day, MCQ, implantation occurs from 6th to 10th or 12th day. Getting the point? So remember, this is our implantation within the uterine cavity. Now the different kind of the changes are starting. In short and sweet way, you can observe after the implantation, too much rapid metabolic activities, cell division activities are there. Yes, remember the trophoblast will convert into the syn cytotrophoblast and trophoblast, while the inner cell mass, yes, this inner cell mass, it will make the true embryo. So try to catch this point. Sir, there is the aggregation of the cells, and within the cell you will observe, suppose this is our outer cell mass, and inner cell mass is presenting the group aggregation at one corner. Now this inner cell mass, it is converting into the columnar cells, which are known as epiblast cells. So according to the new concept, yes, these are the columnar cells, epiblast cell, which will present a nucleus. I'm not drawing the nucleus. Now this epiblast cell, they will make one new cell line, which is initially flat squamous but later becomes cuboidal. So this is our hypoblast cell. Now this hypoblast cell, it will change into the endoderm. MCQ, which is the first germ cell layer to be formed? Answer is endoderm. Getting the point? Yes sir. Here is epiblast, which is making the hypoblast, and this hypoblast is giving origin to the, yes, it is converting into the endoderm. Then later this endodermal cells, they are proliferating and making one membrane. This is our, yes, Husser's membrane, and this cavity of this endoderm is known as primitive yolk sac, which will form the our GIT later. Agree sir? Now try to understand. We are going to focus for this our epiblast cells. Yes, it will show further division and it will make one new cell line. So epiblast cells, sir, these are columnar in appearance, while the endoderm, they are cuboidal in appearance, making the, yes, Husser's membrane, and the cavity is our primitive yolk sac. Now this epiblast is making one more cells just opposite to the endoderm, which is known as amniogenic cells. Getting the point? And there are now new cavities formed. This new cavity, which is in between the epiblast, and here is our endoderm. So in between the epiblast cell and amniogenic cell, the cavity is there. This is known as amniotic cavity. Now this our amniogenic cell and remaining all are responsible to give the nutrition to these layer, the epiblast and endoderm. We are going to focus for this because it is going to make the true embryo. So true embryo is formed by the epiblast cells and endoderm, epiblast and hypoblast, you can say. Okay. And now it is having the appearance, which is having the two cavity. In obs-gyne, in ultrasonography, in radiology, you will see one term, that is a coffee bean sign, which is presenting the our pregnancy condition having the appearance of the zygote with the two cavities, coffee bean sign. Now look here, this is one appearance. The blue color is our epiblast and this yellow color is endoderm. Okay sir, so we can observe this is our rapidly dividing cells after implantation. I told you the epiblast, yes sir, and here is the endoderm. The cavity of the epiblast, you can say amniotic cavity. The cavity of the endoderm, you can say yolk sac. Rapid division, yes. Now we are cutting it, so you can see this is our bilaminar disc. Correct sir? It is just having the appearance just like the one disc, which is having the two layers, bilamina. So MCQ, on which day this bilaminar disc is formed? Remember, B for bilaminar, just hold it and stretch it, you will get, sir, it is 8 in appearance. Now you are cutting it, you are enlarging it, so you can see there is the upper layer, there is the lower layer. So you can remember, sir, this is our epiblast, here is our hypoblast. Hypoblast is converting into the endoderm. Agree sir? Now there is a rapid proliferation by our hypoblast cells, and they are making one rounded elevation. Yes, sir. This rounded elevation is plate like this is known as procaudal plate. Yes, MCQ. Procaudal plate is derivative of which structure? Answer is the hypoblast. Remember, this procaudal plate, it will decide the head end of the embryo. Yes, this is responsible for the craniocaudal axis formation. Getting the point? The craniocaudal axis is formed by which structure? Answer is the procaudal plate. And just opposite to it, yes, the epiblast cells, they are proliferating and they are making one line, one linear structure. Correct, sir? Which is streak-like in appearance. Yes, sir. So this is at the very primitive of the age. That's why it is known as simply the primitive streak. Remember, this primitive streak is derivative of what? Remember, sir, it is derivative of the epiblast. Now, catch this point. This primitive streak is responsible for the decision of the right and left half of the baby. So, craniocaudal axis is decided by the procaudal plate, but right and left side is decided by this primitive streak. Agree? Now, catch this point. We are looking the same bilaminar disc layer from the above. Yes, sir. This is our view. So you can see the procaudal plate, you can see the primitive streak. Now we are going to cut the embryo at the level of the primitive streak. So definitely at this section, this procaudal plate will not be visible. And now we are observing this bilaminar disc from the downside. So it is appearing in such kind of the way. Yes, sir. These columnar cells are epiblast. These lower side cells are hypoblast, which is converting the endoderm. So first germ cell layer which is formed, endoderm. But now this primitive streak is getting angry and it is making one new cell layer which is proliferating, which is developing in between these two layers, epiblast and endoderm. So this red color structure which is spreading, which is getting sandwiched between the endoderm and our epiblast cells, that is nothing, that is a mesoderm. So remember, the second germ cell layer which is getting formed, that is our mesoderm. And then at the last, the remaining epiblast cell, they are converting into the ectoderm. So this is the thing, how all the germ cell layer are formed. Remember, the first germ cell layer which is formed, that is endoderm, then mesoderm, and then there is the ectoderm. This is the recent concept. Earlier there was the concept of first ectoderm, then mesoderm, and then last layer was the endoderm. But now you have to follow this new our concept, endoderm, then mesoderm, then ectoderm. So this is the correct sequence according to the recent concept. Now we are having the embryonic structure which is presenting the three layers. Yes, this is known as the gastrulation. Fine. So we are presenting the ectoderm with the blue color, and then there is the our mesoderm which we are presenting with the red color, and here is our, yes, you can say endoderm which we are presenting with the yellow color. There are the lots of changes and one cord like structure is developing within the mesoderm. So you will say, sir, within the mesoderm one cord like structure is developing. This is our notochord. So again, labeling for all of you, this is the formation of the three germ cell layer which is also known as the gastrulation. Sir, the blue color is ectoderm, the red color is mesoderm, and this yellow color is endoderm. Yes, this green color structure is showing the very primitive structure known as notochord. Remember, this notochord disappear, but one embryonic structure which is persisting within the intervertebral disc, that is nucleus pulposus. Frequently asked question, this nucleus pulposus is very important. Now this mesoderm is dividing into the three different part. What are this? You can remember, you can see in this image. Sir, this is our ectoderm, and the mesoderm will show three divisions. We are going to show in this image. Suppose this is the mesoderm, and here is the yellow color structure, endoderm. This is our cord, notochord. Yes, what are the three different divisions of our mesoderm? One part which is lateral side and making plate like structure. Yes, we will say lateral plate mesoderm. Another part of the mesoderm which is just close to the axis, this is around the axis, so you will say para-axial mesoderm, and another mesoderm which is in between both, that is intermediate in position. So you will say yes, intermediate mesoderm. So what are the different terminology you can easily catch? Sir, this is lateral side, so lateral plate mesoderm. Yes, it is in between, that's why intermediate mesoderm. And here is our para-axial mesoderm. So you can remember one funny mnemonic, LIP. Lip is your sequence. So this is the way how you can remember LIP. L for lateral plate mesoderm, I for intermediate mesoderm, and P for para-axial mesoderm. Now catch this point. We are just completing the important things which you have to remember. Sir, LIP. Okay. So P for our para-axial mesoderm. This para-axial mesoderm, it will show the segmentation and it is making the somites. Remember, these somites are present just close to the axis. So in the embryo, around the axis, the segmented structure, they are nothing, they are our vertebral column. So yes, you can easily remember these somites will make division and it will create the three structures. Important points only. Yes, hard structure is known as sclerotome. Yes, the soft structure which are making the muscle known as myotome, and over the muscle there is the skin, so you can remember the dermatome. Catching the point? Sclero means hard, means it will make the bone. Myo means muscle, and derma, yes, it is the part of the skin, dermis. Remember this sclerotome, these somites, they are located at the central part. Yes, so these sclerotome, they are making the segmented structure at the axis. Sir, these are making the vertebral column and the ribs. Okay. Yes, myotome, they are making the axial muscles around this vertebral column and the ribs, and dermatome, they are making the axial dermis. You can remember the axial dermis which are around the axial muscle, and axial muscles, these are around the our vertebral column and the ribs. इतना कम से कम आपको जरूर 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 याद रखना है. Getting the point? Do you remember the occipital? These somites are spreaded from the cervical region, from the occipital region to the sacrum coccyx. So you can remember there are the occipital somites, then cervical somites, then thoracic somites, then our lumbar somites, and then sacral and coccygeal somites. Getting the point? I told you one point during the development of the tongue, sir, our occipital somites, also you can say occipital myotomes. The nerve is 12th cranial nerve. It migrates within the tongue part and it is making the muscles of the tongue. So that's why all the muscles of the tongue, they are supplied by which nerve? Answer is 12th cranial nerve, except palatoglossus, which is derivative of the fourth arch. So it is supplied by the nerve of the fourth arch, that is a vagus nerve, vago-accessory complex, better to say pharyngeal complex. Now come to here, we are going to talk regarding our lateral plate mesoderm. So this is our lateral plate mesoderm. It will make, you can make easy, it will make the lateral side. Yes, it is making the lateral, also you can say appendicular. Yes sir, it is making the appendicular skeleton. Yes sir, the limbs, humerus, radius, ulna, these all bones are formed by the lateral plate mesoderm, as well as the muscles around these limbs, they are created by the lateral plate mesoderm. Also you can say the dermis part. Okay, this is sufficient, the question is not going to ask, just to correlate. But now see here, this is our intermediate mesoderm. Sir, here is our intermediate mesoderm. Nowadays very less questions are asked from here, so just for the quick revision I am going to tell you few points so that you can recall for your different other subjects also. This intermediate mesoderm, it is dividing into the four structure. You can remember one mnemonic, x ने pg किया. ओके, सो वन फनी थिंग, एक्स ने पीजी किया और हम वहीं पर लटके रहे, अभी भी हम नीट पीजी एफएमजी की तैयारी कर रहे हैं. वन फनी वे यू कैन रिमेंबर, व्हाट इज द फुल फॉर्म ऑफ दिस एक्स ने पीजी किया? यस, इंटरमीडिएट मेसोडर्म, इट इज मेकिंग द excretory tubule. N for you can remember the nephric cord, P for you can remember paramesonephric duct, and G for you can remember the gonads. Okay sir, now catch this point, this excretory tubule, it will make the holonephros. Nephros means yes, kidney part. Now this holonephros, it will divide into the pronephros, mesonephros, and metanephros. Getting the point? Yes, in our 12th standard, we were reading this pronephros and mesonephros. They are making the kidney in the birds, in the avian, but not in the human. Yes, this metanephros, it will convert into the metanephric blastema. Agree, sir. And this structure, metanephric blastema, is going to create the tissues for the kidney. Remember this metanephric blastema, this was the question, very old pattern was asked. This metanephric blastema is responsible for the formation of the excretory part of kidney. So if we are talking regarding the nephron, what are the excretory part of the kidney? You can remember, sir, there are the parts like the our Bowman's capsule, PCT. Yes, then you can say, sir, Henle loop, and then you can say the DCT. These all are participating in the formation of the urine, excretion of the urine. So these are derivative of the metanephric blastema. Yes, what you can remember, sir? Glomeruli, Bowman's capsule. Second is our PCT. Third is Henle loop, and fourth is DCT. These are derivative of the mesoderm, excretory part coming from the intermediate mesoderm. While remember another thing, sir, nephric cord. This nephric cord will convert into the mesonephric duct. Remember one thing, this mesonephric duct, it will participate in formation of the male genital tract. This is also known as Wolffian's duct. Getting the point? This is very important MCQ for the male genitourinary system development. But this paramesonephric duct, sir, it is developing the female genital tract. Getting the point? It is also known as the Mullerian duct. You will see in your ops gynae. Okay, so these are the MCQs. Remember the Mullerian duct, yes. The Wolffian duct, yes. Wolf, who are wolf? Males are wolf. So Wolffian duct, male genital tract. The Mullerian duct, it is responsible for the female genital tract development. So what are the different parts of the male genital tract? You will say testis. But remember the intermediate mesoderm, it is making the gonads. This gonads is making the testis in male, while ovary in female. At least this point you have to remember. More things you will see in respective their subject, but this is the point. Gonads are developing from the mesoderm, intermediate mesoderm, while the paramesonephric duct, it is making the female genital tract. Yes, can you tell me this male genital tract, sir? There is the testis, but testis is formed by the gonads. Okay, so what are the remaining things above the testis? You will say epididymis. Correct, sir. After the epididymis, there is the ductus deferens. Correct, sir. Ductus deferens is carrying the sperm to our, yes, it is uniting with the seminal vesicle. So you can remember the seminal vesicle, and this ductus deferens and seminal vesicle both are uniting and making the ejaculatory duct. So these all are derivative. Yes, this epididymis, ductus deferens, seminal vesicle, ejaculatory duct, these all are derivative of the what? Answer is the mesonephric duct. Okay, minimum these points you have to remember for the rapid revision. Now look here, this mesonephric duct, sir, it is one duct like structure. Okay, sir, suppose this is the duct like structure. Now catch this point, at the lower part there is the development of the one bud. Yes, sir. This is our mesonephric duct. One bud is formed. This is known as ureteric bud. Remember, this ureteric bud is responsible for the formation of collecting part of kidney. Agree? Yes. Urologic concept, we are going to understand the concept of the polycystic kidney disease and many congenital disorder. This ureteric bud will join to the remaining portion of our kidney developing part, and it will collect the urine which is excreted, which is formed by the our, yes, Henle loop, DCT, so on. So it is making the part. What are the different parts, sir? It is making the collecting duct first, then urine will go to the minor calyces second, then the urine will go to the major calyces third, then urine will go to the pelvis, and then urine will go to the ureter. So these all are the excretory, these all are the collecting part of the kidney. They are collecting the urine and carrying them into the urinary bladder. So there is a proper development of the one nephron and the collection of the nephron, that is nothing our kidney. And remember, later these both parts are getting fused, and the membrane in between it is getting abolished. So urine is formed and it is passing to the our, yes, excretory part, and this mesonephric duct, it will open into the urinary bladder. Okay sir, fine. But suppose if both are not properly fusing, so there is the septa. Now urine is formed but it is not passing into the other, so the urine is getting accumulation, and there is the formation of the cyst, formation of the cavity. Okay, can you catch this point? So there are the billions of the nephron in each kidney, and there is a formation of the multiple cyst within the kidney. This is nothing, this is our polycystic kidney disease, which is having the two types, pckd1, pckd2. So study this all the things in your pedia, medicine and surgery. Yes, but the concept is coming from your embryology anatomy part. So this is the short and sweet discussion regarding the development of different structure. Now nowadays the questions are asked from the CNS and CVS sometimes. So just one quick view for CNS and the CVS development. In very simple way, we are going to learn the CNS development. Try to catch this point. We all know the three germ cell layer of the body, sir: ectoderm, then mesoderm, and then endoderm. Correct, sir. You can observe there is a cord like structure, notochord, and these are our three divisions of the mesoderm. You can remember the LIP: lateral plate mesoderm, intermediate mesoderm, and paraxial mesoderm. Now catch this point. First, due to the effect of this notochord, there is the thickening of ectoderm just opposite to the notochord, and this portion is making the neuroectoderm, and this thickened plate like structure is known as the neural plate. The remaining portion is known as surface ectoderm. Yes sir, this is our neuroectoderm which will make the neural plate. Okay, now what happens, this is our neural plate like structure. One demo for all of you. Then it is showing the groove, so this is the neural groove. Agree sir? Now each corner of the neural groove, they are meeting together, and now it is making the tube like structure, neural tube, which is having the opening on the front superior side. Sir, this is anterior neuropore which closes on the 25th day, and here is the another opening downside. Sir, this is the posterior neuropore which closes on the 28th day. This neural tube formation is known as neurulation, for which there is the presence of vitamin B9 folic acid is must. Yes, so this is the topic of the biochemistry of the anatomy, neural tube formation, neurulation. Yes, there is the presence of our vitamin B9 before the pregnancy. You have to start. So it is a topic of the obs gynae. If there is a no formation of the proper neural tube, this is the neural tube defect, which is the topic of your surgery, as well as many anti-epileptic drugs from the pharmacology and the medicine. You will see they will cause the neural tube defect, spina bifida, anencephaly, this all. So yes, this is multiple subject integration topic. So definitely one question is going to ask from here from any related subject. So what I want to tell you, sir, there is our short and sweet notes for all of you. Sir, there is the our formation of ectoderm dividing into the neuroectoderm and surface ectoderm. This surface ectoderm, it will make the epidermis. Remember that dermis part was formed by our, yes, dermatome, but epidermis is formed by the surface ectoderm. This neuroectoderm is making the neural plate, then it is making the neural groove, then neural groove is making the neural tube. Correct? Yes, there is formation of the neural plate. Okay sir, then it is showing the neural groove formation, and then both the parts are joining together and it is converting to the neural tube. Remember, during the formation of the neural groove, at the corner there is the aggregation of the very special kind of cells. Try to understand, whenever the center part is getting depressed, The corners are getting elevation, and elevation is known as crest. Yes sir, these are our crest. So the cells within this crest like structure, you will say crest cells, because these are developing from the neural element. So you will say, sir, these are our neural crest cells, which are considered as fourth germ cell layer, because they gives rise to the very specific structure in our body. Okay, so these are our neural plate, neural groove, neural tube. Later, when there is the formation of the neural tube, you will see neural crest cells, they are located dorsolaterally, very close to the neural tube. Now what I want to tell you, sir, neural tube, it is tubular structure, simple diagrammatic presentation. Remember, this neural tube is having the two opening, you can say anterior neuropore, and here is our posterior neuropore. Remember, anterior neuropore, it is closing on the 25th day, and this posterior neuropore is closing on the 28th day. MCQs. Okay, now remember, there is the requirement of the vitamin B9 for this entire process. And if there is failure of the neural tube, anterior neuropore closure is not normal, then there is the anterior neuropore defect, which is also classically known as the anencephaly. And if there is a failure of the closure of the posterior neuropore, the baby will present with the mass abnormality on the back side at the lower side. This is our posterior neuropore defect. You all know the meningocele. Yes, you will see the spina bifida occulta, meningocele, meningomyelocele. If there is the non-fusion total opening, then that is our rachis or myeloschisis. So focus for this all the points with the few diagrammatic presentation. Sir, this is our neural tube. Now what happens, the cranial part of the neural tube, it is showing the dilatation, it will make the brain, while the caudal part, it will remain narrow, it will make the spinal cord. So you can see the cranial part is showing the 1 2 3 dilatation. These are nothing, these are the forebrain, midbrain and hindbrain. Old PGI pattern question, which is now INICT, how many primary brain vesicles are there? Answer was the 3 primary brain vesicle. Okay sir, now this primary vesicles are converting to the 5 secondary brain vesicles. Yes, this was another MCQ from the PGI Chandigarh INICT. This forebrain, also you can say prosencephalon, it is making the telencephalon and diencephalon. The midbrain alone, it is making the mesencephalon, while the hindbrain, it is making the metencephalon and myelencephalon. Now you will see this telencephalon is making the most developed part of our brain, that is cerebral hemisphere, while the diencephalon, it will make the thalamus, hypothalamus, metathalamus, epithalamus, subthalamus, this all. Yes, midbrain, mesencephalon, it is only making the smallest part of our brain, that is a midbrain. Yes, while the metencephalon, it is making the pons and the cerebellum, and the myelencephalon, it is making the medulla oblongata. The caudal part of the neural tube, it remains narrow and making the spinal cord, and each part will show the cavity. So the cavity of the cerebral hemisphere, MCQ, lateral ventricle, cavity of the diencephalon, third ventricle. Yes, cavity of the midbrain, cerebral aqueduct of Sylvius, cavity of the hindbrain, you can say fourth ventricle, and the cavity of the spinal cord, central canal. So this diagram, this development of the CNS will help you for the identification of the different diseases in your different subjects. Now look here, this diagrammatic presentation. On the 28th day, the fusion first occurs at the cervical region. This is another MCQ. Yes, neural tube fusion first occurs where? Remember, there is a multiple fusion theory, but one answer you have to opt. Best answer will be the cervical region. You can see there is the anterior neuropore and posterior neuropore. So this neural tube is getting close, and these are segmented structure known as somites. And ultimately, there is a full closure on the 28th day. All the our pores are getting closed. Now catch this point. This is our radiological images with the help of this our sonography process. Yes, you can count the age of the baby by counting the somites. Also you can see the opening. Okay, so correlate with your radiology. Also you can see, I told you, within the vertebra there is the nucleus pulposus, sir, nucleus pulposus, which is remnant of the notochord. If there is the rupture of, if there is a slip disc or any situation due to which notochord, yes, nucleus pulposus, it is coming out, it will compress the spinal nerves. and there is the pain along the roots of the nerve, that is the radiculopathy, orthopedic integration. That's why one thing you have to remember, the notochord, yes, it forms the nucleus pulposus. Now look here, the causes of the folic acid deficiency, no excuse with this. Yes, the multiple subject integration, a folic pod, a folic pod. This is mnemonic. Yes, A for alcoholism, F for folic acid antagonist like the methotrexate, trimethoprim, pharma medicine, O for oral contraceptive pills, remember oxygyne, L for low dietary intake. Yes, excessive goat milk also can cause, and I for infection with the giardia, celiac sprue, P for pregnancy, psoriasis, O for old age, and delantine, also known as the phenytoin, antiepileptic drugs, they can cause the folic acid deficiency. Yes, this folic acid deficiency will lead to the neural tube defect. No excuse with this topic. Now, see here, this is our anterior neuropore defect. This is our anencephaly. No excuse with this topic. This is the question from the your INICET, from the your NEET PG. You can see, yes, also asked in FMG 2021. You can see there is the absence of the cranial vault. There is the exophthalmos, and chin is resting over the thorax. So these are the 3 points classically presenting in the anencephaly. Baby cannot survive properly. And this is our posterior neuropore defect. You can see there is the mass at the backside. You will see in the normal situation, yes, we are doing the cross section of the our lumbar region. So you can observe, sir, this is the vertebra. Correct, sir. This is the vertebra. And later there is the fusion. So spinal cord and meninges, they are coming inside. Try to understand. Sometimes due to the folic acid deficiency, the posterior neuropore is not getting closed. So there is opening and spine is presenting. Yes, our vertebra is presenting with the two spine, and baby is presenting with only hair tuft, no other symptom. Sir, this is our spina bifida, because spine is showing the two feet, two spines, that's why spina bifida, and no symptom, that's why occulta. But can you see, in this situation the meninges, they are coming out and these are filled with the CSF. So this is our meningo cavity, meningocele. And in the next image you can see severity so much, so along with the cavity, along with the CSF, the nerves are also coming out. So this is our meningo as well as spinal cord, that's why you will use the term myelo, and there is a cavity, that's why seal. And the next situation, when then spinal cord is coming out, yes, CSF is getting leakage. Why? Due to the rupture of the meninges. So this is the myeloschisis or rachis condition. These are very important, your pediatrics and surgery integration. So don't leave this topic. Now we are going to see one another important topic from the embryology, that is a neural crest cells derivative. Yes, I'm saying one thing, that neural crystals, they are just like the terrorist. Why? Because just like the terrorist can go any part of the India, Jammu, Kashmir, Tamil Nadu, Assam, Gujarat, any part, and they can show their activity. In the similar way, the neural crest cells are terrorist cells. They are migrating from the our neural tube part. Yes, they are coming just on each side of the neural tube and they are migrating in any part of the body. Yes, they are going inside the brain and they are creating the meninges. Within the eye, they are creating the sclera and choroid. They are going inside the pharyngeal apparatus and they are participating in formation of the mesoderm. They are going inside the tooth, making the odontoblast. They are going inside the skin, making the our melanoblast. They are going inside the GIT and making the orbic plexus. These all are very important. Within the adrenal gland, they are making the adrenal medulla. So we have to learn this our list. What are the different derivatives of the neural crest cells? And one recent MCQ in FMG exam, which chemical structure, which structure is helping in this neural crest cells migration? So remember, the most abundant mucopolysaccharide, that is our, yes, you can say hyaluronic acid is helping in the neural crest cells migration. If there is no neural crest cell migration, in that situation many kind of the diseases are occurring. Yes, as you learn always, the achalasia cardia and Hirschsprung disease. That's why this topic is important. What I want to tell you, the tricks and the magics I am telling you, so that you can remember the neural crest cells derivative. This is one funny image. BHU University, you can see Mahamana Madan Mohan Malvi, one funny mnemonic in front of the BHU Mahamana Madan Mohan Malvi ji. The kids, the childrens, they are doing disco. So neural crystal derivative, you can remember the PEADS, PIDS. Okay, sir. disco. They are doing disco. Where they are doing disco? In front of the Mahamana Madan Mohan Malvi. So this is the one funny mnemonic. Always remember, your tricks, your mnemonics should be funny, ghatiya, wahiyat, so that you can create that imagination in your brain for the long term memory. If you are making the good kind of the mnemonic, you will forget it. Okay, so what I want to tell you, yes, P for parasympathetic ganglion, E for enteric plexus, orbic plexus, A for ANS ganglion, D for dorsal root ganglion, S for Schwann cell, D for dentine tissue, odontoblast, S for sclera, C for choroid, and don't forget C for connective tissue of head and neck face area. Any gland, thyroid, parathyroid, thymus, connective tissue of any gland in this head neck area, lacrimal gland, nasal gland, oral gland, salivary gland, palatine gland, these all are coming. They are all are derivative of what? Your answer is neural crest cells derivative. And M for melanocyte, M for mesenchymal bone of the head and neck face. All the bones, frontal bone, maxilla, mandible, every bone, parietal, all are derivative of the neural crest cells except this occipital area. Okay, sir. And M for meninges. So don't leave this neural crystal derivative. One more thing I want to include, that is our adrenal medulla. Why these neural crystals derivative are important? Yes, if there is a failure of the migration of the neural crystals at the lower part of the GIT, neural crystals, yes, they are making the orbic plexus. We all know orbic plexus, they are responsible for the release of the NO, which is having the free radical activity. Yes, it is having the neurotransmitter activity. Yes, it is causing the smooth muscle relaxation. So if there is the no neural crystal migration, no orbic plexus is formed at the lower part of the esophagus, no NO, no smooth muscle relaxation, so there is the permanent constriction. So food material is getting accumulated at the lower part of the esophagus, which is giving the classical bird beak like appearance learned in your radiology, medicine, surgery, and ENT. In the similar way, if this our, yes, neural crystals, they are not reaching to the terminal part of the colon, in similar way you will see there is the constriction of the our rectum part, so it will lead to the Hirschsprung disease, megacolon, where you will see the radiological appearance in such kind of the way. So it is a very very important topic just to learn this neural crystal derivative table again and again. Now we are going to start our next part, but in between the session, few motivating lines for all of you. रास्ता भी जानते हो, चलना भी जानते हो, तुम आग हो तबीयत से जलना भी जानते हो, खुद को मोम न समझो जो झट से पिघल जाओगे, तुम सूरज हो डूबकर निकलना भी जानते हो. Practice gives perfection. Now we are starting our embryology and the histology session. Remember the first thing, these are the topics which are having very less output. So focus over the maximum output area, cover your clinical subjects, and then if you are having proper time, then focus the high yielding topics from the embryology as well as the histology, which are having the integration with the other subjects. So we are going to discuss about this pharyngeal apparatus. You will see this topic in ENT also. See here, here is the one embryonic image, real image. You can see the head bulge of the baby. Yes, sir. Where there will be the development of the brain. Agree. Now, this is our pericardial, or you can say pericardiac bulge. Okay, sir. Now, you can see, sir, this is tail portion, and just on the each side of the thorax part, pericardiac bulge, there is the, yes, upper limb bud. Sir, this is upper limb bud, and near the tail, you can see another bulge. This is our lower limb bud. Agree, sir. Now, you can see at the back side, these are the segmented structure, which are nothing. These are somites, which will make the segmented structure at the middle line of the baby. Yes, this is our vertebral column. Now, if here is the head bulge, here is the cardiac bulge. So in between them, there is the one gap is found. This gap is nothing. This is our oral cavity mouth. You can say, sir, stoma. Also, you can say stomodium. Now, look here. If this is the stoma, so this is inside cavity of the stoma. Sir, this is the pharyngeal cavity, and the very special structure in the pharynx area. Yes, pharyngeal area, which is running like the horizontal thickening. Yes, horizontal arch like manner. So these are our pharyngeal arch. But there is a difference between the pharyngeal arch, pharyngeal cleft, pharyngeal pouch. So we are going to look what are this. For proper understanding, we are looking this one beautiful animated three-dimensional structure. Again, same thing you can see. Sir, this is our head bulge area. Here is our pericardiac, also you can say cardiac bulge area. Sir, this is upper limb bud, here is lower limb bud, this is the part where there are the presence of the somites, and sir, this is tail portion. Getting the point? Yes, you can catch easily the gap between the our head and the thoracic part. Sir, definitely it is our stoma, stomodium, or you can say mouth. Okay, now the cavity within this our mouth part, definitely this is our pharyngeal cavity. This is CNS cavity where the brain will develop, and here will be the development of the heart. Once in Ames pattern this question had been asked, embryological image was there, and they had asked ABCD where the heart will develop. Remember, this is the portion where the heart will develop, and here there is the development of the brain. Now you can see, sir, this is our pharyngeal cavity. Now very special thickenings are visible at the pharynx area. Yes, these are known as the pharyngeal apparatus. We all know outside layer of the baby in our body, sir, that is the ectoderm. So this is our ectoderm. Getting the point? Yes. The GIT is lined by which structure, sir? Yes, it is our endoderm. And in between them, there is our mesoderm area. Agree, everybody? Now what we are doing, we are holding this embryo. Yes, we are cutting the embryo at the coronal section, and we are looking exactly from the back side. So hold this baby and turn it and look exactly from the back side. So now we are going to do imagination from this view. Okay, so look at this part. Correct, sir. So you are looking the pharyngeal cavity from the back side, sir. This is our pharyngeal cavity. Agree. Now look here, the outer layer is our ectoderm. Remember, the ectoderm is shown with the blue color. Yes, so this is our ectoderm. Getting the point? And the inner structure is our endoderm. Yes, sir. This lining yellow color is endoderm. So this is the our endoderm part. Agree? Now look here, in between them there is our mesoderm. So I am highlighting this all the things, sir. The outer layer in the our body ectoderm, in between them, yes, mesoderm, inner layer, definitely it is our endoderm. So this is our first concept. In the pharynx area in our body, ectoderm is outside, endoderm is inside, in between them there is a mesoderm. So simple. Now what happens during the growth of the baby? Yes, mesoderm is growing too much, and this mesoderm is growing from each side and meeting at the middle line. So there is the formation of, you can see there is a formation of the mesodermal thickening. Yes, sir, there is a formation of the mesodermal thickening at the pharynx area, and these are running horizontal bar like structure in arch like fashion. That's why these are pharyngeal arch. What I want to tell you, sir, the mesoderm is running horizontally and it is making the arch. So what you have to remember, sir, this mesoderm will make the pharyngeal arch. Yes. How many thickenings are there? How many mesodermal thickening at the neck area? Remember, total 6 thickenings, but fifth is getting disappear. So fifth arch gets disappear. So only the 5 pharyngeal arches persist. MCQ. Agree? Now look here, the ectoderm is outside, but this ectoderm is getting in dipping in between the first and second mesoderm. Okay, in the similar way it is getting in dipping between second and third mesoderm, and in the similar way it is going inside in between the next mesodermal thickening. So these our ectodermal in dipping. Yes, sir, these are our ectodermal in dipping. These are making the gap. Yes, you can say cleft, because these are present in the pharynx area. That's why you will say pharyngeal cleft. So you will see total 4 clefts are persisting. 1, 2, 3, 4. Agree, sir. And in the similar way you can catch this point, sir. Here is our endoderm. Agree. But the endoderm is bulging outside. Yes, sir, the endoderm is bulging outside in between the two mesodermal thickening. So these are our pouch like bulging. That's why simply these are known as endodermal pouch. Getting the point? And you will observe there are the certain areas where the ectoderm, mesoderm and endoderm, they are very close together. So this portion is known as very thin part. That's why membrane. Yes, it is our pharyngeal membrane. So what is the pharyngeal membrane? The area where the ectoderm, endoderm and mesoderm, they all are very close together. Again, try to understand such kind of a diagrammatic presentation you will see always in different diagram. Okay, different textbook, different MCQ books. So this is our one point which you have to remember. So outer layer is our ectoderm, this is our mesoderm, and inner layer is our endoderm. Okay, so how many mesodermal thickenings you can observe, sir? 1, 2, 3, 4, 6. Remember, the fifth mesodermal thickening, fifth arch is getting disappear. Do imagination, we are cutting the embryo, and we are now showing only this part, we are removing the cut portion. Okay, so don't make these middle structures. So this diagram is in similar kind of the way. Okay, now the ectodermal indipping in between the two arch is known as cleft. So there is a first cleft, second cleft, third cleft, fourth cleft, so on. And endoderm is inside, sir. Endoderm is inside. So endoderm is going out, bulging in between the two mesoderm, sir. It is the pouch. So total 4 pouch and 4 clefts are there. So easy concept. Now look here, within the each arch we are enlarging one arch and we are observing inside. So you can see within each arch their own nerve, their own artery, their own cartilage, and their own muscular parts are getting developed. So now it is clear, within each arch there is a development of the 4 structures. Any diagrammatic presentation you will see the 3 or 4 structure. Yes, the fourth one is our muscle. So these are our, yes, pharyngeal arch nerve, pharyngeal arch artery, pharyngeal cartilages, and pharyngeal mesoderms. Getting the point? Pharyngeal muscles, you can say. Now we are looking one update for all of you from the grades 42nd edition, Langemann edition, Larson embryology. Yes, it was a question from the NEET PG 2018 pattern. Remember the pharyngeal arch. Yes, there are the two types of the mesoderm. Primary mesoderm, yes, that is making the muscles and the pharyngeal arch artery. But remember, there is one secondary mesoderm also, which is coming from the neural crest cells, and these neural crest cells, they are making the our cartilage, skeletal element, and the pharyngeal nerve. So remember, the pharyngeal arch nerve, they are derivative of mesoderm. Yes, you are right. But according to this update, now the best answer is our, yes, neural crest cells. This question had been asked in our NEET PG 2018. Remember, don't mark the mesoderm, pharyngeal nerves, as well as the pharyngeal cartilages. These are derivative of the neural crest cells. We will see the neural crest cells later. Now look here, when there is a development of the arches, yes sir, this is the first arch, second arch, third arch, fourth arch, sixth arch. So at that time, within each arch, one nerve is getting developed. So within the first arch, you can see the fifth cranial nerve is developing, which is having the fifth one, fifth two, fifth three. So fifth three is going inside. In the similar way, in the second arch, you will see there is a development of the seventh nerve. In the third arch, there is a development of the ninth nerve. And in the fourth and sixth arch, there is a development of the 10th nerve. So you must remember what are the different pharyngeal arch nerves, for which I am telling you one concept. Yes, जस्ट लाइक जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. इन द सिमिलर वे, the particular arch which is developing at a particular area, yes sir, that will give rise to the nearby structure. Yes, जो आर्च जहां रहती है, जहां बहती है, वहां के स्ट्रक्चर्स को बनाती है. गेटिंग द पॉइंट? सो just remember, it is the pharynx area. So always the pharyngeal arch derivative, they will make the structures near the pharynx. It will never make the structures of the upper limb, thorax, abdomen, or the lower limb. Okay sir, this is the first concept. So first arch, put the hand over the your ear and the mandible. Sir, this is the first arch area. Put the second arch just below to it, then third, then fourth, and the sixth arch. So it will create the structure near to the our pharynx part. Agree better? Now what I want to tell you, there are the different structures, like you can see the pharyngeal cartilages. Okay, so if you are looking the pharyngeal cartilages, you can see there are the different structures which are developing from the our first arch. So first arch is the area of the mandible. So there is a development of the 5M. Yes sir, there are the development of the 5M. What are the 5M? You can see, sir, there is a development of the malleus and incus. Okay sir, there is a development of the another M. Yes, that is malleolar ligament, better to say anteromalleolar ligament. Then next M I'm telling you, there is a mandible to the sphenoid bone. Yes, mandible, there is a one ligament between the mandible and sphenoid bone. This is our mandibulo-sphenoid ligament. And then you can say the mandible as well as maxilla. So mandible and the maxilla. But according to the new concept, remember, this all are getting derived from the our neural crystals. So 5M are derivative from the first arch cartilage. Okay, sir, we will write down. Remember, this first arch cartilage is also known as the Meckel's cartilage, which forms the 5M. Okay, now the second arch was studied by the our Richards. Yes, sir, Richards. So this second arch cartilage is also known as the Richards cartilage, which gives rise to the 5S. What are the 5S? You can see S for stapes, except the foot plate, which is coming from the otic capsule. Then S for, sir, styloid process. Then next S is styloid to the hyoid, the ligament, stylohyoid ligament. Then next S is a smaller cornu of the hyoid bone. Then next S is our superior half of the hyoid bone. Complete. Then third arch is giving rise to the greater cornu and the inferior half of the body. Whatever remaining from the second arch, they are formed by our third arch. Then fourth and sixth arch, they are making below structure, that is the cartilages of the our larynx. Yes, you can easily remember. Now come to here. This is one beautiful table. How you can remember this, all the things I told you the concept, just you have to apply the logic. Yes, first arch. Sir, this first arch is also known as the mandibular arch. Yes. One thing always you have to study from the embryology. If you want to leave everything, you can leave, but never leave this table, never leave this pharyngeal apparatus. So, which one is the nerve developing within the our mandibular arch? Yes, your answer is mandibular nerve. MCQ. Okay, sir. Now the second arch. Yes, just below to it, there is the our neck part, the nerve of the neck as well as the face, that is our facial nerve. So don't forget this facial nerve. Third arch, the nerve is the glossopharyngeal nerve. The fourth arch, the nerve for the fourth arch and the sixth arch. Remember, the fifth arch totally disappear. So nerve for the fourth and sixth arch, that is the vagus nerve. But according to the Larson and Langemann embryology, the best answer is nerve for the fourth arch. Sir, it is superior laryngeal nerve. If it is not given, then you can mark the external laryngeal nerve. Yes, sir, external laryngeal nerve. And if it is also not given, then you can mark the vagus. I am telling you reference from the standard textbook of the embryology. Okay. And the sixth arch, the nerve of the sixth arch is recurrent laryngeal nerve. If it is not given, then even you can mark the vagus nerve, because recurrent laryngeal nerve is the branch of the vagus nerve. Agree? Now you have to know what are the different muscles of the first arch. Remember, the muscle of the first arch. Yes, put the hand here, so you can see temporalis, you can see the masseter. Yes, there is the medial and lateral pterygoid muscle, means 4 muscles of mastication. And you can remember one mnemonic, M82. What are this M82? M for, you can remember the mylohyoid, it is also in the same part of the first arch. Then A for, you can remember anterior belly of digastric. Then there are the 2T, again put the hand. Yes, there is the tensor tympani and the tensor palatini inside the mouth. So what is the nerve supply of this all the muscles? Remember, these all are a derivative of the first arch, and the nerve of the first arch is the mandibular nerve. That's why all these muscles are supplied by the mandibular nerve. Very important MCQ. Now look here, the second arch, you can remember the mnemonic for the second arch, that is the sun protecting factor. Yes, the second arch, it will spread all over and it will create the muscles of the face. And what we are applying in the face? The sunscreen cream, the sun protecting factor, you can remember. So what are the mnemonic? What are the full form? S for, yes, you can remember the stapedius muscle, the smallest muscle of the body. It is S for second, S for stapedius. Another one is our stylohyoid muscle. And then P for, you can remember the posterior belly of digastric. Do you remember? Anterior belly was the derivative of the first arch, but the posterior belly is the derivative of the second arch. So this digastric is having the double nerve supply, only hybrid muscle of the neck. And then F P for, you can remember, the platysma also, and F for facial muscle. So these all are derivative of the second arch. So you must know these all are supplied by the nerve of the second arch, that is the facial nerve. MCQ. Now look here, the third arch, it will give rise to the our muscle. That is which muscle, sir? This is our stylopharyngeus. Do you remember all the muscles of the pharynx? They will be supplied by the vagus nerve or vagoaccessory complex or pharyngeal complex, except stylopharyngeus. Remember, this stylopharyngeus is derivative of which arch, sir? Third arch. So definitely it is supplied by nerve of which arch? Answer is glossopharyngeal nerve. Yes, it is a rapid revision session. In detail, we had seen the pharyngeal apparatus in 2-hour video. You can go for the detailed video, but it is quick revision session. So focus only over this portion. Now look here, the fourth arch, the derivative of the fourth arch, all the muscles of the palate and all the muscles of the pharynx, as well as one muscle for the from the larynx, that is a cricothyroid. That's why these all muscles are supplied by, your answer is the vagus nerve. But remember, there are the 5 muscles in the palate, there are the 6 muscles in the pharynx. So this vagus nerve is not sufficient to supply it. So it is demanding for the help. So it is, yes, your answer is correct, 10th nerve. Okay, but remember, it is demanding for the help from the accessory nerve. So there is a formation of the one complex known as the vagoaccessory complex. Okay, but still it is not sufficient. So it is demanding for the help from the glossopharyngeal nerve. The pharyngeal branch of the glossopharyngeal nerve is also helping. Few more nerves are there, and these all are making the bunch of the nerve on the posterior side of the pharynx, that is the pharyngeal plexus. So remember, pharyngeal plexus is the best answer. What you have to remember, P for palate, P for pharynx, P for pharyngeal plexus. These all muscles of the palate, pharynx, they are supplied by the pharyngeal plexus. Getting the point? So this is the thing which you have to remember. But what about the cricothyroid? Yes, you will see in your ENT, the cricothyroid is supplied by the nerve of the fourth arch. The best answer is external laryngeal nerve. If it is not given, then you can mark the superior laryngeal nerve, and if it is not given, then even you can mark the vagus nerve. Getting the point? Yes, there is no role of this fifth arch, so just simply cut it. And now the sixth arch, remember, this sixth arch will give rise to the all muscles of the larynx, except, sir, exception is our cricothyroid. Yes, this cricothyroid is derivative of the fourth arch. That's why it is supplied by the nerve of the fourth arch, that is our external laryngeal nerve. So remaining all the muscles of the larynx, they are supplied by our sixth arch. Getting the point? Now we are talking regarding the cartilage. We had already seen this first arch cartilage is our Meckel's cartilage, which is making the 5M. Second arch is giving rise to the Richard's cartilage. Yes, it is known as the Richard's cartilage. It is giving rise to the 5S, I told you. And the third arch, it is making the remaining part of the hyoid bone. And then our fourth and sixth arch, they are making the laryngeal cartilages. Okay, now this artery portion, just whatever I am telling you, remember this point for the rapid revision. Actually, this artery part you will better get understanding in CVS portion. But nowadays, cardiovascular system embryology is not asked since many years. Okay, but remember the first arch artery, there is one artery in the first arch. Yes, sir. This first arch is our artery which is running within the maxilla, which is giving one artery running within the mandible. So you can say, according to the standard textbook, sir, maxillary artery, but the branch of the maxillary artery which is running within the mandible, that is inferior alveolar artery. According to the standard textbook, you can mark the maxillary artery. Second arch artery, yes, it is related with the stapes. So you can say stapedial artery remnant, as well as there is our small hyoid artery. Getting the point? Yes, sir. The first arch disappear, the second arch disappear, and the fifth arch disappear. But there are the small remnant. They are our maxillary artery, stapedial artery in first and second arch. Now, third arch, it makes the external carotid artery. The proximal part, it will make the common carotid artery. The distal part of the third arch, it will make the internal carotid artery. And in between the junction of the proximal and the distal part, there is the new growth. That new growth makes the external carotid artery. Only these points you have to remember. Now, fourth arch artery, yes, it is important. On the left side, don't forget, it will participate in formation of the arch of aorta. Yes, arch of aorta on the left side by our fourth arch artery, while on the right side it is making the right subclavian artery. Now fifth arch, it disappears, but sixth arch on the left side first, and then we will see the right side. Remember, the left side and the right side, both sides proximal part, yes sir, the near part, it will make the our pulmonary artery, right and left pulmonary artery, okay, yes, but right side distal part it disappear. But what is important, don't forget for your pediatrics, the left side, the distal part, sir, it obliterates and forms, yes, earlier it is making the ductus arteriosus, which later disappear and forms the ligamentum arteriosus. So this is very important, because if it persists, then there is a patent ductus arteriosus, which is classical example of left to right shunt pediatrics and the medicine integration. Now I'm going to tell you one WhatsApp joke, anatomy joke, I love you joke. Yes, what was that? एक लड़की होती है, एक लड़का होता है, लड़का जो होता है वो लड़की के पास जाता है और कहता है आई लव यू, बट गर्ल सेज आई नो दिस वन, टेल मी सच काइंड ऑफ अ थिंग व्हिच आई डोंट नो. नाउ द बॉय सेज yes, all the muscles of the larynx, they are supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by the, yes, recurrent laryngeal nerve. Now I'm going to tell you one famous joke from the WhatsApp memes. Yes, that was the I love you joke. Yes, there was the one boy and there was the one girl. Boy goes to the girl and says I love you. Girl says I know this one, tell me any such kind of the fact which I don't know. Now the boy says all the muscles of the larynx, they are supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by the external laryngeal nerve. Yes, now you can crack easily, you can understand easily this joke with the help of this table. I'm going to write down four such kind of the jokes. No excuse with this line, it is helpful for your ENT, medicine, surgery, many subjects. Remember, all muscles of the palate, pharynx, larynx and tongue. Four very great lines we are going to say. First, palate. All the muscles of the palate, these are derivative of, yes, your answer is fourth arch, and the nerve of the fourth arch is vagus nerve. But I told you here the many muscles are there, so better answer is the vagoaccessory complex, and the best answer is pharyngeal plexus. Agree, sir? Now, remember, in the palate, there was the one muscle, which muscle? Tensor palatini, which was derivative of the first arch. Correct, sir? It was a derivative of the first arch. So, nerve of the first arch, which nerve? Mandibular nerve. It will supply the tensor palatini muscle. Every point is MCQ. Now, in the similar way, pharynx, all the muscle pharynx, they are derivative of the fourth arch. So, same story. Yes, vagus nerve, vagoaccessory complex, pharyngeal plexus. But remember, one muscle of the pharynx, that is our stylopharyngeus. It was a derivative of the third arch. So nerve of the third arch, sir, glossopharyngeal nerve. So the glossopharyngeal nerve will supply. Otherwise, in detailed videos, I told you, yes, हमको स्टाइल मारना है, we have to make the style in front of the gloss, so we have to look the gloss and we have to make the style. So stylopharyngeus supplied by the glossopharyngeal nerve. Now all the muscles of the larynx, sir, these are derivative of the sixth arch. So definitely nerve of the sixth arch, recurrent laryngeal nerve will supply, except, so remember this exception, every exception is important, that is a cricothyroid. This cricothyroid was derivative of the fourth arch, and this fourth arch nerve was the external laryngeal nerve, you can say. Getting the point? Now in the similar way, we will talk about the tongue. All the muscle of the tongue, they are derivative of the occipital somites, also you can say occipital myotomes. During the development, yes, which nerve is going inside? 12th nerve. So remember, all muscles of the tongue, they are supplied by the 12th nerve, except, yes, your answer is palatoglossus. Yes, this palatoglossus muscle is coming from the palate and getting insertion into the tongue. So it is the muscle of the palate as well as tongue, but palate is first. Remember, this is the mainly muscle of the palate, fourth arch derivative. So now supply will be this column. Answer is our pharyngeal plexus. You can mark the vagoaccessory complex, you can mark the vagus nerve. Okay, so palatoglossus is exception. So question is, so shifting this point here in this column, remember this palatoglossus is derivative of the our fourth arch, that's why it is supplied by the nerve of the fourth arch, sir. This is our, yes, pharyngeal plexus, you can say. So this is our very very important table, you must remember. Now we are going to see the pharyngeal cleft. We all know there are the first, second, third, fourth and sixth pharyngeal arches. Yes, the second arch is growing rapidly downside. Okay, sir. So here opposite side, you can see it is growing downside, 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 and then it will meet at the lower part. This all the event is occurring near the neck. Now what happens? This is our first cleft. Okay, sir. So what is happening? Look at your body. This first cleft is making one opening here. Yes, it is in the neck part. So this is the opening. Cleft means gap. So this is the first cleft. Remember, this first cleft will give rise to the external auditory canal. Correct, sir. In ENT, you will learn there is the accumulation of the six hillocks around it and it forms the pinna. If there is the abnormality, there will be the anotia, microtia, many diseases you will see in ENT. Now look here, this is our second, third, fourth cleft. Later what happens? There is the growth of the connective tissue and it will fill this gap. This gap in embryology, sir, it is known as sinus. It is the gap, that's a sinus. In the neck, that's a cervical sinus. It is normal in every baby. Agree, sir. But what happens later? It is blocked. If it persists, then after the birth, baby will have the gap. If there will be the two opening, you will say fistula, because it is related with the pharyngeal apparatus. That's a pharyngeal fistula. This pharyngeal apparatus is also the branchial apparatus. That's why you will say branchial fistula. It is present in the cervical region. That's why you will say cervical fistula. If one opening, another opening is disappearing, then it is known as the cervical sinus. If the both ends are getting close and only one cavity is persisting, then it is known as the cyst. Agree? So these are the points which you have to learn, because you will look this topic in your ENT, in surgery, as well as radiology. So just to catch this point, sir, this is the same diagrammatic presentation. There is a rapid growth of this portion and it is hanging down. This is our cervical sinus part. Yes, inside part, inside it is presentation of our pouches. So we are looking that the first cleft, sir, first cleft is persisting and making the external acoustic meters. Then second, third, fourth, these all are disappearing. But sometimes it remains. Then it will make the cavity, any abnormality just behind the angle of the mandible. Yes, at the lower part of the sternocleidomastoid or at the middle part. These are found only and only in front of the sternocleidomastoid. This is another very important integration with clinical. Yes, you can observe here this clinical scenario. Patient is coming and just along the entry border of the sternocleidomastoid, there is the cervical sinus, cyst or fistula can present. Now, look here in radiology, for the investigation, for the identification, what you will do? You will inject the dye with the help of the needle, and if it is fistula, the dye is reaching inside the oral cavity and it will give the bitter sensation. Yes, sir, it is giving the bitter sensation in the mouth. So it will say, sir, it is the fistula. If bitter sensation is not felt at the mouth, then it is sinus. Agree? Now, look for the our pouch part. This is again the diagrammatic presentation. You can see first brown color or red color, sir, it is showing the our mesoderm. First, second, third, fourth, and here is our sixth arch. Can you see? This is our cleft portion. Outside there is a cleft. Yes, so here is our first cleft, then second, third, fourth, but these all are getting disappear. Okay, now we are talking about the our pouch. Can you see this yellow color presentation, orangish color presentation is making our, yes, endoderm. So first endoderm, first pouch is bulging outside, then here is the second, then here is the third, then you can see the fourth pouch. Okay, so third and fourth pouch you can observe beautifully. The first pouch is making one tube-like structure and then one cavity. Yes, it is nothing. It is tubotympanic recess. It is making the tube, which is making further the auditory tube, and this is our tympanic recess, means middle ear cavity. And outside you can see this blue color is the ectoderm, which is nothing, it is our first cleft. So you can see in between this our endoderm and ectoderm, very little amount of the mesoderm. Yes, it is our ear part, external auditory canal, and it is our middle ear cavity. So can you tell me which structure is lying in between of both this structure? There is a tympanic membrane. Yes, tympanic membrane you can easily integrate with the embryology. Why the tympanic membrane is having all the three germ cell layer? Because it is having the very special position. Yes, it is derivative of the first pharyngeal membrane, and the pharyngeal membrane is the meeting point between the ectoderm, endoderm, and mesoderm. You can see beautifully the beautiful integration of the ENT as well as anatomy. Now you can see the second pharyngeal pouch. Yes, sir. The second pharyngeal pouch, it will participate in formation of the epithelium of the palatine tonsil. Now the third pouch is having the our dorsal part and the ventral part. Remember, the dorsal part, it will make the parathyroid 3, while the ventral part, it will make the thymus. And here again you can see the dorsal part and the ventral part. Dorsal part, it will create the parathyroid 4, and the ventral part, it will participate in the formation of our lateral thyroid lobe. Okay, so we will see more things. Again, you can practice with this image. Sir, first pouch, it is making the tubotympanic recess. Now the second pouch, yes, the second pouch is making the, now we are going to see one more concept. In this diagram, you can see this is our third pouch and here is the fourth pouch. Agree, sir? What happens? There is the our second arch which is rapidly growing downside. That's why you will see that second pouch is going down while the fourth pouch remains upside. We all know that third pouch, it makes the parathyroid 3, while the fourth pouch, it makes the parathyroid 4. So what happens? You will see when there is the development of the thyroid gland, the third pouch, parathyroid 3, it is going downside and it is making the inferior parathyroid, while the parathyroid 4, it remains upside, so it is making the superior parathyroid gland. Another very useful concept. Now we are looking the our clinical points which are related to it. You will see always the question related to the Dye-George syndrome in our microbiology, immunology, medicine. Yes, you will see in clinical, you will see the features vary widely, and one beautiful mnemonic, that is the catch 22. How you can remember? This is the manifestation of the our Dye-George syndrome. You will see in this situation CATCH. C for cardiac abnormality, yes, A for abnormal facies, T for thymic aplasia, C for cleft palate, and H for hypocalcemia or hypoparathyroidism. Can you see there is a hypoparathyroidism, means parathyroid gland as well as thymus, they are involved, and both are derivative of which structure? Sir, both are related to the third pouch, means you can say this congenital abnormality is related with the third pouch abnormal formation. This question had been asked in your INICET AIMS pattern, then NEET PG, and as well as in our FMG exam. So now see here, there are the certain more clinical point like the first arch syndrome. First arch syndrome occurs due to the failure of the migration of the neural crystals within the first arch. Yes, neural crystals, they are migrating within the pharyngeal apparatus. Okay, sir. But if it is not getting incorporated, then symptoms occurs like the Treacher-Collins syndrome and Pierre-Robin syndrome. You will see the Treacher-Collins syndrome in such kind of the way in pediatrics and our different genetic disorder. Yes, you can remember Treacher. Just erase this R, so you are getting the teacher. Teacher's Day is celebrated on the 5th September. So remember, mutation occurs in the 5th number chromosome. This disease is also known as the mandibulofacial dystosis. So you can see the mandible and face abnormality here. Yes, mandibular hypoplasia is seen. Also you will see the Pierre Robin syndrome. Yes, Pyara Robbins. Robbins की book हमें बहुत प्यारी लगती है. When at the age of the 17 year, you can remember. Okay, where we are studying in the girls common room, GCR. You can remember. Yes, what are the symptoms? With the help of this mnemonic, you can remember. G for glossoptosis, C for cleft palate, and R for retrognathia. So here is the symptomatic presentation for the Pierre-Robin syndrome. In this rapid revision session, always remember few motivating lines to boost up for you. We all are doing. Remember, टूटने लगे हौसले, तो ये याद रखना, बिना मेहनत के तख्तो ताज नहीं मिलते, ढूंढ लेते हैं अंधेरों में मंजिल अपनी, क्योंकि जुगनू कभी रोशनी के मोहताज नहीं होते. Hello friends, now we are going to see one another unit of our anatomy in this rapid revision session, that is the histology, also you can say microanatomy. In this branch of the anatomy, we will see how to identify the different organs, different systems of our body with their microscopic structure at the cellular level and at the histological level. Now try to understand. Again, just like the embryology, this unit is not having too much output. So complete your anatomy first, then complete your gross subjects, your major subjects, other subjects, and after this all, if you are having the proper time, in that situation the important topics you have to look, because the input output ratio with this embryology and the histology is very limited. After the completion of all the things, you have to look certain areas in the histology which you have to must observe. Yes, in this histology, in recent pattern, you must look the our topic of epithelium. Another important topic is our cartilage as well as the collagen. So these are recently running topics, but few more things we will see in this our rapid revision session. Why this histology and anatomy is important, try to catch this point. Yes, we will do the anatomy integration with our biochemistry, we will integrate with the pathology. Remember, normal histology, yes, that is the anatomy you can say, but when this abnormal histology due to any disease, then it converts into the our pathological slides. And this staining technique, this all the process will be useful in the microbiology also, and we will do clinical integration. So this is our histopathology, which will be useful for the diagnosis of the different clinical disorder. Yes, histopathology is important for the diagnosis of the clinical diseases, that's why it will be indirectly useful for the other clinical subjects also. Now catch these points, we have to know regarding the histological techniques also, because few questions are directly asked from the histology and the pathology also. So if we want to observe the microscopic structure, very small structure which we cannot see through the our eye, yes, we need two basic requirements. What are these two basic requirements? Yes, we have to observe the very small structures, so for this we need microscope. Without microscope we cannot observe the very small things with the eyes. We know the different parts of the microscope since our school time. Okay sir. And another thing, yes, we have to use the contrast agent, the best contrast agent, that is black and white. If anything is black in color, then easily we can point out the white color within it, or if any background is white, then we can identify the black color. This is the best contrast. But when we will prepare the histological slides, at that time many dust particle, many artifacts are there, they will appear itself black and white, so it is not too good for the histology. So another is our, yes, black and white. You can see in the back black background, white is very good appearing. And in the similar way, if you want to opt any good contrast agent, then definitely it is blue color. In blue color you can easily identify the red color, or at the background of the red color you can identify easily the blue color. So that's why Spider-Man is wearing this color contrast. So we are going to use the same contrast agent for the identification of the very small structure. This blue color is nothing, the very popular color in our world of the histopathology. This is hematoxylin. Yes, hematoxylin, this is the staining agent, it is the coloring agent which will appear blue. And remember, excessive blue, if excessive blue, then it will appear black also. Agree, sir? And in the similar way, the red color, yes, red color is obtained by the eosine. Okay, so this is the eosine dye. Eosine is appearing red. Remember, if there is the light red, then it will appear pink also. So that's why the normal histology, yes, we are using the different histological techniques. So you will see the pink or red, and there will be the blue or black appearance. So the histology, yes, remember I'm talking regarding the histology. In pathology you will see the many special stains, but we are making the basic background, basic our platform. That's why we are going to talk regarding the eosine and our basophil color, yes, pink and our blue color. Agree, sir? Now, I'm going to tell you the basic principle. Try to catch. We are integrating this histology from the cellular level. We are going to talk regarding the our biochemistry. Sir, we all know the any structure in our body, yes, it is made by cells. Suppose this is the cell. Cell is having the cell membrane, correct, sir? There is the location of, yes, this is our cell membrane. Agree, sir? And within this cell membrane you will find the cytoplasm, within which you will say there is the location of the nucleus. Okay sir, suppose this is the nucleus. Correct sir. So here is the nucleus. Now catch the very tricky point. This nucleus is made by acid or base? Tell me, sir. Nucleus is having the DNA, deoxyribonucleic acid. Agree, sir. So this is acid. Remember, acid loves base. So there is our stain. Histology is totally the game of the microscope and the staining. So remember, which stain acid will love to the basic stain. So basic stain is coming, it is loving the acid. Getting the point? So which is our basic stain, sir? This our hematoxylin is basic stain. Getting the point? Yes. So it will love the acidic structure, so hematoxylin will come. I am showing with the H, and it will color the DNA. That's why this DNA, yes, it is our basophilic in nature. Baso means blue color, you can say, basic, you can say, and phil means love karna. Yes, it is loving it. So remember, that's why it will appear blue, and excessive bluish color is known as, yes, it will appear blackish in color. So remember, in histology your nucleus will appear blue, 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 blue. Agree everybody? Fine. Now catch our this another point, sir. There is a location of our cytoplasm as well as cell membrane. Yes, so we are talking regarding the cytoplasm. Can you tell me the cytoplasm, what is the pH of the cytoplasm? Sir, the cytoplasm is having the 7.4, approximately near the blood. Its pH is approximately near the blood. Okay sir, plus minus there is little variation, but you can say it is having the pH just like the blood, so it is slight basic. So can you tell me simple logic, if it is slight basic, so it will love, yes, it will love acidic stain, which is nothing, which is our eosine. Yes, so this is our eosine lover, so eosinophilic. So cytoplasm is eosinophilic in nature. And how the eosine is appearing, sir? Eosine appearing reddish. If slightly stained, then it will appear pinkish. So this is our basic concept. Yes sir, it will appear pink or red. Agree everybody? Now that's why whenever you will observe the histology, you will see, sir, there is the pink color appearance. Okay sir, fine. Now look here, the cell membrane is made by the PLLP, phospholipid bilayer, and it is having also the similar kind of the phenomena, the pH nearby the 7.4. So same thing, it is slightly basic, eosinophilic, and pink and red appearance, but it is having the linear appearance. So what you will see, sir, there is appearance of the cell membrane which is pinkish line like appearance. Agree? So anything which is appearing blue, yes, we are talking about the normal situation. So blue color or black color, sir, it will be nucleus. Agree? And any color which is pink or excessive pink, you can say red, that will be cytoplasm. Agree sir? Now catch this point, if there is a pink and red line, then you can say, sir, it is cell membrane. And if it is having the linear pattern over which different cells are located, in that situation you will say, sir, this is basement membrane. So these are the few basic things I told you. Fine. Now try to understand, whenever we are looking our any kind of the classification textbook you will get very easy this all the classification. Sir, there is the our basement membrane, basal lamina, and then cells are located, and you can see that nucleus they are parallel to the basement membrane, then it is our simple squares, cells are flat, so easy. Yes, when multiple layers are seen, then you will say, sir, multiple layer, that's why stratified squares, so easy. In the similar way, if the cell all the dimensions are normal, they are equal, then cuboidal epithelium. When the height is more, then columnar epithelium. When the cilia is present, then ciliated, and you can see multiple cell layer. Yes, so it is stratified. But can you see in this image, all the cells are attached to the basement membrane, all the cells are attached to the basement membrane, so it is not the stratified, it is our pseudo stratified. What I want to tell you, all cells are attached to the basement membrane, that's a pseudo. If correct stratified layer, then you can see all the cells are not attached to the basement membrane, so this is true stratified layer. Yes, there is the stratified layer, and if upper side layer is not presenting the nucleus, it is having no nucleus, means dead layer, so this is the keratinized. Getting the point? So this is the keratinized layer. Now you will see the our stratified cuboidal, stratified columnar, so on, you all know. And also we will talk about the transitional epithelium, which will transit from one kind of the appearance to the other kind of appearance, which is found in our urine tract. We all know, we are studying since the school time. But what is the problem? Yes, you know the classification of the epithelial tissue, one time we are doing such kind of the questions are not asked, but these are important for the basic principle. Yes, epithelial tissue, these are the special kind of the cells which are lying over the basement membrane. One end is attached to the our basement membrane and another end is free, these are known as the epithelium. So there are having the simple or compound layer. Okay, if only one layer, simple, but if multiple layer, then you will say compound layer. Okay, so now see here, simple layer, cell shape. So if you are looking the flat cells, squamous cell, all dimensions are equal, our cuboidal, and if height is more, columnar. But there is the cells which are appearing stratified, but all the cells are attached to the basement membrane, then pseudo stratified. Now you can see these may be ciliated or non-ciliated. Agree, sir? Now catch this point, compound layer, if they are changing their shape, then you will say transitional. Yes, they are changing shape from one kind of the appearance to the another kind of the appearance. Okay, sir. Stratified, if there is a multiple layers, then you will say stratified. Now yes, stratified, so it may be the stratified squamous, stratified cuboidal, stratified columnar. And we know the stratified layer, if there is a dead layer at the upper end, then you will say keratinized, and if no dead layer, then it is our non keratinized. Getting the point? Okay, sir. Now try to catch this point. These all the things, okay, sir, these all we are studying since the school time, and you told very very nice concept, we are getting the point. But what is the problem? When we look our, yes, whenever we are looking the our slides given in the image, even in the first mbbs viva slides, we are getting too much confusion. Yes, theory is at one side and practical things they are at another side. Okay, so I'm going to tell you few more things. See here, God told to all the cells, yes, go. Yes, every cell is having the very beautiful nature, they are very beautifully made, they are having the proper rounded appearance. Yes, sir, they are having the proper round appearance, and the nucleus is very beautiful. Now God told them, go at the basement membrane site. Okay, sir. Now the cells are located there, they are doing their function, but some part of the body where there is the pressure, so these cells are changing their shape. So this is the basement membrane, and these cells are becoming flat due to the pressure, and that's why the nucleus becomes parallel to the basement membrane. So this is the another concept. Yes, whenever the nucleus, sir, nucleus, it is parallel to basement membrane, means it is our, sir, squamous epithelium. MCQ. Agree, everybody? Yes, it is found at the site where there is the pressure, sir, pressure by the blood, pressure by the air, or pressure by the urine, any kind of the fluid. So where is the blood? Yes, sir, it is found within the blood vessel. So you will see the endothelium, they are presenting with the squamous epithelium. Air means you can say lung alveoli, urine you can say Henle loop. So why these are found? Yes, God told them to become flat so that they can do exchange, either the gaseous exchange, nutrient exchange, nutrition exchange, or you can say the excretory product exchange. Okay, sir. But what will be the problem at time of exam? Yes, you will not be able in the slide only single cell. There will be the our cell membrane. Agree, sir? And there will be the one cell, two cell, three cell, four cell, then five, six, seven, eight. There is a group of the cell, and this is the problem with the histology. Everything will appear red, 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 and we are not able to crack the question. Now, what I want to tell you, the Spider-Man concept. Remember the contrast agent. It is very good to see the blue color add the background of the red, or red color add the background of the blue. So what you have to remember, we cannot identify properly the basement membrane, the cytoplasm, and the cell membrane, but within it the blue color will appear properly. Just to make identification of that blue color, if these blue color, yes, they are parallel to the basement membrane, yes, so this is squamous epithelium. If they are multiple layer, 8 layer, 10 layer, 12 layer, not 2 3 layer only. Okay, if 2 3 layers, so there will be the confusion with the pseudo stratified. So try to catch this point. If multiple layer and upper layer, they are also parallel to the basement membrane. Okay, what I want to tell you, who is your friend? Sir, nucleus is our friend. Nucleus is our friend in histology. This is the first line which you have to remember. Who is your friend in the histology? Sir, nucleus is our friend. If the nucleus is parallel to the basement membrane, then definitely you will say, sir, it is squamous. Multiple layer, then you will say stratified. Okay, and if at the upper layer you will see the eosinophilic color which is not having the nucleus, then you will say, sir, it is dead epithelium, so it is our keratinine. Yes, it is our keratin layer. Getting the point? Okay, so what I want to tell you, this principle you have to use. Now look here, another our beautiful concept. There was the very beautiful cell membrane. God told to the cell, go and do the function for the synthesis and secretion. Now there will be the changes at development time. So you will observe these are doing synthesis and immediate secretion. Okay, so there are the problem with the group of the cell. Yes, try to understand. This is our cell membrane. Here is the one cell, then you will see the another cell, then you will see the another cell, then you will see the another cell. Yes, because they are doing synthesis and then immediate secretion, so nucleus, they are having proper balance of the pressure, so they will present with the round nucleus. So what you have to remember, these cells are having beautiful round nucleus. But now we are going to make the multiple cells in a same image. So try to understand, if this is the basement membrane, one cell, another cell, another cell, another cell, another cell, and these are having the multiple layers, multiple layers, multiple layers. So this is the problem. All the cell membrane, all the cytoplasm, they all are getting merged, and we are not able to identify the structure. Can you observe here one more thing? Because they are having the equal pressure, so they are adopting all the dimensions equal, height, width, depth, everything is equal. So these are cube like shell, cuboidal cells. Multiple layer, then definitely you will say, sir, it is stratified cuboidal. Now how you will identify here? Again, Spider-Man theory. You have to remember that in this red or pink color background, you can identify easily the blue color. So whenever you are looking the very beautiful round nucleus, then you will say, sir, it is cuboidal epithelium. And definitely, if you will observe multiple 8 9 10 layers, so this is our stratified cuboidal epithelium. Are you able to catch this point? Yes, sir. So this is our cuboidal epithelium. Yes, sir. And if multiple layer, then you will say stratified. Agree, sir? Where you will find out the part of the body where there is the ability to do synthesis and immediate secretion. Yes, you will get these are lining. Yes, here is our basement membrane, and these cells are located over this basement membrane, equal pressure, so they are adapting all the dimensions equal, and these are presenting with the very beautiful nucleus. Correct, sir? So there is our follicle formation, they will do synthesis and they will release the structures at the lumen. So such kind of the appearance you will see in our thyroid follicles. They are doing the synthesis and then secretion of the T3 T4 hormones. Yes, you can see this secretion, and in the similar kind of the appearance you will see in the PCT and DCT in the kidney. They are synthesizing and releasing the different kind of substances. Getting the point? Now correlate with the pathology. In kidney you are observing the PCT DCT. In pathology, in your, yes, I am talking regarding the patho, yes sir, as well as medicine, where you will see one condition, chronic pyelonephritis. Chronic, yes, it is severe. Pyelo means pus formation, yes, nephritis, inflammation of the nephron or kidney, you can say. So due to it, these PCT DCT, they are getting inflamed and they are showing the secretion of the different kind of the cast material at the lumen. Getting the point? So the PCT DCT, they are having the same kind of the appearance like the thyroid follicle. Okay sir, both are having the cuboidal epithelium and both are having the secretion at the center. Okay, and when you will do staining, these will appear eosinophilic. So in this situation, in case of the chronic pyelonephritis, the appearance of the PCT DCT, they are just like the our thyroid follicle. Are you getting the point? That's why the chronic pyelonephritis is characterized by the one word, thyroidization of kidney. So kidney is showing the feature just like the thyroid. So beautiful integration. This is very important for the pathology and the medicine. And if you are a student from the second MBBS, then definitely this slide is shown in your prof exam, practical exam. Okay sir, fine. Now we are looking one last another story. This is the basement membrane. God is saying to the cell, go and do synthesis, but you have to store, you have not to secrete immediately. So what this cell is doing, sir, this cell is showing the elongated form and it is showing the, yes, storage of the content at the apex part, and there are the multiple cells. So these multiple cells are giving the pressure from each side, side by side, and these are having the content at the apical portion. So due to the pressure from side by side, the nucleus, they are getting elongated. Getting the point? Fine. So what you can see that here, sir, nucleus is 90-degree to basement membrane. Nucleus is your friend. Why? Because when you will see the histology slide, there will be the basement membrane. I am drawing the one. Yes. What is this, sir? This is definitely columnar epithelium. Agree, beta? So you will see there is the multiple cells, columnar cells, which are having the more height, more height, more height. But when there is a stratified layer, yes, these are very small structure we cannot see from our eye. So multiple layer. So what is the problem? Everything is red, 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 red. Sir, this is the problem with the histology. Cell membrane is red, cytoplasm is red, basement membrane is red. So we cannot differentiate between red, red, red. But Spider-Man theory, you must remember, we can easily identify in this red, black, black, in this red background, the bluish color. So we have to find our friend. Yes, if the nucleus are elongated and they are parallel to the basement membrane, yes, sorry, they are 90-degree, they are making 90-degree to the basement membrane. Okay, so definitely these are our cuboid, these are our columnar epithelium. These are our columnar epithelium. Agree, beta? Now catch this point. You will see the multiple layers. Yes. If multiple layers, 8, 10 layers, then you will say stratified. But if all the cells are attached to the basement membrane, okay, in that situation, you will say pseudo stratified. Agree, everybody? So this is our basic principle. But after this beautiful concept, again, I want to tell you the histological technique. Why? Try to understand. During my PG course, I was having the thesis topic, time since death from histological changes in the human liver. Yes, I did this histological technique during my PG course, and this was the our forensic anatomy topic, for which I was made the chairperson at the KGMC National Level Anatomical Conference. Okay, there was the ASI Anatomical Society of India, so they are organizing the NatCon conferences. So there was the one very beautiful topic during my thesis. So I'm sharing that our knowledge of the histological technique, which will be helpful not only for the anatomy but also for the pathology, for the microbiology, and for the diagnosis of the your surgery, medicine, obs pedia, these all the things. Yes, for this histological technique, I was going to the postmortem with the proper permission and taking the sample of the liver. Okay, sir. Okay. Now, what I was doing after that, in histology lab, I was using the L block. We are managing them in such kind of the way, and tissue samples they are put here, and molded wax is kept inside. So now the our tissue sample, it is becoming solid within this solid blocks. Okay, sir. Now we are preparing such kind of the histo sample where there is the position of the tissue inside the wax block. Okay, sir. Now we are using this instrument. This is microtome. Remember, for the image based preparation, this is our microtome. We have to look the microscopic structure, so we have to cut, but we are not able to cut with the knife. We have to use the very special kind of the instrument which is showing cutting. Yes, tom means cutting. Anatomy, anna means to see, tommy means cutting, and we are cutting with the very very small diameter, very small micro cutting we are doing. So here is our instrument and different parts will not be asked, but remember, okay sir, this is the microtome. So the tissue sample is kept here, that wax block is kept here, and then we move this handle. So here is the knife, we are cutting at the 5 micron, 3 micron, you can set here. Okay, and there is the very thin films are cut. So we can cut the wax, we cannot cut directly the tissue sample, but we can cut the wax. So with the wax cutting, the tissue sample they are coming, we are making the ribbon. Now in our water bath we are spreading it, so it is properly spreaded, and then with the help of the needle we are taking this sample in the our slide. Okay sir, we are taking in the slide. Now in the wax, with the very low temperature, we are molding, we are melting the our wax, and the tissue sample, it is getting firmly attached to the our slide. Agree? Now after it we are going for the staining procedure. Okay, so our slide was prepared. Now we are dipping this one into the acetone and alcohol. Okay, it is 90%, 80%, 70%, 60% in descending or ascending order. Okay, fine. And then we are dipping the slide into the basophil hematoxylin. Yes, we are dipping into the hematoxylin. This is the hematoxylin stain. Now whatever the structures which are acidic, they will take the hematoxylin stain. Now to remove the excessive stain, dip into the water, so excessive stain is washed. Now after that, dip this slide into the eosin. Yes, we will use the eosin, red color stain. Again dip. So whatever the structure which are basic in nature, they will take the eosinophil stain, and again dip into the water. Fine sir. Then again we use, there is the acetone alcohol. Remember, we are dipping this slide inside the acetone alcohol, which are organic solvent. We know the like dissolves like. So whatever the fat, whatever the organic things within the tissue, they will be washed within the acetone alcohol. That's why fat is not observed. So to observe the fat, you will use the special stain in your pathology, like the von cosa, yes, like the Sudan. These all the things you will learn in your pathology. For the fat, you have to use the special kind of the stain, but in normal hematoxylin eosin, you cannot observe the fat. Okay, so after this all, you are able to observe in the microscope. And remember, microscope is having also the different kind of the 5x, yes, also few microscope 4x, then 10x, 100x, also few very beautiful 400x. Yes, electron microscope are there, all are having the different kind of the appearance. So here we are going to look this slide now. Why I told you? Because now with this story, you all are having the clear concept. Yes, in exam such kind of slide will be asked. What I want to tell you, I told you beautiful concept. you are learning in your textbook beautiful concept, but at time of exam, when you are looking the slide, all concept at one side. Remember I told you the histological technique in which there was the mechanical pressure. Yes, knife was cutting the tissue. Correct, sir. So there is a mechanical pressure. So any nucleus, if it is having, who is your friend, sir, nucleus. If any nucleus is in such kind of the way, okay, it is elongated, but when there is the mechanical pressure, yes, the knife is coming and it is cutting the tissue block with the pressure, so this elongated structure can be converted into the round or even the flat. All the stories, they are again getting distorted. Okay, yes, we are giving the thermal, yes, we are giving the external chemical pressure also. So lots of problem during the preparation of the slide. So never look one nucleus, but look all the different kind of the sites. What I want to tell you, whenever you are looking any site, don't observe one single thing. You have to look right, left, right, left, middle, center, everywhere you have to observe and then take an average. Okay, so let's start now how to identify the our histological slides. Sir, in this slide we can see there is the no color. Okay, sir. So no color means you will say this may be air or it may be fat also. Okay, but remember the fat, they are having the regular round shape, but air, so there will be the irregularity. Okay, fine. Now look here, this is the pink color. So this pink color, either it will be the cytoplasm or it will be your basement membrane, because it is linear in appearance. Yes, sir. So better to say, sir, it is basement membrane. Okay, sir. Now look over this blue color, black color. Sir, blue color, black color, this is the nucleus and it is our friend. Sir, here is the round, so you will say cuboidal. But what I told you, never observe the histology slide from one thing. Yes, look at the top, right top, left top, below, center, everywhere, and then make an average. So you can observe the maximum nucleus. Yes, can you see this one, these ones? Yes, here, can you observe here, here? Yes, the maximum nucleus, they are parallel to the basement membrane. So if they are parallel to the basement membrane, nucleus is your friend. Nucleus is, yes, you can say parallel to basement membrane. So you will say, sir, it is squamous epithelium. Now use common sense. In our body, where there is flat squamous epithelium, where there is a need of the exchange. Now try to understand, these lumens are rounded or irregular. Sir, these are irregular, so these are not the fat space, these are the air space. Use your common sense. In our body, what are the spaces where there is the air and there is a need for the exchange? Definitely only one answer, that is our lung alveoli. Now look, whenever you are looking the histology or any MCQ, go for the options and give the direction to your thoughts, so that you can crack the question within the less time. Okay, so look at the option and you will find such kind of the any option, mark it. Okay, now look here, can you see? Use common sense. Remember, in exam the bad histology slides will be given. Okay, sir, this is red line, so we will say this is basement membrane. And you can observe beautifully, yes sir, there are the blue color are your friend and these are rounded. So definitely no confusion, these are nucleus which are rounded to the basement membrane. So this is a cuboidal epithelium. Okay, and you can observe the lumen also. Can you see here, the cells are visible? Agree, sir? Remember, if nucleus is present, means cells are living. If no nucleus, cells are dead. But can you see, sir, here is a no nucleus. Try to understand. Suppose this is the cell and here is the nucleus. If our section is from here, nucleus will be visible. But suppose section is from here, nucleus will not be visible. Okay, so you can see, yes sir, these are nucleated cells. Few cells, they are not showing the nucleus because section was not from there. Agree, sir? And these are having the lumen also. Yes, it may be the thyroid, it may be the kidney. Yes, right now the kidney slide, it had been asked in your NEET PG 2023. In kidney, remember there is the tuft of the blood vessel, that is glomeruli. Yes sir. So if glomeruli tuft, blood vessel tuft will be seen, then say about the kidney. But if no glomerular tuft, then better to go with the thyroid slide. Okay, now can you see another bad slide? You can say, sir, this is our cell membrane, all the cells are having the very tall appearance. Yes sir. And the nucleus are rounded. So you will say, sir, rounded nucleus, you told us that these are cube like, so cuboidal. But remember, go for the average. I told you, when there is a pressure, then this elongated nucleus, it becomes the round and sometimes also the flat. So you can see every cell is having the more height, so it is better to say our columnar. Yes, for your practice, I had put here the bad kind of the images, because in exam the good images will not come, always the problematic things will be there, and we have to face such kind of a situation. Can you see here, sir, there is the another bad slide, sir. This is our basement membrane, basement membrane, basement membrane. Yes sir, here is the basement membrane. And can you observe, these are our nucleus, sir, multiple nucleus are there. Okay, but remember, if 8 layers, 10 layers, then go for the stratified. But if there is a 2, 3 or 4, then remember, these cells are actually, all cells are attached to the basement membrane. So these are our pseudo stratified epithelium. You can see upside there is presence of cilia. So this is the ciliated pseudostratified which epithelium. Yes, height is more, nucleus they are elongated, so you will say columnar. It is very important. And you can see there is the presence of the storage. Actually these are our goblet cells. Yes, these are presenting the storage of the mucin secretion. These are nothing, these are our goblet cells. Yes, it is classically found in our respiratory epithelium. Don't forget clinical integration. If there is the abnormal ciliary movement, yes, it is leading to the Carter-Jenner syndrome, which is identified with the State Bank of India. S for you all know, that is situs inversus. B for that is our bronchiectasis. In bronchiectasis, this cilia are not showing the movement, so there is a more chance of the infection, and there is inflammation of the bronchial. So there is the ectasia. Ectasia means dilatation. Bronchiectasis. Agree, sir. And also you will see there is the I for infertility. Yes, sir. There is our chances of the infertility. Yes, in sperm this cilia is present. So ciliary movement is affected in the Carter-Jenner syndrome. Immotile cilia syndrome also you can remember. So such kind of the clinically integrated question topics will be asked. So remember, this epithelium is important. This is our pseudo stratified columnar epithelium. Now look here, such kind of the bad slides will be asked in your exam. You are observing, sir, this is the basement membrane. Agree, sir. Now you can see 8 to 10 multiple layers. So this is our stratified epithelium. Now it is stratified epithelium. Can you make the front to the nucleus? Yes, sir, these are rounded. So you will say, sir, these are our cuboidal stratified epithelium. No. Who is your friend in case of the stratified epithelium? Upper layers. Can you see? The upper nucleus, black, blue color, these are parallel. So you will say these are squamous. So better to say stratified squamous epithelium. Can you see nucleus is present? Yes, nucleus is present. That's why you will say non-keratin. Yes, sir, these are non-keratinized. But if there is the presence of the thick red color without the blue color dot, in that situation, yes, it will be our keratin. Getting the point? So this keratinized, we all know, sir, there are our two types of the stratified epithelium. Which epithelium? Squamous epithelium. Yes, sir. These are our keratinized, and another is non-keratinized. Try to understand. Keratin is dead layer. Where these dead layers are formed? Remember, if there is a dead layer, so there is a no secretion. No secretion means there will be the dry. Okay. Now, stratified layer, to prevent the friction. So if any site which is having the dryness and friction area, then it is the non-keratinized stratified squamous epithelium. And only one place in our body, sir, that is skin. Touch the skin, it is dry. Yes, there is the pressure, there is a friction. So skin is having the keratinized stratified squamous epithelium. Very important. The skin is very important. This is directly beginning part of the your one subject, that is skin subject. So this is our skin conceptual brainstorming integration. We will see the skin slide. Now see non-keratinized. These are the part, if there is no keratin, so the epithelium they will show secretion, and if there is a secretion, so that part will be wet. Okay sir, these parts are wet, and definitely these are friction areas. So what are the different parts in our body where there is the wetness and these are friction? Step by step. Look, concentrate over the conjunctiva and cornea. Yes, there is a friction. Yes, and these are having the secretion. So remember the cornea, the conjunctiva, our ophthalmology integration. Now come to the our next part, nasal vestibule, lower part of the nasal vestibule. Yes, it is having the wetness and friction area. Now come down, oral cavity. Yes sir, oral cavity, even the tongue, palate, upper part of the pharynx, upper part of the larynx, this all are having the wetness and friction due to the food movement, air, this all. Now come to the downside of the body. Yes, you will see the tip of urethra. Sir, the urinary tract is lined by the transitional epithelium, urothelium, but the tip of urethra, there is the friction. Yes, at the glans penis, there is the friction during the sexual intercourse, you can say. Yes, and these are wet. So these are again having the our non-keratinized stratified squamous epithelium. Now, in the similar way, the lower part of vagina, same story. Okay, and as well as the lower part of anal canal. Correct sir, these all are having the same kind of the feature, fecal material, they are doing the friction, and these are the wet area. So that's why, so these all are your different MCQ in different kind of the subjects. Now look here, come to this special kind of the epithelium, it is very most important. Why? See here. Can you see this pink line? So if pink lines are seen, so definitely it will be the cell membrane or the basement membrane, because it is in continuity very long. So you will say basement membrane. Now observe, there are the presence of the single cells. Yes sir, there are the single cells are observe. Okay sir, and these are having the multiple layers. Yes sir, multiple layers, but when you are looking at the topmost layer, can you see these are having the binucleated appearance? Correct sir, and if you can concentrate, these are having the extra reservoir of the cell membrane which are encroaching downside, and if you are using one stick, so it is just appearing like the umbrella. Yes, so it is our umbrella cells. Getting the point? Fine sir, so these are our beautiful umbrella cells. Catching the point? Yes. Also you will observe above it there is a thick layer of the glycoprotein which will prevent absorption of many subjects. Yes sir, there is a thick layer of the glycoprotein. Okay, so you will see there are the basal layers. Yes sir, and middle cells, they are having the pear shaped cells, and topmost layer they are having the binucleated appearance, having the extra reservoir of cell membrane. Yes, uppermost cells, they are umbrella cells, these are stretched, and when these are getting stretching, they are changing their shape, and when they are getting relaxed, they are changing another appearance. So this kind of the epithelium is known as transitional epithelium. Remember, it is found in our urinary tract, that's why these are also known as the urothelium. It is found everywhere in our genital, in our urinary tract. Yes, you will say it will start from the distal part of the collecting duct, then minor calyces, then major calyces, then pelvis, then ureter, then urinary bladder, then in urethra, except membranous urethra, because here is the pressure by the urogenital diaphragm and tip of the urethra. These all are the MCQ, so don't forget this epithelium. Okay, now come to here. This is another very bad slide but very important. We cannot identify such kind of slides. Yes, but be cool, calm, relax, look at the options, give proper direction to your thoughts, and according to which you have to look here. Yes sir, can you see the thick red color? Okay sir, Can you see one pigmentary structure which is coming straight? Yes, sir. So this pigmentary structure is nothing. It is our hair, and this thick red color is nothing. It is our keratin. So definitely it is our hair. Skin subject integrating, skin conceptual brainstorming integration. Now look here, at the root you can see, yes sir, at the root of this hair follicle there is a soap bubble kind of appearance. This soap bubble appearance, yes, it is used in the giant cell carcinoma, giant cell tumor, and many other things, but I'm here using so that you can identify easily, sir, these are having the soap bubble appearance. Why? Because of either the air or the fat, but air cannot come within the tissue. Okay sir, in the lungs it is possible, but here it is not possible. So it may be, and you can see, you can also see these are rounded regular, so these are fat. When we are preparing the slide, we are dipping inside our acetone and alcohol, so yes, it is getting washed out. These are having the empty appearance. These are the fat cells. Yes, these are nothing. These are our sebaceous gland. Getting the point? Yes sir. And one very popular question, these sebaceous gland, they are totally destroyed after the secretion, whole destroyed. That's why these are known as holocrine gland. We know apocrine, if the apical portion is destroyed, yes, whole gland is destroyed, then you will say holocrine. And if these glands are not destroyed, then it is known as the ecrine gland. In our detailed classes we had discussed, but here we are not discussing. Okay, this is the rapid revision part. That's why only this thing you have to remember. There will be the slide and they will say which type of the glands are shown here, that is sebaceous gland. At our time the same question was asked, sebaceous gland, they are which type of the gland, holocrine, but nowadays they are putting the image and then they are asking, and you will study in your skin, if there is the problem in the duct, then sebum will be accumulated here and it will result in the, yes, it will result into the our acne, which is very very important topic. You will see this integration in your skin subject. Now also I'm going to talk regarding the muscle histology, because it will be very useful for the identification of the your different topics. Remember, three types of the muscle you all know, sir. There is presence of the skeletal muscle, yes sir, smooth muscle, also you will say cardiac muscle. Agree? Why these are important? Because you have to identify the muscular dystrophy slides. You will see smooth muscle in GIT slides. Agree sir? And cardiac muscle like the rheumatic heart disease, and very important for the myocardial infarction. That's why, so these are our different conceptual brainstorming integration with the patho as well as with the medicine. Now look here how you will identify the slides. Okay, so very very beautiful. You can observe here, sir, whenever there is the dark band, light band, dark band, light band, dark band, light band, and nucleus are parallel in a row, multinucleate appearance, then definitely mark it, it is our skeletal muscle. So now you can easily identify the different kind of Duchenne muscular dystrophy, polymyositis, many kinds of muscle related problem in your Harrison. If such kind of slides will be there, not exactly same but similar kind of slide will be there, then definitely you have to mark, sir, it is our muscle related problem integrating with all multinucleated and say nucleus are arranged in a row. Now look here, this is very important. Can you see again, sir, dark band, light band, dark band, light band, dark band, light band, and these are showing the branching pattern. Yes sir, here there is the no branching pattern and here is the branching pattern. Can you see? Yes sir, there is the our branching pattern, they are meeting together. And very carefully, there is the also presence of intercalated disc. Sir, there is the presence of intercalated disc. Okay, so also you can observe in each part there will be the one single nucleus. If the section is passing through the nucleus, then you will see the nucleus. If it is not passing, then you cannot see. But can you see multinucleated in the row? It is not appearing, so you cannot say it is skeletal muscle. Intercalated disc are present, that's why definitely it is our cardiac muscle. Getting the point? Now you will see this cardiac muscles having the intercalated disc, it is having the too many gap junction. Yes sir, this was the one old question, why the gap junctions are found? To exchange the different ion, so that our heart tissues they can contract simultaneously as a single unit, so ions exchange is permitted through the gap junction which are present in this our intercalated disc. Why I am teaching you? Now go for your patho go for the your medicine where you will see the rheumatic heart disease. Yes, within this cardiac tissue you will be able to observe the Ashkoff body, you will be able to see the Anish cow cell, you will be able to see the caterpillar nucleus, you will be able to see the owl eye nucleus, different kind of the things you will see. This is the clinical integration. I told you the basic point. Okay, so whenever you're looking the Robbins or you're looking the Harrison, this will be the image on the backside. Even in your myocardial infarction histology image pathology slide, you will see, sir, there is a cognitive necrosis, but at the normal side you will see such kind of slide, and in between them there is the eosinophilic degenerative changes, so that will be the cognitive necrosis. Just to do that integration in your pathology. Agree beta? Now come to here. Sir, there are appearance of the nucleus which are spindle shaped, but the cytoplasm and cell membrane they all merge together. Yes, these are the spindle shaped cells actually. Yes, these are nothing. These are our smooth muscles. If you are doing section from here, so if it is passing through the nucleus, you will get the nucleus. But suppose this is any spindle shaped cell, nucleus is here but section is passing from here, so the nucleus will not appear at this portion. So in case of the section, can you see here the nucleus are visible but no nucleus are seen here. All are nucleated cells but sections are not passing through the nucleus, that's why sometimes it is not visible. So these are our smooth muscle. Yes, this is our section, cross section, and these are our longitudinal section of the smooth muscle. Now I'm going to tell you one very important topic, the cartilage, according to the recent pattern. Cartilage as well as bones both are very important due to the many diseases. Yes, entire orthopedics is depending on it, as well as medicine, surgery, they are integrated with the bones and our cartilage. Now see, bones are very easy to identify because of the Haversian canal, Walkman canal. You will see there is the osteocytes, so it is very easy. Okay, but nowadays this cartilage is most commonly asked, so we are focusing over the cartilage. First thing, we have to identify the cartilage. Remember, if there is any nucleus, agree sir, and you are observing the bluish appearance around it, but in between this cell membrane part, yes, cell membrane is also appearing bluish, and in between the nucleus and the cell membrane part there is the no any kind of the stain. So what you have to remember, sir, it is nucleus, this clear space is known as lacuna, and you can see cell membrane, generally it is also bluish in color. Why? I will tell you later with the biochemistry integration. And you will observe there is not such kind of single but multiple different number of the cells. Sometimes only two, sometimes only one, and sometimes there is presence of the five, six, multiple. Yes, what I want to tell you, multiple groups of cells. So definitely this is our chondrocyte. Getting the point? And chondrocytes, if you are able to identify the chondrocyte, then definitely it is cartilage. It is not any other structure. Okay, sir. We are looking the nucleus, we are looking the lacuna, we are looking the bluish color appearance, and we are looking the multiple number of the group of the cells. Then definitely it is our chondrocyte, and chondrocyte means cartilage. Why, sir? Why there is a bluish color appearance? Biochemistry integration. You will see in the cartilage, yes, sir, there is the appearance, there is the presence of the mucopolysaccharide, that is a chondroitin sulfate. You know, it is sulfate, just like the H2CO4. Sulfuric acid, this chondroitin sulfate is also acidic. So if it is acidic, definitely damn sure one school going children can say, if it is acidic then it will take the basic stain, and basic stain means blue color, and that's why the cartilages they will always usually having the bluish color in appearance. But in histology, remember, there is the dadagiri. If we will do the excessive dipping in the your opposite kind of the stain, then bluish can appear reddish also. Okay sir, fine, but bluish color means cartilage. Agree beta? Now if there is a cartilage, now you have to look outside. Look outside the cartilage. If in this our outside part, which is known as the matrix, ground substance, if there is the no fiber, I am telling you, no kachada, okay, no fiber, no kachada, but it is having the homogeneous bluish appearance, then you will say, sir, this homogeneous blue appearance is showing the hyaline cartilage. Remember, these hyaline cartilage, they are having the hyaluronic acid. Again, it is the acid, so it will have the bluish color appearance. Agree? No kachada, no fiber means definitely it is our hyaline cartilage. Now, if there is the single, double fiber, so it is our elastin fiber. And if elastin fiber, then you have to say, sir, it is elastic cartilage only. Agree, beta? Fine. Okay, sir. And when you will see the thick red bundle, not the single double, but you are getting the thick red wavy bundle, then it is our, yes, fibro cartilage, because it is nothing, it is our collagen. So I told you the way how you will identify. First task, you have to identify the chondrocyte. How you will identify? Sir, nucleus, then lacuna, then bluish color cell membrane, and then multiple group of the cells. Definitely it is the chondrocyte. Okay, now look outside the chondrocyte. If there is the no fiber, then you will say, sir, it is our hyaline cartilage. If single double fiber, then elastin cartilage. But if these fibers are thick red in appearance, then you will say, sir, these are our fibrocartilage, this is the collagen. Okay, let's start. Can you see this image? Observe here, sir. Whenever any slide is given, look at the option, give direction to your thoughts. Now observe, sir, nucleus is seen, nucleus is seen, nucleus is seen, blue color nucleus, and the clear white color space, sir, these are our lacuna. Agree? And also two cells, one cell, multiple cells. Yes, sir. Multiple number cells are also present. So these are exactly the chondrocyte. Agree, sir. Now look outside. This is the matrix, ground substance. In these ground substance, no fibers are seen. So this is our hyaluronic acid. Yes, remember, no fibers. So definitely this is our hyaline cartilage. Getting the point? Now, where this hyaline cartilage is found, you will say that there will be the slide in such kind of the way, and they will put this kind of the tissue is found where. Getting the point? This kind of the tissue is found where, this will be the question, and we will not be able to identify. So I'm putting one mnemonic for all of you. Yes, this is the car of the girlfriend. So remember, this is your mnemonic. Yes, high GF car. So you can remember, high means hyaline cartilage. Yes, GF means girlfriend, you can say. CAR you have to remember. So what is your mnemonic? Funny way, high GF car, high girlfriend ki car. This is the one way. Okay, so high is the hyaline cartilage. G for growth plate. I told you in our gross anatomy detail videos that bones are having the four different parts: epiphysis, diaphysis, and there is a metaphysis, and there is a growth plate. This growth plate, they are having the cartilage in nature. So these growth plate are having the hyaline cartilage nature. Also the fetal cartilage, even the ribs are articulated with the sternum with the help of the costal cartilage. They are hyaline in nature. Articular cartilage, whenever we are eating the chicken leg piece, so these are having the bluish color layer of the cartilage, that is also the hyaline cartilage. Integrate with the orthopedics. Yes, these our articular cartilage, they are getting degeneration, and there is the arthritis. Even the C-shaped cartilage of the trachea, respiratory tube cartilage, they are hyaline in nature. Now look here, next slide. Can you see? Again, sir, nucleus, sir, lacuna, sir, there is a different variable number of the cells, so definitely it is chondrocyte. Okay, now look outside. When you're looking the ground substance or matrix, you can see the single double fiber. So these are elastin fiber, so definitely it is our elastic cartilage. Now the problem is where these elastic cartilages are found. So remember one another mnemonic, that is the etc news channel. Okay, etc news, you can remember. So elastic cartilage, they are found in the 3e. Yes, there is the elasticity. Touch the ear pinna, sir, it is very soft, elasticity is there, elastic cartilage is there. Eustachian tube, epiglottis 3e, and then tip of the nose, you can touch the tip of the nose, sir, tip of the nose is very soft. Even the tip of the arytenoid cartilage, tritiate cartilage, you will see in your ENT. Even the corniculate and the cuneiform, these all are the elasticity, these all are having the elasticity. And for your clinical, remember these elastic fibers, they are having the zigzag snake like course also. So you will use the silver stain, and you will see such kind of the wavy appearance in your clinical pathology and different subjects. Okay, now look here, the fibrocartilage. You are observing, sir, there is the nucleus and very small layer of the white color, that is our lacuna. Yes, lacuna, white color layer, lacuna, single cell, double cell, triple cell, sir, but bluish color is not there. Remember, there is the dadagiri, excessive staining with the red color, that's a reddish appearance. Now look outside, can you see there is a thick red appearance. So this is nothing, this is our collagen, and if collagen is present, then definitely you will say, sir, these are our fibrocartilage. Getting the point? Now check here where these fibrocartilages are found. So your mnemonic is Fiat logo. So you can remember F for, sir, fibrocartilage. Yes, Fiat logo. So I for intervertebral disc. Collagen is very strong structure, it is giving the strength properly. So intervertebral disc, in between the two vertebra, there is the very thick layer of the fibrocartilage, that is our, yes, intervertebral disc. Okay, articular disc, the menisci in our knee joint, the temporomandibular joint disc, these all are bearing the too much pressure. So here is the need of the fibrocartilage. Tendon insertion site, there is the need of the too much strength, that's why our cartilage is fibrocartilage, and our glenoid labrum, acetabular labrum, too much pressure are here, that's why. So these are the point how you have to identify the three cartilage. It is very important. Why? Try to understand. Yes, cartilage, sir, there are the different cartilage related diseases, that's why. Catch this point, these cartilages are more, yes, these are approximately 28 types till now. We are studying the important one. Yes, what are the important one? Like the type 1 cartilage, type 2 cartilage, type 4 cartilage is important. Remember the type 1 cartilage, yes, just we had talked regarding the our collagen, that's one very most important topic in your histology we are going to observe. Don't leave this collagen topic and the epithelium at least. Okay, what I want to tell you, that whenever you are observing the thick red bundle, then definitely it is collagen. These collagens are synthesized by the fibroblast, which are having the longitudinal nucleus and spindle shaped cell appearance. Okay, sir. So these are fibroblast. One pathology integration, these fibroblasts are getting stimulation whenever there is the fibroblast growth factor activity. So whenever the fibroblasts they are getting activation, then there is a more and more collagen, and this excessive deposition of the collagen is known as fibrosis. Yes, in connective tissue formation, what is the connective tissue most abundant protein? That is our collagen. So you have to remember about the collagen, sir. There are the 28 types of the collagen, among which the type 1, type 2, and type 4, these are commonly asked. Okay, type 1, remember the type 1 collagen is found in the BAL. So BAL is your mnemonic. What is this BAL? B for, you can remember, the bone is having type 1 collagen. A for aponeurosis. What is the aponeurosis? I told you the flat tendon is known as aponeurosis. So you can say the tendon and aponeurosis, they are having the our, yes, type 1 collagen. And L for, you can remember, sir, ligament, they are also having the type 1 collagen. But never, it is very important, the cartilage is never having the type 1 collagen. The cartilages, they are having the type 2, and the bones, they are having the type 1 collagen. So cartilage related disorder, bone related disorder, you have to correlate in your clinical. And don't forget this type 4 collagen. This type 4 collagen is found in our basement membrane of lung, you can say pulmonary basement membrane, as well as basement membrane of kidney, nephron, you can say, means glomerular basement membrane. So if there is the mutation in this type 4 collagen, there is the our mutation abnormality in the basement membrane, pulmonary basement membrane, glomerular basement membrane, so the patient will present with the, no excuse, yes, answer is hemoptysis, and the patient will present with the, yes, bleeding from the urine. So you will say, sir, there is the hematuria. So this classical situation where you will see the type 4 collagen mutation, correct sir, there is the hemoptysis and the hematuria in the patient. This situation is known as good posture syndrome. Very important clinical situation. Don't forget this collagen topic, at least for this rapid revision session. This is sufficient. Now what I want to tell you, few recent questions I want to tell you. Tongue is important. I told you earlier, tongue, thyroid, tonsil, and temporomandibular joint clinical points you have to observe. These 40 are important. But one question in your NEET PG exam from the 2021 pattern, they had asked, see here, the tongue is having the taste bud and these are having the different kind of the appearance. So this question had been asked, histological appearance in the NEET PG 2021. You can observe this is the our thick red color in the our tongue. There is the friction, so stratified epithelium is found. Okay sir, now you can see the taste bud which is having the circular appearance and there is the presence of the trench. Yes, so this is our circumvallate taste bud, and at the basal part there is a location of the different taste bud. Okay, so at the trench part taste bud are there. Whenever we are eating, they are mixing with the saliva, they are reaching at this trench and they are stimulating the taste bud. So this is our circumvallate taste bud. Try to understand, it is having the circular appearance and on each side you will see the trench appearance. Okay sir, now in the similar way, NEET pattern 2020-22, they had asked about such kind of the image. Yes, you will see the eosinophilic appearance, but in between them there is the one less dense area, less stand area is seen. This is nothing, this is our islet of Langerhans, sufficient for the rapid revision session. We will see, yes, in our detailed session, but for the rapid revision this is sufficient. Now look here, in FMG 2021 they asked that fallopian tube is lined by which kind of the epithelium. So you can see, sir, here is the presence of the cilia which will show movement and it will carry the sperm ovum zygote, and here you can observe the cells are attached to the basement membrane and each cell they are having the one nucleus. So this is our simple, yes sir, columnar and with the ciliated epithelium. Getting the point? So it is found in the our uterine tube. You can integrate with your obs gynae also. And these all are the things. Remember what I want to tell you for the rapid revision. We are concising all the things. Yes, we cannot say all the 100% things will be come from here, but 80% topics will be come from here. And do this concise way, revisable content, and be confident for it. Concentrate properly, revise again and again. You can crack your exam with the proper focus, with the cool, calm, relaxed nature, and yes, you will get success. So remember these key points, revise again and again, integrate different subjects, and give proper grand test. Grand test is important. Never lose your calm nature, relaxed nature. Don't show hurry and the worry. So remember, life is better when you are laughing. I tried my best. Definitely you will do your best. Remember, मानव जब जोर लगाता है पत्थर पानी बन जाता है. All the best. God bless you all. Any kind of the problem, we all are with you. God bless you.